अविनाश भैया कैमरा ऑन करो। हेलो 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 चेक। हेलो 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 चेक। हेलो हेलो चेक। हेलो 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 चेक। हेलो हेलो
ये तो बस इसको चल रहा है। क्या हो रहा है? प्रॉब्लम आ रहा है। क्या हो रही है? अभी रुक जाओ वाले तो उसको वो चेक करेगा। हाँ जी, आप भी जाना है आप डाउनलोड कर लो। इस वेटिंग अरे क्या हो गया? इसी में भी क्लिक कर दो सर। पूरा गूगल क्रोम में साइन इन करना पड़ेगा। जीमेल नहीं है क्या इसमें डायरेक्ट? ना जाएंगे क्या नहीं रखेगा? क्या नहीं रखनी अभी? हो जाएगा। हो गए क्वेश्चन सब व्यू अफेक्ट करेगा ना। कोई जूम में कनेक्ट नहीं है ना।
Hello. 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 Check. Hello. 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 भाई बंद मत करना यार, बजर बजा रहे थे भाई, कैमरा तो बंद मत कर यार बस। हाँ?
इधर तेरी आवाज आ रही है।
मेरा जा रहा है लेकिन उधर से तो बोलो, और उनको कैमरा चालू करने बोलो ना, बंद क्यों कर देते? चालू है।
चालू है। देखिए कैमरा चालू है क्या?
अब हुआ।
हाँ हुआ।
कंटिन्यू। हेलो चेक। हेलो। 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 हेलो चेक। हेलो। हेलो चेक। हेलो। हेलो चेक। हेलो। हेलो चेक। हेलो। 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 हेलो चेक। हेलो। हेलो। हेलो चेक। हेलो। हेलो। हेलो चेक। हेलो। हेलो चेक। हेलो। 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 हेलो चेक। हेलो। हेलो।
आवाज नहीं आ रही।
आवाज नहीं आ रही? यूएसबी आटू तो है। इको नहीं हो रहा ना, ठीक है ना? ये माइक्रोफोन यही तो है क्या? हेलो चेक। हेलो। 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 नहीं आ रहा है
नहीं
आपका?
आपकी आवाज नहीं आ रही। हेलो। आ नहीं आया।
म्यूट तो नहीं रखे हो ना?
अब आया कि नहीं आया? क्या हुआ है?
अब आ रहा है।
ठीक है,
अब
आ
आ
गया
रहा है।
ना? ठीक है, ओके।
अब आ रहा है। ठीक है।
ठीक है,
हम्म।
बंद कर।
From AIMS Raipur, PGR Medicine.
Good morning, everyone. I'm Dr. Nilesh from AIMS Raipur, General Medicine Department.
हेलो। ओके।
Mobile.
चालू कर।
All of you, please switch off your mobiles.
We are going to have first round of passing questions. One round of passing questions. First round, 10 marks for each correct answer. If you don't get it correct, you don't have any negative marks. It passes on to the next question. So the sequence in which it will pass on to the next question is team A to team B, then team B to team C to team D, subsequently team D to team A. So it will go like that. So first question will start from team A, second question will start from team B, third question will start from team C, fourth question will start from team D. We'll have 3 such passing rounds. We'll have one buzzer round in which the team which presses the buzzer gets to answer. This question is not passed to other teams. 10 marks for correct answer, -5 for wrong answer. There is another round of audiovisual round in which the questions will not be passed. There are 10 marks for correct answer and no marks for wrong answer, no negative marks. And finally, there will be a rapid fire round. Please take note that each team will get 1 minute and there will be maximum of 8 questions to answer. You can pass the question and attempt it later if you have time left after all the 8 questions. Otherwise, if you get it wrong once, you won't get a chance to attempt it later. Each correct response will give you 5 marks, no negative marks in this. 1 minute, maximum 8 questions. Okay, for this, you'll get 15 seconds to respond.
Good evening, good morning, everyone. Myself, Dr. Asha, senior resident from General Medicine Department. So we'll be starting first round, that is passing round 1. So subsequently, we'll have passing round 1, 2, and 3, and later on we'll have audio-visual rounds and then buzzer round. At the end, if there is a tie, we'll have tiebreaker round also.
Thank you, Dr. Asha. I'm Dr. Amrita Ghosh from Department of Endocrinology, AIIMS Raipur. I'll start off with the first round, which is a passing round, and I'll start the first question with team A. So in diabetic ketoacidosis, bicarbonate, we are not displaying the questions. In diabetic ketoacidosis, bicarbonate is indicated if pH falls below. Correct answer, 10 marks. Next question, starting from team B. Glucagon stimulates. Glucagon stimulates gluconeogenesis by which organ? We can give it to you, 10 marks. Yes. Okay. Okay. So next question, starting with team C. Tell the relative contraindication, the diabetes complication, which is a relative contraindication for vigorous exercise. The diabetes complication, which is a relative contraindication for strenuous exercise. Wrong answer. I'll pass the question to the next team. I'll pass the question to the next team. Okay, okay. I think both team A can be given marks for this because they have got it correct. But okay, so can you tell any other complication? Team, I'm looking for the appropriate answer. Team B, would you like to attempt this question? Okay. Any of the teams? Okay. So proliferative diabetic retinopathy is the answer we were looking for. Can we give marks to team A for their answer? No. Okay. Team D. Okay. Team D, can you name the most common cross-linked advanced glycation end product? Yes. Okay. I'll allow the question to pass on to team A. Team B. Okay. You want to pass it? Team C. No, the correct answer is glucose pen. Okay, so you had already given a wrong answer. So, okay, so can we have the scores at the end of first round?
Team A is at 10 points, Team B is at 10 points, Team C and D are ready to open their accounts.
Okay, so we move on to the next round. We'll again start from Team A and then come back to Team B, Team C, and Team D. So, name the first study which investigated effects of management of multifactorial risk factor control in type 2 diabetes mellitus. I repeat the question. First study to investigate the effect of multifactorial risk control in type 2 diabetes mellitus. I'll allow the question to pass on to Team B. Okay. Team C? Not the correct answer. Team D? Pardon? Can you be a bit more clear? No, you got the 2 correct. It is 1002 trial. So you won't get any marks for that. Okay. So, can I be a bit more clear? Team D. No, you got the 2. Okay. So, next question we are starting from Team B. Tell the type of diabetes in which usually isolated mild fasting hyperglycemia is observed. Very good. That's the correct answer. You get 10 marks for it. Next question for Team C. Tell monogenic cause of diabetes which is associated with defects in insulin action. Correct answer, you get 10 marks for it. Next question for Team D. Tell the organism which is the responsible for most cases of emphysematous pyelonephritis. Correct answer, 10 marks. Okay, so second round is over. And I'll ask the scorer for the scores after round 2.
At the end of round 2, team B is leading with 20 points. All team A, C and D have 10 points each.
Okay, there are many rounds to come and all teams have equal chance, I believe, at this stage. So this is the third passing round. Again, we'll start with team A. Name the clinical trial which was investigating the effect of intensive glycemic control among those with ACVD risk factors, but which had to be prematurely discontinued because of increased mortality in the intensive control arm. Correct answer, you get 10 marks for it. Next question, starting with team B. You have to give the full name of the long-term follow-up of DCCT trial. Okay, we allow the question to pass on to team C. I'm asking the name of long-term follow-up trial of DCCT. Wrong answer. I'll pass on the question to team D. Pass. Okay. We come back to team A. Pass. So it is Epidemiology of Diabetes Interventions and Complications Study, EDIC. So this long-term follow-up is usually often called DCCT EDIC. Okay, the next question is for team C. Team C, are you ready? Okay. Name the drug which was evaluated in the leader trial. Wrong answer. Team D. Correct answer. 5 marks. Okay. So next question is for team D. The Diabetes Control and Complications Trial, DCCT, studied the effect of intensive glycemic control between two groups of type 1 diabetes mellitus, conventional and intensive control. So, can you tell the HbA1c levels which were targeted in the intensive control group? Huh? Okay, I'm looking for a better answer. I'll allow the question to pass. Wrong answer. Team B. You pass the question. Team D. Yeah, I think you are nearest to the correct answer, and actually it was 2 standard deviation was targeted from the usual control in the population. We give you 5 marks for that. मैम इसका आंसर मिल गया, इसको अनहाइड कर दो ना। ठीक है, तो 1 करना है इसको।
नहीं, this is the wrong answer. मुझे accept वाला है ना।
ओके
मुझे giving the option. इसको डिस्प्ले कर दें।
ये प्री रेबेलियन ये आंसर है।
नहीं, प्री का पहले तो नहीं था। इसको डिस्प्ले कर देते हैं।
ठीक है, so this score is ready with the scores at the end of round 3. Okay, we can display this. $6.7. Okay, you announce it. Okay. Okay, डिस्प्ले करेंगे मैम, पहले इसको एड्रेस करते हैं। क्वेश्चन डिस्प्ले का वो
हाँ कर दो।
अरे क्या डिस्प्ले करना चाहते हैं? स्कोर्स फ्रॉम दैट कंप्यूटर यू आर कनेक्टिंग टू द उसको, बट वी हैवंट अपडेटेड इट।
Am I audible? Team A is at 20 marks, B is also at 20 marks, and C and D are at 15.
Still we are having a neck to neck battle.
आपको दे रहे हैं 1 मिनट में iPad में।
So, this is the buzzer round.
Do you have your buzzer apps ready?
Yeah, you can take yours. बुके अभी डेलीगेट्स आने
हाँ
लगे,
है ना
बुके हैं?
रखे हुए।
अंतर आई नहीं। मैडम अंतर नहीं है ना?
अंतर है ना, और
अच्छा पैसे नहीं भागा। सुनो ना, डेलीगेट्स आएंगे तो वेलकम करना है, देना है क्या? एटलीस्ट वेलकम करना है।
वेलकम करके सबको सीधी बुलाऊंगी उसके बाद
नहीं अभी मान लो आ गया पिकनिक क्विज, तब क्या करेंगे?
सब जीके तो उस टाइम
हाँ उस टाइम देंगे, अभी जस्ट वेलकम। हाँ
नीचे टाइम आ रहा है ना।
ये ट्रांसमिट हो रहा है क्या? ये ऑनलाइन नहीं है ना? नहीं है ना, रहने दीजिए। हाँ किसको मैम?
ये वो बजट राउंड को डिस्प्ले कर सकते हैं।
हाँ
बजट
राउंड डिस्प्ले करेंगे मैडम।
चारों क्वेश्चन सेट है सर,
हाँ 4 क्वेश्चन सेट है।
इन ऑर्डर। ये
हाँ,
हेड
और
स्लाइड हो
फिर
गया है, ये कौन
ये-
सा हेड स्लाइड है? 80 to 1
इसको भी कर सकते हैं, बजट राउंड में 5 क्वेश्चन कर सकते हैं।
ज्यादा क्वेश्चन भी कर सकते हैं, आप कर सकते हैं अगर आपके पास।
नहीं उतना बेसिकली हमारे पास टाइम नहीं है।
ठीक है सर। क्वेश्चंस करना है।
ये और ये इसको ऊपर भेज रहा हूँ, बजट राउंड। इसको डिस्प्ले कर देंगे, ठीक है?
तो अभी कितने क्वेश्चन हो
5 हो गए।
गए? ट्रीटमेंट ऑफ द स्टेट की सेटिंग
वो मैंने दो, ठीक है ये 5 है, ठीक है। वी आर रेडी विद दिस। Okay, so
You have your buzzers
are the
ready?
buzzers ready? We can start off with the buzzer round. So testing हो गया ना? Testing, Asha, it has been tested. So okay, thank you.
When in doubt, we'll match the times and we'll see.
इसका डिस्प्ले करना है।
हाँ
डिस्प्ले
एक मिनट हाँ अभी
There are multiple choice questions. Whoever hits the buzzer first will get to answer. If you hit the buzzer and don't answer or answer it wrong, Team A, this is the last warning. Please don't press the buzzer unless you are ready with the answer.
Okay, so the next question.
So after buzzer round, team A is at 35, leading with 35, and team B is 30, team C 15, and team D is also 15.
Team B, your question. Identify this region. Correct answer, you get 10 marks for it. Next question, team C. Identify this animal and which drug was derived from this. That's enough time, I think. Time is over. I will pass it to the next question. I'm looking for complete correct answer. Correct answer. Okay. So I think we can give 5 marks to team C as well as 5 to team B. Yes, because the half of it was already answered. Okay, team D, your question, identify this complication of diabetes. Your time starts now. correct answer, you get 10 marks. So, can we have the scores at the end of the visual round?
Team A 35, Team B 40, C 20, and Team D is at 30 marks.
Till it is closed, next round of quiz is the most scoring one. So, I thought team to be attentive, see the questions. If you want to pass, you can pass it and come back to it later. So, you get 5 marks for each question. There, each question and each team can score up to 40 marks in this round. Your time starts now. Name the group of drugs associated with euglycemic ketoacidosis. Correct answer. 5 marks. Which class of antibiotics can cause hypoglycemia? Next question. Which is the predominant ketone in diabetic ketoacidosis? Correct. 5 marks. What proportion of patients with type 1 diabetes have anti-TP antibodies? Next, what is Whipple's triad? Number 2, correct. Okay, you get 5 marks. Malignant otitis externa in diabetic patients is caused by which organism? Correct answer. Next, at what entry level HbA1c does ADA recommend starting insulin directly? Correct. So you've got four correct answers and 20 marks. Your time starts now. Drug which has been shown have effect on lipids as well as reduce the progression of diabetic retinopathy. Yes. How many patients point areas you test with monofilament? Early sign of diabetic retinopathy. Which antidiabetic drug was most recently approved for treatment of heart failure? Okay. Name one DPP-4 inhibitor that doesn't require dose modification in kidney failure. Correct. Which basal insulin has longest duration of action? Basal insulin has longest duration of action. Correct. I think there were 3 correct answers. Three correct answers. They get 15 marks. Group D. Your time starts now. What does 3P mess include? Correct. Next question. Crohn's diabetes is caused by accumulation of. Correct. Name 2 non-sulfonylurea insulin secretagogues. Ketonemia is defined as ketone levels more than. Wrong answer. Next question. Amount of blood obtained from the fingertip puncture of blood glucose estimation. Fingertip puncture for CBG monitoring. How much blood is obtained? Wrong answer. Painful diabetic neuropathy is called acute if the duration is less than. Wrong answer. 1% rise in HbA1c translates into how much increase in mean glucose level? More time. So how many have you got correct? 2. So you get 10 marks in this round. While the scorer is busy with getting the final results, we'll just discuss the answers of this round. Can it be displayed? Can we have the display on? No, we are discussing the answer. The teams to questions to team A, normal ABI 0.9 to 1.29. Half-life of IV insulin is 5 to 10 minutes. Shortest site of neuropathic foot ulcer is head of metatarsal. This friend joint refers to tarsometatarsal joint. First line of defense, you got it correct. Fall in serum insulin. Which drug increases the risk of foot amputation? Canagliflozin. What are, okay, you could read up to here. Simulation lesions, these are not the sclerosis of BKD. What happens to serum potassium stores in decay? They are decreased. Questions? To the answers. Name the group of drugs you got it correct. Which class of antibiotics causes hypoplasmia? Fluoroquinolones. What is the predominant ketones decay? You got it correct, I think. Beta hydroxybutyrate. What proportion of patients with type 1 diabetes have anti-TPO positive? 4.5, that is 20%. What is Whipple's triad? You got it correct. Malignant otitis externa is caused by Pseudomonas. At which entry level HbA1c does? You got it correct. What is the most concentrated available insulin was the question which you couldn't reach? 500. So you reached 9 questions. It was good. Team C, your question. Drug which has been shown to reduce the progression of diabetic retinopathy. How many point areas? Usually we 6, you can see up to 10. Earliest sign of diabetic retinopathy, microaneurysm. Which anti-diabetic drug most recently approved? Empagliflozin. Name one DPP4 inhibitor that doesn't require dose modification in kidney disease. Basal insulin, you got it correct. Most common, you can reach this question. Most common dyslipidemia and uncontrolled diabetes is hypertriglyceridemia. SGLT2 inhibitor with highest possible risk of osteoporosis, canagliflozin. Team B, 3-point mess, you got it correct. Crohn's diabetes, you got it correct. Two non-controlled areas, you just couldn't remember it at that time, but you knew the answer, I believe. Lipoplinide and neticlinide. Ketonemia is defined as ketone levels more than 4. Amount of blood obtained during CBG, 10 microliters. Painful diabetic neuropathy, if it is less than, acute is less than 12 months. 1% rise in HbA1c translates to 5 mg per kg. These are the answers. Are we ready with the winners? Answer get so. It is head of method. Honorable Director, sir, Professor Nitin, sir, to the occasion. I welcome Agarwal, sir, HOD Department of Orthopedics, to the occasion.
A very good morning to our Honorable Director, Professor Nitin M. Nagarkar, sir. Good morning to Dr. Alok C. Agarwal sir and Dr. Pandit sir. We just completed the quiz final, sir. We had 3 passing rounds, followed by one buzzer round, one visual round, followed by a rapid fire round. So at the end of the quiz, the final scores are, the winners of the quiz are Team B with 60 points, Dr. Srihari and Dr. Abhishek from AIMS Raipur. The first runners up are Team A, Dr. Superior and Dr. Shubhabrata Viswal, again from AIMS Raipur.
On the behalf of the Department of Entrepreneur
times associated with COVID pandemic. But even before that, for many years, we have been dealing with worldwide pandemic, a chronic disease which is responsible for death, health, consequences.
म्यूट करो।
have him as the chief guest. So I request you, sir, to kindly say a few words for us. Sir, next I would like to take the opportunity to request our Dr. Amitava Ghosh, sir, present a memento to our honorable director, sir. request Dr. Vinay Pandit sir to present a memento to Dr. Alok Agarwal sir. Now I request Dr. Amitava Ghosh sir to present a memento to Dr. Vinay Pandit sir. May I request Dr. Rohini madam to kindly present a memento to Dr. Amitava Ghosh sir. Now may I invite Dr. Rohini madam to give the vote of thanks.
Good morning to all. On the behalf of Endomed, I, Dr. Rohini, take this as an opportunity to propose the vote of thanks for this inaugural ceremony. I would like to start by thanking our Honorable Professor Dr. Nitin Nagarkar sir for presiding over this inaugural function. Thank you, sir, for taking out your time from busy schedule and addressing us. I thank Professor Alok Agarwal sir for gracing us with his presence and for being the most supportive guide. Thank you. I'd also like to thank Professor Vinay Pandit sir for his precious presence and continuous guidance and support. I thank Dr. Amrita Ghosh sir for his vision and enthusiasm in organizing this CME. I especially thank Dr. Antara Sen for conducting this function smoothly and smartly and finishing it well within time. Thank you, Antara. I request everyone to please proceed for some tea and breakfast. We can resume at 10:15 for our academic session.
Hello. 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 Check. Hello. Hello.
Hello. Hello.
Yes, ma'am. Hello. 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 Online है ना, online भी ज़्यादा था। Hello. 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 Check. Hello. 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 Check. Hello. 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 Check. Hello. 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 Check. Hello. Check. Hello. 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 Check. Hello. 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 Check. Hello. Check.
Hello.
Hello. Hello. Check. Hello. 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 Check.
Hello. There is some problem, I think.
Hello.
Support hello hello ହଉଛି ବୋଧେ ନାଇଁ?
ଶୁଣି ପାରୁଛନ୍ତି?
ହଁ ଶୁଣୁଛି, ତମେ?
Okay, okay.
ହଁ କଣ ଖବର?
Relay होतो ते ଟିକେ wait କର।
ହୁଁ? ବର୍ଷା ହଉଛି? ବର୍ଷା ଚାଲିଛି କି? ଅନମ୍ୟୁଟ କର।
सर आवाज आ रही है?
Hello.
Hello. Sir, good morning, sir.
Yeah, I already joined.
Okay, thank you, sir.
Just Nayak also joined.
Okay, thank you, sir. Sir, questions, you have gone through the questions.
Yeah,
sir?
yeah.
Sir, time, there's some time, so.
Yeah, 1 minute we will finish
sir,
up that. Not an issue at all.
Okay, sir. Okay, sir. Welcome, sir.
Okay, thank you. Thank you so much.
Okay, thank you, sir.
पढ़ो
Hello.
Sir, am I audible, sir?
Hello.
Can you hear me, sir?
You?
Hello.
Unmute, no, sir. Sir, can you hear me?
Yeah, can hear you.
Behra, sir?
I am
Yes,
Dr.
yes.
Naik here.
Yeah, Dr. Kishore from AIMS Bhubaneswar. I can hear you also. Can you hear me?
Yes, sir. You're clear.
Yeah, okay.
So
Okay.
just give us 5 to 10 minutes time.
Yeah,
to
no issue at all.
Start shortly.
No problem.
Thank you everyone for returning on time. Now let's start our academic program. I request all the attendees to please post their questions on the online portal. We will try to answer the questions at the end of the session. So the first session of the day is panel discussion on access to diabetes care and the role of institutes of national importance in India. To chair the session, I would like to call upon our first chairperson, Professor Alok Chandra Agarwal, sir. He is the head of the Department of Orthopedics, AIMS Raipur. He has won awards at various regional and national conference and has published numerous research papers in various index journals. So I request, sir. Our second chairperson is Professor Anil Kumar Goyal, sir. He is the head of the Department of Pediatrics and Pediatrics Emergency. He is the recipient of numerous awards and honors and has published more than 40 research papers in various indexed articles. He has special interest in infectious emergencies and also vaso-occlusive crisis in sickle cell disease. So, sir. Now I would like to introduce our panelists. Our first panelist is Honorable Professor Nitin M. Nagarkar, sir. Now I would like to hand over the session to our respected chairperson, sir.
Good morning. Dear friends, I feel privileged in introducing Professor Dr. Nitin M. Nagarkar, sir. He is our director as well as Chief Executive Officer. MS from PGI Chandigarh, DNB, MNAMS, and FIMSA. He is from the Department of ENT, Head and Neck Surgery at AIMS Raipur. He has more than 25 years of experience in the field of ENT, Head and Neck Surgery. He has got 5 orations and many major awards on his credit. He has a special interest in oncosurgery and laser surgery, and he has more than 80 articles indexed in international and national journals. He is also an examiner in various universities for UG, PG, DNB, and PhD examiners. I call Dr. Nagarkar sir to please take his seat. The second panelist for this session is Professor Dr. Vinay R. Pandit. He is MD Medicine, FACEE, and PG Diploma in MLE. He is working as a professor and head of general medicine at AIMS Raipur. He has more than 20 years of experience in the field of general medicine with a special interest in medical emergency, NCD, and infectious diseases. He has more than 55 national and international publications, and he has co-authored 5 chapters in books. He has been given the HPSN Simulation Conference 2017 Honor and Award. He has attended Resuscitation Conference 2016, Association of Physicians of India in 2007, and RSSDI in 2006. May I request Dr. Pandit to come on the dais. May I call Dr. Abhiruchi Galhotra on the dais. Dr. Abhiruchi Galhotra is a professor from Community and Family Medicine at AIIMS Raipur. He is also the course coordinator of MPH School of Public Health. He has a total clinical and academic experience of 19 years, the qualification being MD Community Medicine. He has 50 publications, including 5 chapters in books, 264 citations, 13 index publications, and an RG score of 17.96. Our important contributions are formulation of policy to make Chhattisgarh state smoke-free under National Tobacco Control Program and implementation of this policy in Jashpur and Sarguja districts as an external expert for the state Chhattisgarh. Along with Department of Nephrology, she has prepared the proposal for establishing peritoneal dialysis services under National Dialysis Control Program in Chhattisgarh, which is in the implementation phase. He is a member of the steering committee to address the CKD problems in the state. He has a key interest in NCDs, especially CKD and hearing impairment, and she is presently working on streamlining the mortality data, including COVID, of the institute, WASH in healthcare females, nutrition of children, and adolescent girls in the urban slums of Chhattisgarh. The next panelist is joining us online. He is Dr. D.B. Nayak. He is an additional professor from Zipmer, Pondicherry. He has a total clinical and academic experience of 11 years and has 50 publications as indexed publications. I welcome Dr. D.B. Nayak.
Thank you, sir. Thank you.
We also have with us Dr. Kishore Kumar Bahera, MD General Medicine, DNB Endocrinology, PACE, Scope Certified. He is an Associate Professor of Endocrinology at AIIMS Bhubaneswar. He has 17 publications in the national and international journals. Presently, he is involved in one of the clinical trials. He has the Strategic Center for Obesity Professional Education Award by the World Obesity Federation this year. He got the best oral presentation in ITSCON last year in Visakhapatnam. He was awarded best poster in SECON in 2019 in Nagpur and the 10th A.V. Gandhi Award for Excellence in Endocrinology in the year 2012. His areas of research interest are obesity and weight management, young onset diabetes and its macrovascular complications, thyroid disorders, pituitary disorders, and adrenal disorders. Currently, he is also the treasurer in SECON since 2018. And he is a membership of Endocrine Society of India, the Endocrine Society of America, the European Society of Endocrinology, and his RSSDI membership number is 7021. Dear Dr. Kishore, I welcome you to this conference as a panelist. Thank you. The moderator for this session is, as you all know, the organizer for this conference, Dr. Amrita Ghosh. He is working as an assistant professor and faculty in charge in the Department of Endocrinology at AIMS Raipur. He has a total clinical and academic experience of 17 years. He is MD Medicine and DM Endocrinology. He has 12 research publications in international national journals. He has paper presentations in a number of state national conferences, including award-winning presentations at AESCon 2015. He is a reviewer for a number of international journals. He is the author of a MCQs in Endocrinology for DM entrance examination book, which is a bestseller. He is an associate editor of Manual of Lipidology, a section editor for RSSDI Yearbook Diabetes 2017, and also a section author for the same book for the year 2020. So I'll invite Dr. Amrit to come on the dais and moderate this panel discussion on World Diabetes Day theme. Thank you.
Thank you, Agarwal sir, for the kind introduction. I welcome all the panelists who have joined us here and online. The topic of our discussion for panel discussion is access to diabetes care. That is the World Diabetes Day theme. And our question is the role of institutes of national importance in India. The agendas under which this topic will be discussed are the disease burden, diabetes-related national health programs, the vision of institutes of national importance in India. Then finally, subsequently, I'll take an opinion of panel for improvements in existing national health programs, the other strategies which can be taken to improve diabetes care, availability, pricing, affordability of essential diabetes medicines, and we'll try to learn certain lessons from JIPMER and a few questions on development of health workforce. With permission from chairpersons, I'd like to start my panel discussion. So my first question to Dr. Dukhabandhu Naik is, can you, sir, please highlight the burden of diabetes mellitus in India and economic costs to the nations resulting from it?
Good morning, everyone. At the outset, I will thank Dr. Amita for designing such a wonderful program on World Diabetic Day. Look, as we know that India is even considered as the diabetic capital, because if you look at the data for diabetes living in India as compared to various other parts of the developing countries, very, very high. And if you look, the data from IDF Atlas show that about around 73 million Indians are diabetics. And that if you look at the ratio of diabetes in India with regards to urban and rural, around urban set of around 11 to 12% of the people are diabetic, and in the rural about 7 to 8% people are diabetics. So definitely a huge number of people in India are diabetic. You can say it is a diabetic is more of a pandemic kind of condition in India. Moreover, if you look at the recent literature, most of the diabetics are now affecting a younger generation of the people. So definitely over a year, the number of diabetic may goes up very, very high as compared to previous decade. With regard to economic cost, when you're looking at the economic cost, it's not only blood glucose monitoring or medications, because diabetes related complication can contribute significant to the economy, not economy, particularly with regard to the treatment, and even with regard to the affecting the life of the family, affecting the quality of life. So if you look at the IDF data, the total expenditure of for diabetic expenditure is 966 billion US dollar overall expenditure. For India, it is 486 million US dollar. So even if you look at, if because most of the younger generation, as they are affecting with the diabetes, because they are the prime breadwinner of the family, and particularly if there is any early death happen in this family, it definitely impact not necessarily the individual, it also affect the impact of the family with regards to the income and income. So even the data on daily associated life year, disability associated life year for 1 lakh population, it was shown that it has been increased significantly to 792 per lakhs as compared to 440 in 1990. So definitely it will have a significant economic burden to the nation time to come.
Thank you, sir. Next question, I'd go to Dr. Kishore Kumar Behra. Sir, are you able to hear me? Am I audible, sir?
Yeah.
Sir, what is the prevalence of undiagnosed diabetes in India?
Thank you, Dr. Amita, for organizing such a wonderful meeting. And may I audible to you?
Yes, sir. Yes, sir.
Okay. So basically what you have asked, and I want to put forward the answer based on this recent data in 2015 and 16. It is based on nationally representative survey by National Family Health Survey 4 and Demographic Health Survey, which is conducted in 29 states and 7 union territories in India. And they found that the 42% of the individual in India with diabetes are unaware of their diabetes status. That means they are undiagnosed. And second is, there is a poor detection of diabetes in India. Nearly 45% of the undiagnosed diabetes individual have access to healthcare, but they are not going to check and find out whether they have a diabetes or not. And you know, this recent in 2015-16, the data in IDF, so the prevalence of overall prevalence of the diabetes in India varies around 10 to 11%. And I think this is a underestimate, and we expect probably it is more than that. And third one, the reason of the country is significant factor for the undiagnosed diabetes, more so than the urban versus rural dwelling population, of disproportionately affecting more of men and younger individual.
Okay. Thank you, sir. Next, I've come to Professor Nitin M. Nangarkar, sir. Sir, you have vast experience for many years, and I'd like to ask your experience regarding surgical patients. How often do you find the presence of diabetes among patients who presents to the tertiary care hospital for surgical reason? And how many patients among these have undiagnosed diabetes at the time of presentation? Thank you very much, Dr. Amrita, and a very pertinent question again in consonance with the discussion today. As you rightly mentioned, that diabetes is very common in our Indian population, especially, and in surgical setup, if we see many a time these patients, like Dr. Kishore has also mentioned, that when an undiagnosed patient is not aware. So many times these patients come to us for their surgical issue, whatever related to their specialty. And it is during the workup of those patients that the diabetes gets detected. This happens fairly commonly in the middle-aged population. As we can see, the prevalence is 10% plus. Many a times these have other comorbidities also, so and so forth. So if the diabetes, they have hypertension, many a times raised urea creatinine, etc. They get detected when the patient gets worked up for the surgical issue when they present to us. The other problem is they come with complications related to diabetes straight away. And for example, abscesses in different parts of the body. We talk about the ENT head neck surgery, deep neck abscesses are very common, or conditions like malignant otitis externa. We had mucormycosis post-COVID this time. So many a time these patients have diabetes, they have undetected diabetes, they have uncontrolled diabetes, and they present to us with the problem related to the diabetes. And on the workup of that particular condition, we are aware that yes, it should not have happened. So why is it? And then blood sugar levels which are raised, or if the patient has been under control, but left the treatment in between, and many times that also happens. So I think we get a variety of patients, but definitely I think awareness will help, and proper early detection or regular, if we can do screening, then it's fine. Otherwise, whenever the patient will be presenting for surgery and during workup, we will continue to pick up these kinds of cases, I'm sure. And it definitely affects the outcome of the surgery also if the patient is not well controlled. Thank you.
Thank you, sir. Next, I'd like to ask Professor Abhiruchi Galatra, ma'am. Ma'am, what is the data from Chhattisgarh regarding diabetes disease burden and its risk factors?
Thank you, Dr. Ghosh. Data regarding Chhattisgarh is very scanty, and whatever data we have, I'd like to share with you the prevalence of diabetes in Chhattisgarh in the year 1990 was somewhere around 4.5 to 5.9%. And in 2016, 6 to 7.4%. The deaths death rates in Chhattisgarh was 22 per lakh population. And the DALIs, the disability adjusted, that's how we measure the burden of disease. The DALIs due to diabetes mellitus in Chhattisgarh in particular is to the tune of 1,075 per lakh population in our state. And of course, we have some other data related to with years of life loss due to premature mortality. And this was to the tune of 1 to 3% in the year 2016. And in addition to it, recently in the year 2017-18, National NCD Monitoring Survey was conducted in India. And Chhattisgarh was a part of that important survey. And the report for which was released very recently in the year 21 January. And the overall prevalence estimates to be to the tune of 9.3%. The detailed workup for the state of Chhattisgarh is yet awaited. This is what I can tell you, right?
Okay. Thank you. So that's quite a high prevalence, ma'am has pointed out, and definitely as all our panelists have shared, there is very high prevalence of diabetes and undiagnosed diabetes. So, sir, I'd like to ask Professor Pandit, sir, regarding your previous experience of past 2 decades, what has been your experience regarding the trend of incidence of diabetes over the years? Has there been any change? What you have observed?
Thank you, Dr. Ghosh. So if you talk about the trends in India, so maybe I will talk about when we were born. So maybe era of 1970. So that time, the prevalence from the studies reported that it is from 2.3 to 3.3. So in the 1970s and 5. But gradually over the 3 decades, it kept on increasing at a moderate pace. But in the last 2 decades, there has been a constant rise in the diabetic cases. So if you look at the one particular thing, what has been observed by the epidemiological data is the rural and urban inheritance. So if you look at the year around 2000, the urban diabetes prevalence was 11%, and the rural prevalence was 5%. But if you look at around 16 to 18 data, the rural prevalence in few states have increased from 5% to almost up to 18-20%. So that means there has been a threefold increase in the prevalence of diabetes in the rural population. But on the other hand, urban population, it has increased nearly 1.5 to 2 times. So what is alarming is the more about the rural populations which are getting affected. One particular study was done in Chennai is they looked at the Chennai city, they looked at the Kanchipuram, which is 80 kilometers from there, and they looked at the Pandupur around 200 kilometers from there. The study revealed that the phenomenally rise is basically in the suburban regions, in the town and peri-urban villages. There's a 10-year data published by Ramsar Record. So this is what is alarming, related to the urbanization of the lifestyle in the rural population. And it continues to other thing, as rightly said by the other people, there are so many undiagnosed diabetes, and also incidence of pre-diabetes is increasing almost up to 3% of the population, the very urban population.
So, sir, a significant point that significant rise in prevalence, particularly in rural areas, where the access to care may be particularly limited. So here our importance of our national programs come in, which are targeted to reach to the farmost areas of the country. So I'd like to come back to Abhiruchi madam. Kindly enlighten us regarding the diabetes related national program in India, the initiatives, the impact it has had over the last 10 years or more it has been in place, and what are the implementation challenges that is commonly being faced?
First of all, the program for diabetes, which we, for whole of the NCDs, we have the NPCDCS program, the National Program for Prevention and Control of Cardiovascular Disease, Diabetes, Cancer, and stroke. The initiatives under this program, it was started in 2010. And the main initiatives it has brought into the population-based screening has been introduced with the help of this program. And also the concept of opportunistic screening in various healthcare level facilities. And just the main initiatives, the recent ones, the introduction of CKD and COPD in this program, integration of Ayush with the NCDs, and very important changes, the inclusion of RNTCP. You see diabetes and tuberculosis, and under this program, the now it is some sort of bi-directional screening is being advocated. And the third question you asked about the impact. I would like to quote some data here. Under this program, ever since its inception, we at present have 524 district NCD cells and 565 district NCD clinics. And we have approximately 170 district cardiac care units functional as of now. This is India's data, and 164 district daycare centers, and to the tune of 3,000 CHC NCD clinics have been established, and supply of the essential drug list as needed for NCD management at all these centers. And the impact of this, I'll give an example, especially for the state of Chhattisgarh, let's say. The catastrophic health expenditure in out-of-pocket expenditure for NCDs in total for the state of Chhattisgarh was to the tune of 79 point something, around 80% in 2014. Now this in the year 2017 to 18 has reduced to around 63.83%. And the implementation challenges, of course, There is implementation of lack of infrastructure facilities. This is the infrastructure as of now which we have, and considering the population of India, we have the infrastructural challenges. We have the trained healthcare providers challenges. Whatever manpower we have is mostly on the contractual basis. And if you look into the programmatic aspects, this is functioning under the NCD state NCD cell. The funds are released under the National Health Mission. So financial issues are create lot of hurdles. Then of course, data management, the health information system integration with that is another challenge. Then there is poor focus as a primary health worker or as a community medicine person. My emphasis remains on health promotional activities. There is a poor focus under this, though it has been envisaged, but it is, I feel there is, and lack of multi-sectoral participation. These are some of the challenges which I can. Of course, then surveillance, monitoring, and evaluation of this program. That's another hurdle.
Okay, ma'am. So I'd ask you one more question regarding this, that would you suggest any improvements in the present structure of this program?
See, at policy level, what I personally feel is whenever we design a policy, the social determinants of health, they have to be taken into account. And if given an opportunity, yes, I would like to work on that and include more focus on the behavioral aspects for it.
Thank you, ma'am. I'd like to ask Nagarkar sir, what are the roles of institutes of national importance in the implementation of these national programs? How can we participate?
Thank you very much again. A very relevant question, because you see the institutions of national importance, whether we are talking of fields, so many others, they have a leadership role to play. They definitely have a very important role along with ICMR to help in the policy matters for the Minister of Health and Family Welfare Government of India. Like Dr. Abhijit, you mentioned that there has to be multi-sectoral participation, and all these institutions of national importance have a major role for teaching, training programs, for patient care, for research focused in our region. So I think all these institutions can do that, and the ministry has repeatedly had various expert level committees, and I think many inputs have come from these public health experts or specialists in that particular field. Dr. Pandit mentioned that it's not just in the urban, but even the rural population that has been found that diabetes, the prevalence has been alarmingly increasing. And because of that, these health and wellness centers came up, integration of Ayush, because possibly the availability of Ayush in the peripheral centers was there. So I think lots of these features have been incorporated, but meanwhile, focused research also should be taken up by the INANs. And I'm sure that, again, as I mentioned before also, we have many experts, we have many young researchers, we have that background to take up this kind of research. And I'm sure that treatment which is focused to our region, to our part of the world, which can actually become an example for countries like Asia and Africa, I think we should be doing that. A lot of role for us to play.
Thank you, sir. I'd move on to Dr. Dukhavandhu Naik, sir. Sir, I have one query that NPCDCS is an actually single program which deals with multiple non-communicable diseases like cancer, diabetes, cardiovascular disorders, stroke, and now there is also a plan to integrate COPD and chronic kidney disease into this program. So are we putting too many things in our plate? So can we give enough focus to each of these disorders if we try to manage them together? Given the global burden of diabetes and its complications, is it time that we think about a separate program for diabetes in order to achieve greater impact? Like so many communicable diseases each have their own program. So your opinion, sir?
Yeah, as you told that many of the communicable disease like tuberculosis, AIDS has their own program. But however, in India, this NCT-related diseases are many of the diseases are been taken care by the single programs. Maybe because of many of the diseases are interrelated. But however, as looking at the burden of diabetes increasing in India, it's essential to have a separate means new initiative to start a diabetic related program. Not necessarily diabetes also has a separate even obesity and other things also can be combined, and should have a new program which can facilitate better treatment or better approach to better reach to the people those are living in the rural area. As madam has already discussed, because there are so many things are there even in the even in the NCD, because you need infrastructure, you need manpower. Unless otherwise, these are been means economically we are means economic is not been supported. Very difficult to have a separate kind of program, but still we I think maybe over time we should have a different kind of program for the diabetes as such to definitely to improve the goal, and we should have a separate goal for our goal for this diabetics management and outcome also.
Thank you, sir. So I'd like to open this question to other panelists as well. So if anybody has any comment about this.
Yes, Dr. Amitav, I just want to have some comments. Like, as we know, in India is concerned, diabetes is coming, it is the 9th position of mortality. And Dr. Nayak has rightly said, among them, the diabetes, which is the forerunner of causing multiple non-communicable disease, be it a cardiovascular disease, it can cause stroke, it can cause COPD and chronic kidney disease. You can see now the most common causes of, now if we consider that NFLD, the most common causes is because of diabetes and insulin resistance. And insulin resistance can cause multiple non-communicable disease. So it is the right time. And you will be surprising, we have our own data, which is unpublished. Probably now around 40 to 30% of the diabetes, what we see in AIMS endocrinology Bhubaneswar department, around, it comes around 20 to 35. That's a very young onset. What has been encountered in our developed country like US and Europe, it is above 40, 45. So if you'll just analyze it, if somebody having a diabetes at age of 20 and not been 50% of that is not been underdiagnosed or not diagnosed at all, probably within 10 years, definitely they can have a microvascular complication, which can increase the morbidity, and among another 50% of those subgroup of patients, they can develop a macrovascular complication, which is the cause for the mortality. So it is a high time and we should not delay that. And the policymakers, and we have to convince them, probably it is a high time, and we should have a separate program how to prevent the diabetes in young, especially so that it can be preventable. It is a preventable disease, and there is a multiple studies in a primary healthcare center, the direct study which has been done in 2019 in UK. They found if a diet modification and exercise about 150 minutes per week can prevent or can postpone the diabetes. So I think I agree with Dr. Dukhomendu and panelists that probably it is a high time to have a separate diabetic prevention program.
Even there is a concept of reversal of type 2 diabetes if these measures are being taken care, and those are diagnosed within less than 10 years. The likelihood of reversal of diabetes is very likely within period of less than 10 years of diagnosis. So that is also to be kept in mind if early intervene this kind of patient, particularly type 2. Obviously type 1 and other diabetes are not reversible, but type 2 it is a kind of, it can be reversible.
And I think the type 2 consists about 90%. So leave out about 10%, even less than that of the type 1 diabetes. So we are the modifiable diabetes of short duration of about 1 to 3 years, which has been shown in the direct study, and it is preventable. It is 100% preventable.
May I? See, a separate program for diabetes, we need to understand first the epidemiology of diabetes or any non-communicable diseases. In majority, we always call them as lifestyle related diseases. You cannot address, when you are at population level, you cannot address a program or a problem on a single based on a single factor. Logistically, I don't think it is feasible. And my take is that it is always an integration in your clinical practice. Majority of the patients which report to you have hypertension along with diabetes. You cannot talk about diabetes as a separate entity. Of course, I agree with sir's remark that we can prevent it. See, if we talk about the age of detection of diabetes these days, it's in the early 30s, 40s. And if a healthy lifestyle is maintained, it can be the complications can be stretched up. Prevention of these complications can be done till maybe another 15-20 years, but quality of life is compromised. So why not talk about health promotion at the basic level, or the primary prevention, what we say. And primary prevention, irrespective of it being diabetes, hypertension, or any other disease, it is inherent in the social what we call the social determinants of health, the behavioral factors. So my take is very different, that a separate program for diabetes, I don't think.
I can just understand both the issues very well. Burden of the disease, we do understand that diabetes per se, other infections, whether it's or malaria, we can have separate programs. Yes. But I think very rightly, because the numbers are so much, so that popular. But many of these lifestyle disorders are interrelated. I think even I agree that diabetes is a very central role in most of these diseases, whether it's cardiovascular, stroke. And again, if we see at the level of the periphery, where the implementation of these programs is actually important, there integrating this would help out in every manner. So to take care of diabetes, you're obviously taking care of cardiovascular stroke at the same time. Yes, these diseases might be specific, but there are many things that are common. And to understand the disease and to study the determinants of the disease, or come up with research on the one hand is truly very important. But at the same time, when it comes to implementation, it becomes very difficult to split these programs to the non-profit. There are many lifestyle. But I think focused research on specific diseases can be.
I'd like to move on to the next question about other strategies to improve diabetes care. Professor Pandit sir, can you please highlight the other strategies which can be taken to improve access to diabetes care?
As the pertinent point is as an INI, so what is our role in improving the access to the diabetic care? So as sir has pointed out, diabetes, insulin resistance are all part of same umbrella. Now the ministry has included an AFN as one of the program at this point. So since the nature of the disease is they are all interlinked. So, and even in an AFN and other non-communicable disease, as an INI, so we have a larger role to play. So if you can share our experience with the NCD from the Department of Medicine from AIIMS Raipur. So actually we were involved in the drafting the standards of care for protocol for diabetes for the state of Chhattisgarh. So we have been interacting with the NCT cell coordinators, and we have meetings with the district medical officers and other officers. And sitting it all together, we have devised now the standard of care protocol, which is there for the state of Chhattisgarh. At least you can say that in the peripheral, we have displayed it, and these are the things that we have to do. So in that way, providing an education and sensitizing the workers or healthcare workers who are working at the peripheral, So that's what is most important, I believe. As sir has pointed out, many programs may come, but how much it goes to the grassroots and how much it will be implemented and what is its benefit. So these are the one which we have to look into that. As an INIs, yes, capacity building, training, sensitizing all the healthcare workers. So being a role model, and as sir has already pointed out, we can become a center of clinical excellence in some of the areas of diabetes, like monogenic diabetes or gestational diabetes, or a challenging cases. So we can become the center of excellence and guide the state people. And also we have a role in the implementation of the program, and also in the training the undergraduates and postgraduates and health promotional activities. These are things which are very important. In that way, INIs can always become a source of knowledge center and a clinical excellence.
Ask Director sir, what are the, so you are actively involved in management of cancer, and there is a cancer registry. So what is the importance, what are the benefits of arising out of presence of registries, nationwide registries of various methods?
I think registries play a very important role, because after all, I think it's a game of numbers. You need to highlight how many patients are coming, what are your mortality and morbidity figures, and they would be reliable figures. So if you have a properly trained force of medical professionals supported by epidemiologists, you can have registries, for example, like you mentioned about the cancer registry. They have done a wonderful job. They tell us about the burden of the disease, which parts of the country are having greater. There are even rural areas which have more cancers. And I'm sure this thing would also be highlighted for diabetes also. There would be certain populations which are more prone because of their fooding habits or their genetic predisposition. So these registries are important. It will definitely help us to come out with credible data at the international level, and also focus on those areas where the disease burden is especially higher.
Thanks, sir. So, sir has talked about registry. I'd like to ask you, Dr. Kishore Behra, regarding the role of registry in diabetes. Kindly unmute yourself.
Yeah, as Sir has rightly pointed out, I think the registry, which is helpful for long-term prospective patient registries, are critical epidemiological tool, and we can have a knowledge based for the chronic diseases, and it is both can be done in both population and hospital-based registry. I think the hospital-based registries are there in Pondicherry, and also I've gone through, I think in a Goa Medical College, they have also having a registry, and the registries are also able to track the trend in the incidence of disease in a defined geographical area, which is very important. Second thing is the policymakers from the registry that can find out and to set a public health priorities, and also help them in evidence-based decision making. And in the developed country, and the registries play a pivotal role in the health system to assess the quality of care delivered to the chronic condition like diabetes, which requires a continuous long-term care. And one of the central component of is the chronic care model is the use of registry to improve patients' outcome, and this has been substantiated by the recent research studies. And also it is a big registry, you will be aware of that, that's called YDR, diabetes in young. This is surrounded by the ICMR, and I think it is governed by 5-6 institute in India, and by Dr. Tandon Shah. And it is about the type of young diabetes, including their geographical variation. And also it's very, very important. And from that, we can have a track the patient, increase the follow-up rate, identify the high-risk patient, and also facilitate the use of evidence-based guideline in the treatment. So registry is quite important so far is concerned. So to formulate the treatment, to find out the prevalence incidence of the diseases.
Thank you, sir. So another important aspect is the availability and pricing of the drugs which is particularly important in our country. So I'd like to ask Vinay Pandit sir regarding the current status of availability and pricing and affordability of the drugs in India, including insulin.
Okay, you asked me a difficult question. Yes, first we talk about the availability of oral diabetic agents. So if you look at the Indian pharmaceutical industry, it's very vibrant. You mean to say we produce the drugs for almost 60% of the drugs which are globally available. So we are the leaders in the pharmacy industry as such. But if you look at our own country about the availability of oral anti-diabetic drugs, so there has been a huge divide between the public domain and the private domain. So in the private domain, so oral anti-diabetic drugs, so essential drugs are all of them are available. Even the newer drugs like gliptins and SGLT2 and other degludec and insulin, newer insulins are available in the private, but we know that they are not affordable and they are very expensive. So as far as the essential medicines, what we talk about the sulfonylurea, glimepiride, and the metformin. So the availability in the government hospitals have shown that it varies from around 50 to 60%, depending upon the what kind of outlets they have. So it has fairly been the, what I would say is availability is a big issue in the Indian population, especially in the rural India. And in the private domain, yes, so the problem is the money and then, affordability. And if you look at the WHO, what is recommended is, so it has recommended a target of minimum of 80% availability, both in the public and the private sector. So nearly 1/3 of the global population has inaccessibility to oral antibiotic drug, even to what I'm saying is the baseline drugs like essential medications. So what did we experience in state of Chhattisgarh is when we designed about the protocol, we came to know that, so they're in the periphery, they've got only one drug which is available, glimepiride, metformin is available plus minus. And now what we have implemented is we have pushed through the ministry and pushed through the NCD cells to make available. So one of the drugs like teneligliptin and things like that, of course, that has been made available. The funding is there for a non-communicable disease, but there is a will of implementation and taking it to the periphery is the biggest problem as far as the availability of drugs is concerned. That is one point. And as far as the affordability and the pricing, all of you know that how the Indian market is. So I'll just give you, there has been a large amount of pricing variation of the drug. So I will give one example. So glimepiride 1 mg is the basic drug which we use as a first line for diabetes. So if you quote that 1 milligram 10 tablets, so the minimum pricing of a company XYZ is 14 rupees. But the maximum price, the other brand sells at a 150 rupees. So you can see that from 15 rupees, the one company is selling, other company is selling at the 150 rupees. So that is the magnitude of the variation of the pricing which is available. But on the other hand, what has happened is the ministry's Jan Aushadhi. So this program has been a boon to all the low middle class people and the low income groups. So because the same tablet of 1 milligram glimepiride 10 mg costs only 4 rupees in the Jan Aushadhi. So you can see that it's a big difference as far as the medications are concerned. And also Indian government has introduced the drug regulatory control. And then in spite of that, some of the medications are available at exorbitant price. So which makes them the affordability a big issue. We know that the cost of diabetic medications are increasing as the newer drugs are coming. So, but the generic, what I would say is generic medications used with a high quality medications, so which is going to be definitely a good option for all our patients. As far as the insulin is concerned, we have an availability of a human insulin, and now expensive insulin analogs have come. So the human insulins like a short acting insulin or NPH is available in all the public hospital. But studies have shown that even in Bangalore and in the Delhi studies have shown that the availability is suboptimal. It's around 60 to 70%. With the COVID, it has become even more problem when the supply chain was affected. So we have seen people lack the insulin, they coming with the complications and decay and things like that. So because of disruption of supply chain, so this has become even more a problem. So now the good thing is we have Indian companies which are producing the biosimilars. So like we have long-acting analogs which are biosimilar, which are much affordable price. So which are also made available in the few of the public hospitals. So in that way, again, the insulin availability is an issue, and people are switching from the conventional vial and then syringe to the cartridge and then pen-based this one. So there are a lot of advances are happening, but at the same time, how much our people will be able to get? So that is the question. But there is a big issue about the availability, affordability, and the cost which is involved in the as far as the both the OHA and then the insulin is concerned.
Thank you, sir. So there are many questions we can continue discussing, but time is limited. So I'd just like to ask last couple of questions. One question to Dr. Gopabandhu Nayak, sir. So what is the role of multidisciplinary team management in diabetes? And for that purpose, should there be a role of starting paramedical courses in diabetes?
When you are talking about the multidisciplinary approach for management of diabetes, we should it means there is a role of say podiatrist for diabetic care and a physiotherapist and orthotics. Many of the center have facility for PMR and orthotics facility, and for screening the diabetes at the time of initial visit, you may have trained personnel which can be diabetic trained personnel. Maybe those are have basic education up to maybe 10th class. They can be trained adequately to do how to do all these testing like monofilament, bias meter, and checking the BPI and pressure. This can be very, very helpful, and even we need to have a nutritionologist at the facility, and I think most of the center have facility for nutritionologist. Those are very trained in the management of diabetes, and these are the basic requirement. And many of the patient also have the psychological and behavioral problem with regard to diabetes. You may not have a psychologist, so it is a kind of a multidisciplinary management, rather than you cannot alone able to manage the diabetics patient alone. So even those patients are coming in the OPD because of time constraint. We are not able to train them about how to take the insulin, how to adjust the insulin, and how to. So diabetic educator program. Many of the places have diabetic educator program where the nurses can be trained for the diabetes educator program. Particularly, I can tell CMC Vellore has the training program which train the nurses for diabetes. They also have a training program with regard to the doctors those are have MBBS degree or MD, or so they can be trained under for the short-term diabetes education program. And even many places have a facility for integrated diabetic food training program. So definitely, if you have a training program, it can definitely improve the quality of care in patient with diabetes.
Thank you, sir. So one last question I'd ask Professor. The under PMSSY, many new aims are coming up, various stages of development. What opportunity does it give us and present to the country for improvement of healthcare?
Yeah, of course, these institutions were envisaged so that affordable care could reach in different parts of the country where it was not available. And at the same time, it would also create facilities for teaching, training, and research for the medical professionals, nursing professionals, and other paramedical technical force also, which could be trained. I think they've already started doing a very good job. We had only one AIMS, that is AIMS New Delhi in 1956. And now, like you mentioned, 20 plus are there in different stages of development. And they've already started doing their job very well, whether it is training of undergraduates, postgraduates in the medical field, the nursing field. And in many of these new AIMS, even endocrinology departments have been set up initially with less faculty, and gradually that number is bound to increase. I will have also DM courses coming up, and more, I think, super specialists would pass out and then would also serve different parts of the country. The other aspect, I think very rightly touched up by Dr. D. Vinayak, was regarding the ancillary support that the medical professionals will require. And nurse practitioners have a very big role to play. We have seen it in the NHS in UK and so many other countries, especially in the peripheral areas where it's difficult for doctors or MD or DM specialists to be available. They can play a very wonderful role over there. Then you have the facilities of telemedicine, teleconsultation. Many patients can be treated in the periphery, and you can have a proper referral pattern and refer those patients to the bigger center wherever. So I think we also have a role to devise these kinds of treatments, become hubs and develop a hub and spoke model. All these institutions can do it in different areas wherever they have been set up. It was envisaged like that. I think all of us, it is up to us to take up this leadership role, and the policy matters will always guide us. But I think the local issues, we are the best to understand. And like Dr. Pandit mentioned, in collaboration with the state government, which is possibly the biggest stakeholder, we can do a much better job. Thank you very much.
Thank you, sir. Thank you. I would like to thank all our panelists for this wonderful and enlightening discussion. I'd like to ask our chairpersons to take over.
Good morning, all. That was a very excellent and enlightening session where the different core aspects of the diabetes were discussed, may it be preventive, curative, or diagnostic. And the different panelists, they have shared their experience. So with regard to the surgical care of the patients whenever they are coming across. The public health expert in Dr. Abhiruchi has shared his knowledge so far as the epidemiology and the preventive aspects of the diabetes in the society. And our clinicians like Dr. Pandit, Dr. Nayak, and Dr. Behra also, they have shared their experience as regard to how to prevent and how to increase the access of this care to most of the patients in the country. So that was enriched. That was a really enlightening discussion. And I think the audience or the persons who are online also will be highly, they will get more information and they can propagate this message to the deeper, like in the rural setting, to have more access to the diabetes. Now I will request anybody in the audience would like to ask any questions to the panelists for their clarifications.
Is one of the factor we can undertake. So I am keen to know that how many patients of diabetes can be prevented by lifestyle modification, because diabetes is disease of genetics, potential, behavior, and environmental factors. So suppose we have 100 patients of diabetes, how many could have been prevented just by modification of his lifestyle? That is one. Secondly, means if the life, suppose how we are going to take lifestyle modification, is whole population or based upon the risk, like screening of pre-diabetes condition or high risk like obesities, family history of diabetes, or it is the whole population?
Yeah.
Thank you.
In response to your first question, sir, see, lifestyle factors play a big role, as was recently pointed out in this discussion. See, these are multiple factors, and etiology, if you say clubbing them as just in three aspects as genetics, type 1 diabetics, right? And the behavioral factors and these factors. See, I would add upon here, when we consider the epidemiology of diabetes, it is multifactorial. Even stress, maybe, that also might lead to certain effects. So whenever we talk about these diseases, the thing is we have to improve the quality of life. So the first and foremost principle is, if detection is already done, as I was mentioning earlier also, at let's say 30 years or 35 years, these lifestyle factors can at least, the controlling of these lifestyle factors can at least prevent the complications. See, here we work at tertiary care level. At tertiary care level, our responsibility, apart from whatever respected director sir and Pandit sir had said, our responsibility also is that we do not let it progress further. So the focus should be there once you have detected early. So that is the role here. So yes, I believe I can share some data with you. I have that, which was as a result of the NCD monitoring survey. It is AIMS Raipur under sir's guidance was privileged to be a part of that survey also. And it has said that in any diabetic or any person who is suffering from diabetes, they have more 2 out of 5 of these who suffer from all these NCDs have more than these 3 risk factors in actual. That's my take on it. The further data I have, I can share it with you.
Thank you, Dr. Abhiruchi. If anybody has any other questions, they can ask. I want to add one more thing, sir. Today in the panel discussion, we have discussed about the adult pediatrics. So yeah, so there is a growing concern about the childhood diabetes also, because the prevalence, though the studies were conducted isolatedly in North India, South India, but if you like to combine epidemiological data, if you gather, the prevalence will be around 4 to 11, sir, per 1 lakh population. So the prevalence is very high. And we should not forget that this diabetes has got to do with a lot of complications as regard to the growth and development of the children. And because that is very crucial during the childhood period, particularly during the puberty period. Sorry. And particularly during the period puberty period, as we have witnessed like COVID also, the obesity is a very growing concern, and that is more in 20 to 30% increase in the resistance to the insulin. And one more thing I want to highlight here is the neonatal diabetes mellitus, which is also in the rise, where you can diagnose the disease in first 12 months of life. Obviously the genetic makeup is more important in that situation, monogenic diabetes mellitus. But nonetheless, we should focus on the maternal, gestational diabetes, pregnancy diabetes, and the preventive aspect, what you have highlighted, so that we can decrease the burden of diabetes to a large extent. Coming to the theme, I wish today's, I think 100 years of insulin has been discovered 100 years back. So this is a centenary. And still with the discovery of insulin of 100 years, still thousands of children are far access to the care of diabetes, or you can say get the insulin. Like Dr. Pandit was also telling, the availability, and you can say the drug which is available to the consumer is less, though the production is more on the higher side. So this is all about I want to say. I think Dr. Alok sir was to say something.
So what I could gather from this panel discussion is that in the 90s, the incidence was 3.2%. And now in 2016, it came to 6.5%. And with the growing population, think about the absolute count. It has gone high in lakhs and lakhs. Now, diabetes can be managed as such, it's okay. But then there are cases which are complicated and they need a comprehensive care. You can think of establishing centers for diabetes control, but then they cannot serve to the masses. And this is where the role of institutes of national importance comes, which provides a comprehensive care for these complicated cases. And in a comprehensive manner only, diabetes can be given better care at an individualistic level. Thank you.
So on behalf of the organizing committee, I would like to thank our panelist, Professor Dr. Nitinam Nagarkar sir, Binay Pandit sir, Abhiruchi madam, and who have joined through online, Dr. Naik sir and Dr. Behra sir. So over to Dr. Abhiruchi.
I thank our panelists and chairpersons for such an informative session. Next, I would like to request our Honorable Director, sir, to kindly felicitate Dr. Anil Goyal, sir. Now I request Dr. Alok Agarwal, sir, to felicitate Dr. Abhiruchi Galhotra, madam. Next, we will proceed with the prize distribution ceremony. Last evening, we had organized a postgraduate quiz competition where out of 8, 4 teams were qualified for the final rounds, and the final rounds were conducted today morning. And amongst these 4 teams, we have a winner team and a first runners team. So the first runners team is Team A, Dr. Superior and Dr. Shubhabrata. Let's have a big hand for them. And the winner of the postgraduate team is Team B, Dr. Sri Hari and Dr. Abhishek. I request Honorable Director, sir, to kindly present the first award to the winning team. I also request Honorable Director, sir, to kindly present the award to our runners-up team, Dr. Superior and Dr. Shubhbrata. Thank you so much, sir, for joining us today, sir. Next, we will proceed for the second session of the day. To chair the session, I would like to call upon Dr. Preetam Wasnik, sir, who is the Associate Professor, Department of Medicine, AIIMS Raipur. He has more than Sir has more than 13 years of clinical and academic experience and has published numerous articles in various national and international journals. Our second chairperson of the day is Dr. Jashaketan Meher, sir. He is the Assistant Professor, Department of General Medicine, AIIMS Raipur, with 8 years of clinical and academic experience. He has numerous national and international publications with special interest in rheumatology, immunology, and infectious disease. Now I would hand over the session to our respected chairpersons.
Because we are running somewhat behind the schedules, we will proceed with the procedures of this next talk. So there is some iteration. So next talk will be given by Dr. Deep Datta, sir. The topic is diabetes mellitus and liver association and management issue. So Dr. Deep Datta, sir.
Yes, sir.
Will
Thank
join
you.
online.
Yes, thank you so much.
Sir, I would like to introduce you. So Dr. Deep Datta, sir, is DM in endocrinology. He has also done DNB endocrinology and FRCP, UK. He's working in Cedar Super Specialty Clinic, Dwarka, Delhi. He's a former associate professor endocrinology and member ethics committee, Dr. RML Hospital, Delhi. He has 225 publications in indexed and international journals. He has special research interest, vitamin D, bone metabolism and parathyroids, pre-diabetes, diabetes prevention, autoimmunity, infectious endocrinopathy. He is member of various organizations. He is a member of Executive Committee, Indian Society of Bone and Mineral Research. He is a member of Executive Committee, Endocrine Society of India. Welcome, sir, to this online CME. I will hand over the mic to Deep Datta, sir, for further proceeding in his, for his lecture. Thank you, sir.
Thank you so much, sir, for the kind introduction. First of all, I would like to thank the entire family of AIIMS Raipur, especially Dr. Amritava Ghosh, the Department of Endocrinology and the entire Department of Medicine for inviting me. I have been enjoying the previous session. It has been a great learning experience for me. I have been given the difficult topic of discussing diabetes and liver and its association with regards to management issues. This itself is such a huge topic. Perhaps one day we'll have a separate symposium on this. I'll try to justify all the possible permutation and combination in the next 15 to 20 minutes. We have already discussed in the previous sessions the huge problem of diabetes in India. If you add to it the burden of pre-diabetes, that's like 1 in 4 Indians are metabolically challenged. 25% of the population are dysglycemic. That's a huge number for a country with a population of around 136 to 138 crores. What's making worse is that we perhaps developed the diabetes the earliest. We're talking of type 2 diabetes here, earliest across all the ethnic groups across the globes. Now, the things are really worse in urban India. So the previous values for the overall country perspective. Now, this is the CAST study, which specifically looked at the burden of dysglycemia in urban centers, focusing on Chennai, New Delhi, and Karachi. If you look at the numbers from Delhi, from where I come from, they found the prevalence of diabetes to be around 23% and an additional 37-38% to have pre-diabetes. That's like more than half of the city is dysglycemic. And a majority of these patients, individuals, do not even know that they have dysglycemia, and they are going to present with 1 or more end organ damage, which are easily preventable. So on this World Diabetes Day, I think prevention is the way forward we should highlight. And why these figures are important from liver, because the liver is the door to not only liver is not only end organ damage of diabetes. Liver can be a big marker for picking up people with dysglycemia early, so that we can actually institute measures to prevent diabetes then. Now, it is not surprising if you look at the global data of non-alcoholic fatty liver disease, the term has become obsolete. Now we call it the metabolism-associated fatty liver disease. It's a more holistic term. And when we look at it in India, nearly out of every 100 individuals, nearly 2 to 3 people have established metabolism associated fatty liver disease. We know when we talk of liver and diabetes, it's a spectrum disorder. At one end, we have chronic liver disease, which is end stage liver disease. Then we have NASH, but there's significant amount of liver fibrosis. Then we have a long latent period of fatty liver disease, which may go undetected for decades. Which is perhaps the earliest form of presentation. Now, when we talk of liver and diabetes, the most widely available tool to pick up liver disease or fatty liver and diabetes ultrasound, but it is a it has a very low sensitivity. Typically, when we pick up grade 1 fatty liver, the liver already has more than 30% fat weight by weight. So it's pretty late. The most sensitive tool to pick up fatty liver disease would be CT scan, but then it's a very costly test. A CT scan can pick up once the liver fat cross 5% fat weight by weight, but it's a very costly test, involves a lot of radiation exposure, not easily available. We have FibroScan. Again, there's no radiation exposure, but it's a very costly test. It's a surrogate measure of liver fibrosis. Again, it's a good method to pick up people who have going into NASH, but it's again not a great tool to pick up early liver involvement in diabetes. So we are still at need of good, cheap tools by which we can pick up liver disease early at the level of population, which we don't have. In this regard, we published a paper in IJEM where we showed that certain anthropometric parameters like neck circumference to height ratio can be a very good reliable tool for picking up liver disease in people with pre-diabetes, which is the intermediate state before diabetes. We developed Indian cutoffs both in men and women by which we can pick up people who have a high risk of liver disease, and these are the people we can do ultrasound or fibroscan. That would be a more cost-effective approach. This was developed in the eastern population among the Bengali ethnic group. It needs to be validated across the different other ethnic groups in our country. Now, moving on from Calcutta to Delhi. In Delhi, this is our center's data, which we published a few years back. Now, this is all the people walking into a center cohort of more than 5,000 people. If you see the BMI, just the BMI, 60.5% were obese by Asian cutoffs, which is a BMI of more than 25 kilograms per meter square. And if you look, an additional 8% were morbidly obese who had a BMI of more than 35. So basically, Delhi is all obesity. When we talk of type 2 diabetes in Delhi, it's almost always diabesity. And as an important point was raised in the previous panel discussion, that childhood type 2 diabetes is becoming a big problem. The pandemic last 2 years, kids have stopped going out. The prevalence of childhood obesity has increased exponentially since COVID-19 came to our country, and that has led to an exponential boom in pediatric type 2 diabetes, not type 1 diabetes. Very scary scenario here. To add to it, we Indians are metabolically challenged. We have a thrifty phenotype. We published a paper in DRCP where we showed that when we give a mixed meal diet to Indians, when we compare people with diabetes with people with apparent normoglycemia, people with diabetes, they were more metabolically challenged in handling that mixed glycemic load. They had a greater surge in postprandial triglyceride levels. So postprandial hypertriglyceridemia is a very strong predictor of insulin resistance, further progression to diabetes in people with prediabetes, development of prediabetes in people with normoglycemia, and they are also predictors of worse outcomes in people with established type 2 diabetes. We tried to find some genetic factors, and we established that people in Eastern India who had a certain polymorphism of the TNF gene, they had a greater underlying systemic inflammation, and these people had a higher risk of progression from pre-diabetes to diabetes. Again, we know that urine albumin creatinine ratio is a measure of renal injury in people with diabetes, but it's not unsurprising to know that people with early dysglycemia and pre-diabetes may have this measure of endothelial dysfunction, and these people again tend to have worse metabolic outcomes. So what is driving the problem of diabetes and metabolic associated fatty liver disease is the Indian diet. Irrespective of which part of India we are coming from, what language we speak, what unites us is the love for carbohydrates. The starch study showed us that across the country, we were taking around 65 to 68% carbs in a diet. An average Caucasian takes only around 45 to 50% carbs in a diet. So single population intervention is being increased protein content of an average Indian diet, reducing the carb intake would go a long way in prevention of diabetes and diabetes related liver disease. So when we talk of liver, it is important to discuss about diabetes reversal. So now we know that type 2 diabetes is not the last word. It is a flexible term. At least people who have recent onset type 2 diabetes. The direct study showed us that people with type 2 diabetes for even 4 to 6 years, who were on oral anti-diabetic medication for 4 to 5 years, who were obese, if they lost body weight, you could reverse diabetes. And How the weight loss was done? In this study, it was done by a very low calorie diet. And what were the exact figures? People who lost 15 kilos or more body weight, they had more than 80% of chance going into normoglycemia and off all diabetes medications. People who lost 10 kilos of body weight, they had around 50 to 53 chances of diabetes reversal. People who lost only 5 kilos of body weight, they had only 20 to 30% chance of diabetes reversal. So quantum is, if an obese person with diabetes or pre-diabetes walks into our OPD, if a person with having fatty liver disease walks into an OPD and obesity, we tell them, come on guy, you can lose your weight. If you shed the excess weight, you can reverse diabetes. That's a great motivating factor. We discussed in the last session the huge cost associated with diabetic medications. So if you can tell our patients, you can go off medications, your monthly bills are going to come down significantly. That can be a really important motivating factor to go for more strong, more motivated therapeutic diet and lifestyle changes. So how does this diabetes reversal happen? Here comes again the role of liver. We all know that we have greater visceral adiposity. When we talk of visceral adiposity, there is the fat in the omentum, there's also the fat in the liver, and there's also some fat in the pancreas. So now we know that once a person crosses the critical threshold of liver fat and pancreatic fat, they develop significant insulin resistance. They have a greater amount of hepatic glucose output, greater amount of gluconeogenesis and glycogenolysis, and that leads to impaired fasting glucose and fasting hyperglycemia, and that leads to type 2 diabetes. If the person loses body weight, reduces the liver fat by a critical amount, we can actually reverse type 2 diabetes in them. And we are not only talking of reversing diabetes, we are talking of prolonging life, increasing survival. Look at the Okinawa people, the people who live on the Okinawa Islands in Japan, they average live more than 100 years. In any case, Japanese live the longest, and these are the people who live the longest even among Japanese. And what was shown that these people ate much less calories and they had a very low carb intake. So we are getting clues from different ethnic groups, what changes we can bring in our diet and lifestyle. There are papers published in Diabetology to show that acute calorie restriction also leads to remission of diabetes in people with established type 2 diabetes. What happens mechanistically? With acute calorie restriction, there's a sudden decrease in hepatic glucose output. The fasting blood glucose comes down, and the lipid, the triglycerides, significantly comes down in them. So intermittent fasting, religious fasting, certain religions have more extensive fasting, like Jainism, they have very severe form of fasting for a few days to even weeks. They are great ways if done in a controlled scenario. So we should look back to our literature, look back to our culture, and these are also important methods of controlling metabolism associated liver disease and reversing type 2 diabetes. So what in nutshell is what we understand in 21st century is the twin cycle hypothesis, which talks that if you reduce the liver fat by a critical amount, if you reduce the pancreatic fat by a critical amount, there is recovery of beta cell function, there's recovery of insulin production, and you can reverse type 2 diabetes in such obese people. How we can do it? What are the better methods? I think we will have newer data coming up in the next few years. So in this regard, my guide, my teacher, Professor Sasnath Mukherjee at IPGMA Calcutta showed us that vitamin A can be an important predictor of development of type 2 diabetes in people with fatty liver disease. And he is developing a molecule which can inhibit vitamin A levels, because higher circulatory levels of vitamin A has been linked to development of type 2 diabetes. So vitamin A antagonist can be a novel medication in the future, which can not only handle the metabolism associated fatty liver disease, but may have some role in controlling dysglycemia also. We have already published epidemiological data to show that people having high circulating vitamin levels, they have a higher risk of progression to type 2 diabetes, and they have a higher systemic inflammation and circulating inflammatory markers. When we talk of liver and diabetes, till now we have been talking of type 2 diabetes. It's important to consider something called glycogenic hepatopathy in people with long-standing, poorly controlled type 1 diabetes, who are malnourished, underweight. When we give them insulin and control their diabetes, they may suddenly develop transaminitis and hepatomegaly. It's a benign condition. We should not lose heart. Control their diabetes, and this is a reversible condition. Thankfully, this is a condition we don't see commonly in 21st century. It was more common in the previous century. The liver is another important source of an enzyme, the AMPK. AMPK is an enzyme which is present in all the cells of our body. It's a currency regulator. The currency of the tissue is ATP. So there are studies to show that medications which stimulate AMPK or improve our metabolism, they will not only have a better control of diabetes, they may have a beneficial impact on liver disease control. So metformins and glitazones are the classic medications which are AMPK stimulators, by which they not only improve the type 2 diabetes control, they have beneficial impact on diabetic liver disease also. When we talk of diabetes, I think it's important to talk a few words on fibrocalcific pancreatic diabetes, a very unique form of diabetes found in Eastern India and the Southern India. So this is behaves somewhere between type 1 and type 2. They are progressively insulin deficient, but they are ketosis resistant because these patients have lost their alpha cells also. There's no glucagon, so there's no risk of ketosis in them. These patients in the initial few years, they behave like type 2 diabetes, but soon they will need insulin because they lose their beta cell mass progressively. An important factor to keep in mind, people with FCPD, they have 100 times higher risk of pancreatic CA and also hepatocellular carcinoma. Why it occurs, why the risk of cancer has gone up, we still don't know, but that is the point which has to be kept in mind. So when we talk of interventions on diabetes and liver disease, I think weight loss is the key. By weight loss, we can not only reverse type 2 diabetes, we can even reverse the hepatic fat content of fatty liver disease. Diet and lifestyle is the mainstay. There are medications which help us like metformin, the pioglitazone. Lot of encouraging data is coming with regards to SGLT2 inhibitors and beneficial impact on fatty liver disease. Saroglitazar is a molecule which has shown remarkable data in terms of not only controlling hypertriglyceridemia, but also has a beneficial impact on fatty liver disease. Recently, a few papers have been published from USA in hepatology journal where they showed that saroglitazar has a beneficial impact even in people with primary biliary cirrhosis and primary sclerosing cholangitis. So a lot of new information is coming on this dual PPAR alpha and PPAR gamma agonist. Now, moving on to end-stage liver disease and diabetes, which is chronic liver disease and diabetes, we must realize that diabetes per se also has an adverse impact on liver outcomes. Uncontrolled diabetes is going to worsen the liver fibrosis, is going to accelerate the development of portal hypertension, increase the risk of variceal bleed, increase the risk of ascites, and further complications of end-stage liver disease, which is hepatorenal syndrome and hepatopulmonary syndrome, and not to mention the increasing the risk of hepatocellular carcinoma. So what can we do about managing diabetes in people with established liver disease? Now, in people with chronic liver disease who are in child C, who are in encephalopathy, the drug of choice remains insulin. No questions asked, no confusions. But what about a majority of people who have child's A or child's B chronic liver disease and diabetes? Can we use oral medications in them for managing diabetes in the OPD settings? Of course, we can use. Alpha glucosidase inhibitors are great agents. They have low risk of hypoglycemia. They have low hepatotoxicity. Metformin can be very safely used. Metformin and lactic acidosis is a myth. There's a huge Cochrane meta-analysis published of more than 5 lakh people that show that lactic acidosis does not happen with metformin. It is a historical phenomenon reported with fenformin. Of course, nobody uses fenformin in the 21st century. We already know the beneficial impact on metformin in reversing diabetes-related fatty liver disease, like reducing the insulin resistance, reducing the liver fibrosis also, not to mention reducing the risk of hepatocellular carcinoma. Moving on from metformin, pioglitazone are great agents in managing diabetes-related fatty liver disease, to be used in child A and B, not to be used in child C liver disease. Sulfonylureas, they work good, but the risk of hypoglycemia goes up, especially in people with established chronic liver disease, significant liver fibrosis. They have reduced glycogen stores, so they cannot handle hypoglycemia well. They are at risk of brittle diabetes. So better avoid them in advanced liver disease. If you really have to use a sulfonylurea, gliclazide has the maximum safety data as compared to other agents like glimepiride or glibenclamide, which are also used among this class. Among the non-sulfonylurea insulin secretagogues, I think nataglenide is the agent which is not metabolized in liver and is the safest, and not repaglenide, which is more commonly available. A bit on other newer agents like DPP4 inhibitors, they are a nice agent. They have a low risk of hypoglycemia, well tolerated. They can be used safely in child's A or child's B chronic liver disease. GLP-1 analogs, not much studies available. In chronic liver disease, patient per se is anorectic, is not feeling well. If you give a GLP-1 analog, you're going to further increase the nausea, vomiting. So they are not commonly used in people with diabetes and liver disease. SGLT2 inhibitors, again, this is a class to be used in stable diabetic liver disease. They have some data in improving liver function tests, reducing transaminitis, reducing fatty liver, but not used in sick patients because that would increase the risk of euglycemic ketosis in those patients. Insulin is the backbone of managing diabetes in established chronic liver disease. We can use the basal bolus regimen. You can use a split mix regimen. You can use the premix as per the needs of the patient. As per individualization is the way forward in them. Now, a bit about other medications which we are commonly used. Hypertension is very common in people with diabetes and liver disease. What is the agent of choice would be? Here's some data to give us some trends. Lisinopril is an agent which is not metabolized. So if you have used an ACE inhibitor, I think lisinopril would be the safest agent. And important among ARBs, I think losartan is the only agent which has some anti-fibrotic effect at the setting of liver. So losartan is a very cheap, it's a generic ARB and should be preferred if you are going to use ARB for managing hypertension in diabetes and established chronic liver disease. What about lipid medications? Statins have been linked with increased occurrence of transaminitis. So use them cautiously. People with having more than 5-time elevations of liver enzymes, a good practice would be to reduce or stop statins. In this regard, I think saroglitazar is a great agent in managing hypertriglyceridemia related to metabolism-associated fatty liver disease. And it has some independent beneficial impacts on reducing progression of liver disease in people with diabetes. Liver transplantation is the last option in people with child C chronic liver disease. Liver transplantation has been linked to not only improving the quality of life, but also reversing diabetes in a good number of people. Many patients with chronic liver disease untreated or poorly treated, they may end up having cirrhotic cardiomyopathy also, which also has a poor outcome. So I would like to end my presentation that liver and diabetes is a vast topic on its own. Liver plays a critical role in the genesis of pre-diabetes and type 2 diabetes, and hence liver also has a major role in reversal of type 2 diabetes. Reduction of liver fat is the most important factor for diabetes reversal. Twin cycle hypothesis is the way forward. 1 in 4 Indians have dysglycemia. Nearly 1 in 3 Indians have some degree of metabolism associated fatty liver disease. Neck height ratio may be a key community screening tool for liver disease in people with dysglycemia. Metformin, acarbose are safe agents. Insulin is the safest agent for managing type 2 diabetes and liver disease, and better to avoid sulfonylureas in people with advanced liver disease. Thank you so much.
Thank you very much, sir. You have covered this complicated and vast topic in this short duration. Thank you very much, sir. And
Thank
you
you.
also try to make it as simple as possible for physician perspective, because we are running behind the schedule. If organizer permit, we can take 1 or 2 questions from the audience. Yes, sir. Please.
Hello, good morning. Good afternoon, Deep, and for excellent presentation. I am Dr. Bandyopadhyay from Raipur. My
Thank you, sir.
question is, are we not rating saroglitazar a very high hierarchy? Because it came for reducing HDL. It did not work. Then now they are saying it will reduce the triglyceride, and now it has shifted towards the arena of a gastroenterologist, and left and right people are writing it. So if you write it, then I think more than 100 crores of population in India who have got fatty liver will require saroglitazar. So is it not highly placed, and documents data don't show it? It's it should be very judiciously used.
Excellent inputs. I was looking forward to this question from you, sir. I personally don't use saroglitazar. We published a meta-analysis. It's available online in Diabetes and Metabolic Syndrome Research and Reviews on the use of saroglitazar, and we noted a slight increase in serum creatinine levels with the use of this molecule. My job was just to highlight whatever literature is available. I am not the person to recommend the use of medications. Personally, I use very sparingly. I don't use this molecule. We need more stronger data with the use of this molecule, but a lot of basic science interesting data is indeed available with the dual PPAR agonist, which is PPAR alpha and agonism. We had muraglitazar, tesaglitazar, which saw never the light of the day. This is the only molecule of this class which has seen the light of the day, and a lot of exciting work is still happening in the Western world, also starting from India. This is a molecule which came from India and has gone to the Western world. Time would be the best person and to teach us about all the good things and also the bad things about this molecule. But my point was to highlight the role of dual PPAR alpha and PPAR gamma agonism in terms of improving metabolic outcomes in people with liver disease.
Sir, you want to ask question, sir?
Good afternoon, everyone. I thought of raising a discussion with you, with the endocrinologists and the physicians, but luckily the speaker has already raised some of the points like reversal of diabetes, particularly with weight reduction, the role of liver in diabetes, etc. But my simple question is, what is this insulin resistance? Why is there insulin resistance? Everybody is talking of insulin resistance. Yesterday, to attend this seminar, I read nearly 40 pages of Leininger's biochemistry. What is insulin resistance? At the most, they say it is down regulation of insulin receptors. Did you quantify that? What is the reason for down regulation of insulin receptors? Lack of exercise. Is it the only cause? I think the main cause is the cell is overloaded with glucose. That is why the cell is not accepting any more glucose and insulin resistance has developed. What are we doing? Our main treatment is pushing more insulin. Already I am hyperinsulinemic. I am a diabetic for the last 25 years. Non-insulin dependent diabetes means I am hyperinsulinemic. We are pushing much more insulin into the system. And we all know that insulin is lipogenic. That is the main culprit for obesity developing like a pandemic. And then the other important thing is that we have to unload the cell. Did we ever measure intracellular glucose? We are measuring only blood glucose, extracellular glucose, but the problem is with the intracellular glucose, not with the blood glucose. And what is the normal range of diabetes? When I was a student, we was talking about 120 milligrams % is normal because that is the renal threshold. But now it has come to 140 milligrams %. And our speaker has said one word. It reduces the cost of treatment. But sir, you will become a Taliban if you reduce the cost of treatment. You are not accepted. You cannot reduce the cost of the treatment. You have to increase the cost of the treatment. So here the simple thing is intermittent fasting. I had practiced that. And before that, for the of the 25 years of my diabetic life, more than 10 years I used direct insulin. Of course, oral hypoglycemics also increase insulin, direct insulin, but never my blood glucose came down. It was always around HbA1c around 8. I stopped insulin, I stopped all hypoglycemic drugs. Why stopping hypoglycemic drugs? Intermittent fasting cannot be practiced as long as you are taking diabetic medication. So you have to stop diabetic drugs. Once I had stopped diabetic drugs, luckily my endocrinologist is also present as a witness here. My HbA1c for the first time in my life came to 5.6. We were alarmed. And he advised me to continue this. But there is one more side effect with this treatment. The side effect is I have reduced 4 kgs of weight. This treatment is ideal for obese. For non-obese, it is a much more complicated case. We have to balance. Because of that, I again started metformin. I again started taking more carbohydrates. The simple thing is, sir, I have read ADA guidelines. I had read the Association of American Association of Physicians guidelines. They said don't start insulin unless it goes to 8. Unfortunately, when I heard this word first from a medical shop fellow, I felt ashamed. A medical shop fellow knows this, that American Association of Physicians has recommended this, but we don't know this. We are pumping insulin directly or indirectly. Then what I have noticed is I started for breakfast coconut. The moment I took coconut, carbohydrate requirement came down drastically. That, and we practiced with several sweets made with coconut, with using almost no sugar or with very less sugar. So here we have to think of what is the cause of this obesity and how far insulin is playing a role in the development of obesity. As you said, a very good word, if obesity is reduced, diabetes can be reversed. And then out of the 25 years of my diabetic life, I had no symptoms. Of course, I had 3 times frozen shoulder. Except that, I had no symptoms. My only symptom is recurrent attacks of hypoglycemia. But my physician won't listen to it. He won't believe it. It could be false alarm he was telling. Once I went into hypoglycemia in my department, I have to lie down in the sofa in my department. Then he said, this could be real. Because my blood sugar level is showing high, but I am getting hypoglycemia. And ADA has clearly said, keep the target high if a patient is prone to hypoglycemic attacks. But my blood sugar level, that number is not accepting. So we have to rethink about this, sir. Yes. There is a serious thing. Unless some non-medical fellow bang us, it is better we ourselves rethink about what is happening here and how can we make out a scientific study of that. Estimate intracellular glucose, not just blood glucose. And my cardiologist always says in the 25 years, your heart is perfectly all right. But our doctors are threatening. At one time in Hyderabad, Apollo Hospital Fellows has put a board in each and every corner, in each and every gully. Chest pain, it could be MI. We know there are 100 types of non-cardiac chest pains. So is that threat real? How much? 25 years have passed for me. Never did I get any UTI. Never did I get anything except this frozen shoulder. So what is the normal level of blood glucose also has to be re-estimated. It is not a fixed thing for all people. It is a much more complex thing. That is where the art comes into play in the medical science. I think.
Thank you.
Thank you very much.
Thank you, sir.
I request you, all of you, to consider these aspects of treatment of diabetes. And now, it is not the role of physicians to diagnose diabetes, because every Indian is a diabetic unless proved otherwise. Please diagnose non-diabetics. It has come to that level, and there is something, the problem here in this, the management of diabetes. Please kindly consider this.
Okay,
thank you very much for giving you this.
Thank you, sir, for the comments. We proceed further with next session because we are running late. So next topic, I think Dr. Jasketan will introduce the speaker.
Thank you, Pritam sir. So next is a very interesting topic, and we know that the diabetic mellitus is a major non-communicable disease with very high prevalence, as well as the microvascular and macrovascular complication is very high. So among them, Charcot foot is a very important complication that create very high morbidity among the diabetic populations. So next topic would be Charcot foot, the newer insight. I would like to invite our esteemed speaker, Dr. Asu Rastogi, who is a MD DM and is a faculty in Department of Endocrinology in PGIMER and Chandigarh. So he has a very high experience in managing diabetes and its complications like Charcot foot, and he has published around 100 papers in a national and international journal, and his best research paper in presented in the Netherlands, and he has got the Oreson, Professor B.R. Srivastav Oreson in 2017, and also many awards. And he has got the outstanding paper awards in the US Endocrine Society in the 2015 also. He has also received the Young Investigator Award in 2011 in USA. and also have received A.V. Gandhi Award by the Endocrine Society of India in 2012. And he has done his many fellowships in American College of Endocrinology and Royal College of Physicians, and also he has been the treasurer in RSSDI in the Punjab chapters, and he also is act as a PI in various trials also. So I like to invite Dr. Asu Rastogi to give lectures on charcoal food and newer. Over to Dr. Asu Rastogi.
Yeah,
Welcome,
I hope I'm audible and my slides are visible. Chairperson, sir, I hope I'm audible.
Yes, sir. Yes, sir. Audio.
And my slides are visible. You can see my slides?
Yes, yes, sir.
That's
audio is also audible. Right. Correct.
Thank you. Thanks a lot. And thank you to the whole AIMS Raipur team, and especially Amritav, to make this Diabetes Day, World Diabetes Day, as 14 November meaningful. And I'll be dwelling upon, I would say, a topic which is not commonly spoken of in the conferences, in the meetings, and a topic which is very pertinent, because at the end of the day, it is the foot which carry us to many locations and many places. But unfortunately, this foot is only a bystander during the treatment of diabetes. People talk so much about the drugs, the glucose levels, but foot is also the part of human body which needs to be seen. So I would be, before that, I have nothing to disclose regarding the today's topic. And today I will just discuss that why actually we are discussing diabetic Charcot's foot in patient with diabetes. More importantly is because I know that there would be many physicians and people, internists in the AIMS Raipur. So it is very pertinent to them that when they should suspect Charcot's foot and how exactly to diagnose that. And if they have diagnosed Charcot's, then how we can stop this ongoing process, how to follow a patient with Charcot's, how to define the remission of Charcot's. This is again a very interesting area. And now we have been working on it. And finally, what are the long-term outcomes? So I would begin with that why we have gathered here regarding the management of this diabetes and diabetic foot. This was the study, and this is one of the largest study in the world. This is our study, which included more than 4,700 patients of diabetic foot, followed for a period of around 8 years. And the main aim was that all of these patients had neuropathic foot ulcers. Some of them also had Charcot's foot. And our aim was to study the limb amputation and mortality in these individuals. We found out that those patients of diabetes, if you see, and if they have a foot ulcer, they are at very high risk of dying. And the risk of dying is around almost 5 times as compared to our diabetes patients with matched duration of diabetes who do not have a foot ulcer. So that is very important. So if a patient is having diabetic neuropathy, we have to be more careful. This is another study, and this is one of its kind study, where we studied the mortality in patients with Charcot's neuroarthropathy. And mind it, we had twice matched controls who were matched for the duration of diabetes, and then we followed these patients for 5 years. Interestingly, we found that almost 1/3 of these patients who have so-called Charcot's also develop ulcers, and 1/6 also have consequent amputations. But what is interesting to note is what happens to them after 5 years. So we noted that those patients who develop Charcot's, they are more likely to die. The mean survival was less, and the odds of dying was almost 2.5 times as compared to a routine diabetic patients with matched duration of diabetes and also having diabetic neuropathy. So I mean to say by these slides is that probably if we are discussing Charcot's in this forum, it's not a myth, it's truth, and it's a reality. So this study showed that Charcot's is associated with not only the limb outcomes, but also the life outcomes of a patient, because they are associated with higher mortality as compared to a patient without Charcot's. Now, this is a patient who came to us, a 53-year-old gentleman who was a diabetic for 9 years, and he had a swelling of right foot for 12 weeks. He was just roaming here and there. He was prescribed quinolone, suspecting cellulitis by a first physician. Then the swelling did not decrease. Then he went on to second person who started him on parenteral antibiotics, ceftriaxone, and so on and so forth. So after wasting 3 months, he presented to us. So diagnosis in this patient who has a swelling in the midfoot, predominantly the midfoot region, with the erythema, and on touch it was also warm. But what you can see is the loss of arches, and it is a flat foot or even rocker-wide kind of deformity is going there. So you can have a differential of cellulitis, osteomyelitis, gouty arthritis, traumatic fractures also, or Charcos. But unfortunately, nobody did in simple X-ray in this patient. So once you do an X-ray, this was the picture. So this was a very unfortunate for a patient because nobody had advised him offloading or not to put the foot on the ground. So you can see many of the bones, which are the mid-tarsal bones, have just vanished. And this is just, and all of this tarsal bones, this calcaneum bone, talus bone, everything is fractured. Unfortunately, this limb is unsalvageable. We cannot make a patient walk again. So we published this as vanishing bone disease, but this is very unfortunate for the patient. So it's very important to recognize this entity, which is called Charcos foot. How do the patient actually presents? So you can see this patient just present within 2 weeks of onset of a swelling. You can see a left foot which is swollen up, which is red, erythematous, as compared to his right foot. So in this context, definitely you can make a diagnosis or a differential of cellulitis, but always consider Charcos. So we did a bone scan and we found out that there was a markedly increased uptake in the bones, and that was suggestive of Charcos neuroarthropathy. So you can have a varied presentations and outcomes, but what is important is that you should know what exactly we are dealing with. So unless we know the disease, we cannot diagnose and treat this. This is another patient. Again, you can see a swelling in the left foot as compared to the right. You can see it is also erythematous, but interestingly, this gentleman also had a swelling of the left wrist also. You can see the wrist is swollen up as compared to the right wrist. So this was one of the very few cases that have been reported in the world regarding the concurrent wrist and the midfoot Charcos neuroarthropathy. So this is very interesting. Whenever you see a patient of diabetic foot swelling, yes, you can consider infection, but remember there are some other differentials also, and one other differential is acute Charcos foot. So you can consider osteomyelitis, septic arthritis, gout, which is mainly in the forefoot, especially in the MTP joint or rheumatoid arthritis, or even DVT, but never forget acute Charcos foot. How exactly we diagnose acute Charcos? It's, as I was mentioning, it is essentially clinical. You have to have a high index of suspicion for that. A background history of dense neuropathy is very important. The swelling is usually localized predominantly in the midfoot region, and these patients have a normal pulses of sometimes pounding pulses with a normal ABI. And this usually suggests a presence of Charcos in a given patient with swollen midfoot region. What people say is that serological profile is not useful, and we also have found out that probably the ESR might be raised, but it can be raised in cellulitis also, so it might not be useful. So the plain X-ray, but important is a weight-bearing X-ray. So whenever you ask for an X-ray, you write to a radiologist, it should be a weight-bearing X-ray. Then only you should send the requisition form for the diagnosis of Charcos. But if X-ray is normal, you have to do an MRI. So what you see on X-ray is a flattening of the metatarsal head, and which is considered as the first sign of the Charcos neuroarthropathy. You can also have some focal demineralization, especially in the periarticular regions. So therefore, you need to characteristically mention to your radiologist that you are suspecting Charcos neuroarthropathy, and there would be absence of soft tissue involvement, and predominantly the subchondral part of the bone will be involved, mainly periarticular, and multiple bones or the joints would be involved. Therefore, it is called Charcos osteoneuroarthropathy. So therefore, joint will be involved, periarticular bone will be involved, and marrow will be involved in these patients. But do all patients require MRI scan? If plain X-ray is normal and you're still suspecting Charcos, yes, you have to do an MRI scan. Because remember, the X-ray findings are not so sensitive. They might take quite time, and especially they might take even up to 1 week before any bony changes will be visible on X-ray. But MRI is very sensitive. It can detect the marrow changes in the MRI scan just within 24 to 48 hours of onset of Charcos process. If a patient is having an ulcer overlying suspected Charcos, to have a better soft tissue detail, yes, you need to have an MRI. And if you're suspecting osteomyelitis, again, you need to do an MRI. And MRI is also required for follow-up in remission. And what you see in patients with Charcos on MRI is a bone marrow edema, and which usually appears T2 hyperintense. And that is very characteristic, especially in the periarticular region involving multiple bones of the midfoot, is suggestive of the Charcos process. Now we have a quite of work with nuclear scans, and I hope that AIIMS Raipur would also be having a nuclear scan facility for this. So sometimes we need to do a nuclear scan also for Charcot's foot, especially if the skin is ulcerated in a patient with Charcot's and you're suspecting osteomyelitis, you might have to do a labeled WBC scan, and that might be a useful modality. So F18 WBC PET CT is one of the modalities. So this is one of the first study in the world regarding the utility of the labeled WBC for the diagnosis of osteomyelitis in patients with Charcot's neuroarthropathy that we published. And what we had, because it's very commonly seen that those patients of Charcot's which continue to walk and then they have ulcer, then osteomyelitis also, it sometimes gets very difficult whether we are dealing with an acute process or an osteomyelitis. You get these kind of images in this gentleman. You can see that once you do a simple FDG PET, you can get these kind of images because FDG goes to any kind of inflammation. It will go to the soft tissue, it will go to the bone, as compared to a WBC labeled PET, which usually goes especially only to the bone which is inflamed. And here you can see it is the first metatarsal. So we found out that this modality is 100% specific for diagnosis of osteomyelitis in complicated diabetic foot ulcers. So this modality is really useful, and if you have facility, you can definitely go for it. Now you have diagnosed a patient with Charcot's and a given patient with diabetes. The next burning question is how exactly to treat and how to stop this non-infectious inflammation of the foot that is called Charcot's. So first, we have to go back to the basics. Now, what happens is we should know about the pathophysiology. We know about the neurovascular theory. We know about the German theory, the French theory of the Charcot's. But these are the recent developments in Charcot's, and this is related to increase in blood glucose with the absence of receptors for advanced glycosylation end products lead to increase in ages. And we know that increased age stimulate the rancle. And rancle is the primary stimulus for the osteoclast, which is responsible for bone destruction in patients with Charcot's, as I was showing in the first X-ray. Moreover, these patients also have neuropathy, distal symmetric sensory motor neuropathy. So they would also have a decrease in the calcitonin gene-related peptide, which stimulates again rancle, again stimulating osteoclast. They also have autonomic neuropathy, which associated with decrease in the endothelial nitric oxide synthase, which again stimulate osteoclast. And more importantly is these patients, because of neuropathy, just continue to walk on that foot, which is affected, which leads to the production of more inflammatory cytokines like IL-6, TNF-alpha, and which again stimulate osteoclast to cause bone destruction in Charcot's. So once you know the pathophysiology, we can definitely target these pathophysiological aspects and decide upon the treatment. So you can directly inhibit the rancle, which is stimulating osteoclast, by giving bisphosphonates or denosumab. You can directly inhibit these inflammatory cytokines by using steroids or etanercept, or you can use calcitonin, which can directly act on osteoclast. So we have evidences for these molecules, maybe bisphosphonates, calcitonin also. And if there is the demineralization of bone has already occurred, can we use teriparatide in these patients with Charcot's? So this was one of the few early studies by one of my friend, Professor Edward Jude from University of Nottingham. Now he's in Manchester, who initially published the first randomized trial regarding use of bisphosphonates in Charcot's. And he showed that the temperature was decreased, but the outcomes they did not mention in terms of remission of Charcot's. Then came the study regarding the use of zoledronic acid in Charcot's, and these authors, which were from Norway, Pekrinen, they showed that patients who were on zoledronic acid have a longer immobilization time, and they showed that probably zoledronic acid do not work for patients with Charcot's. So this was a recent study. This is from Netherlands, again one of my friends from Westbrook, and they used denosumab for acute Charcot's neuroarthropathy, and they showed that the duration during which the time the patient will require a casting, that is called a TCC or total contact cast, is significantly reduced by giving denosumab. It was 123 days as compared to 182 days with the use of denosumab. So what we thought is that we have so much heterogeneous data, some authors saying that some drugs work, some do not work. Then we again went back to the basics and we found out that where does this contact cast is working? The contact cast works by preventing this generation of inflammatory cytokines, because it inhibits or it decreases the recurrent trauma, but still these cytokines are increased. So can we use methylprednisolone in these patients? Moreover, there was a recent study from King's College by one of our colleague, Dr. Nina Petrova, who showed that there is some T cell related factors which are responsible for the directly activating osteoclast, which is independent of rankle, and this can be inhibited by methylprednisolone. So we thought that there is no study regarding the use of methylprednisolone in patient with Charcot's. So if you can inhibit the inflammatory pathway, if you can inhibit the SOFAT, probably you can inhibit the active Charcot's process. And we just recently published this paper, this mechanistic insight in PLOS One. And because of that, we did this study by the use of methylprednisolone, and we compared it with zoledronic acid and the total contact cast in a 3-arm study. And our main aim was to see if the patient's foot is hot, so how much time does it take for a foot to go into remission, especially which is active Charcot's foot. So we studied the inflammatory markers, and we found out that inflammatory markers which are markedly increased in patients with Charcot's, they are significantly reduced by giving them methylprednisolone. You can see this, the checkered one is a methylprednisolone. This is the zoledronate one, and this is the only total contact cast. And both of these other arms also TCC was used. So we found out that inflammatory markers are significantly reduced by giving methylprednisolone. That is not a surprise, but they are also reduced by giving zoledronic acid and also by TCC. So TCC definitely reduce the inflammatory cytokines, but they are best reduced by methylprednisolone. We also found out that the bone mineral density of foot bones, because the bones which were involved, we studied the foot bone BMD, and we found out that the BMC, the bone mineral content, was increased by giving zoledronic, and it is reduced by giving methylprednisolone. And we found out that probably methylprednisolone do not reduce the time to remission in patients with Charcot's in spite of significantly decreasing the inflammatory cytokines. So at the end of this study, we found out that TCC alone is the best treatment for active Charcot's. Then we went on to ahead and we studied all the existing literature regarding Charcot's, and we just collated all the documented evidence of Charcot's till date. And we did this meta-analysis, which was recently published in ACTA, and we found out that probably pharmacotherapy was till date, whatever we are using is not so effective as compared to total contact cast alone to reduce time to remission. But yes, you can have certain benefits. One benefit which was observed with the bisphosphonate was increase in the bone mineral content, which was better, but the time to remission was not found to be statistically significant. So if you ask me what is the final holy grail for managing acute Charcot's, I would say that offloading is the gold standard strategy that could arrest the progression of deformity in patients with Charcot's foot. This was way back in 2012, and probably we, all the researchers around the world, are sitting again in 2022, and we'll again make kind of a guideline for management of Charcot's. So this is how we give a total contact cast to our patients, which is a cast which is made up of fiberglass, and then once the patient has achieved remission, we give these crow boots, which is called Charcot resistant orthotic walkers, which are removable. Now, next most important question is, once the patient is given TCC, how long to continue? And that is a very burning question. So usually the patients have temperature which is more than 2 degrees in the affected foot as compared to the normal foot. So we say if the temperature difference between 2 foot is less than 2, it suggests that Charcot's is gone into remission, but you have to document the temperature at least 4 weeks apart. You can also do certain kinds of markers which can assess the possibility of remission, like BTMs and MRI and PET CT SUV. So we usually ask the patient to come weekly. We monitor temperature by the infrared guns. Then we change the cast because it usually gets loosened to avoid a pistoning effect. And then we again apply the cast and reinforce offloading in these patients. So definition of remission is very important, and this is one of the recent papers. This is again from our colleague from Switzerland, who has published that probably for remission also you might not exactly rely on just temperature monitoring. You might have to do a FDG PET, and they found out that the temperature remission usually occurs just within 6 months, but the clinical remission, as you can see, just occurs within 7 months, but time to PET remission takes 15 months. And this is the best time where you can ask the patients to leave TCC and come back to the modified footwears. Because if you leave the footwear at 7 months, between 7 to 15 months, many of these patients have active Charcot's which are not picked up by temperature difference, and they would develop later on deformities. So this is what happens after remission of Charcot's. So people have studies. that what happens to exactly the foot bones, and they have found out that the bone mineral density of the foot which is affected is significantly reduced. You can see in patients with Charcot's neuroarthropathy, the foot BMD is reduced as compared to the control foot. And this is a very important finding as compared to a patient either who has a neuropathy or who has diabetes but without neuropathy. So one thing is sure that Charcot's definitely leads to kind of localized osteoporosis of the foot bones. And there have been some bone biopsy studies where they have found there is increase in the bone which is disorganized, which is immature, and there are a lot of house-shaped lacunae which is filled with osteoclast. Therefore, we thought that can we intervene in these patients by strengthening the foot bones so that do not develop fractures and do not deform. Now, this is again the first study in the world that we did by using teriparatide, which is a recombinant human parathyroid hormone in patient with Charcot's neuroarthropathy. And we found out that by giving teriparatide, there is increase in the bone formation markers, there is increase in the foot bone remodeling, especially because we use FDG PET and studied the foot bones. And we also found out that the foot bone mineral content in this red is the teriparatide and green is the placebo. The foot BMC is increased by teriparatide as compared to placebo where it is decreasing, suggesting that teriparatide is found to be useful. So this is one of the latest study that we published in PLOS One. This is regarding again 3.5 years of follow-up of patients who were initially given methylprednisolone or zoledronate. And we found out that over 3 years, there was no difference in the outcomes, whether the patient was giving TCC, bisphosphonates, or the methylprednisolone. Interestingly, none of the patients required amputations, but yes, some of the patients developed ulcers. So I would say that please do not neglect the patients of diabetes. We have to watch their foot. That is very important and pertinent, and never forget this so-called uncommon entity called Charcot's, but it has implications for both the limb as well as life of a patient. TCC is still the gold standard. Bisphosphonates increase BMD, but do they lead to clinical resolution? Our meta-analysis do not show that. Denosumab is a good option, and it can be especially used in patients with CKD because CKD is especially associated with weakening of the bones and Charcot's. Chronic Charcot's, teriparatide might be useful. And remember, you have to have a very high vigilance for the increased risk of mortality because these patients also have autonomic neuropathy. And we have seen that these patients have sudden deaths because of the presence of cardiac autonomic neuropathy. So always screen your patient with Charcot's for cardiac autonomic neuropathy. So thank you. And this is just my research staff, which is Professor David from Los Angeles, Dr. Edward Jude from Nottingham, Dr. Jeff Court again from Nottingham, and these are my collaborators and lab staff. So thank you. Thanks for patient listening.
Thank
back
you.
to the organizers.
Thank you, Dr. Asur Rastogi, sir, for your in-depth and extensive presentation over the Charcot arthropathy and your insights. And you have touched upon the diagnosis, the usefulness of MRI and PET scan with evidence-based treatment and management. So we have a few minutes. We will take some questions from the audience and from Chartful also. So,
yeah, good afternoon, Dr. Rastogi. I am Dr. Bandopadhyay, endocrinologist from Raipur. So you are a tertiary care center. Naturally, the patients are coming late to you. In secondary care centers, how to suspicion is clear, neuropathy with disorganized joint. How to suspect first that the patient has got Charcot? Because the stages we are showing here is not the first stage. Is there any staging of Charcot's disease which can be done, which can show that pick up the patient earliest? And second thing is, which will be better to do? Naturally, bone X-ray is the best thing to do first with neuropathic evidence. And what is to be done? MRI or a PET FDG scan?
Yeah.
How to pick up earliest in our secondary care center? You are tertiary care center. You are getting the patient very late.
Exactly. So thank you, Dr. Bandopadhyay. And that is the very pertinent question regarding how to pick up early. So first important thing, my presentation was specially designed to just educate the masses regarding when to suspect. Because unless we know the disease exists, then only we will suspect. So I have seen even my residents making a mistake. They never ask the patient to just put off their shoes and socks. So now it is a habit that every patient who land with diabetes in our clinics, we ask them, please put off your shoes and socks, because sometimes patient might not complain. They will just accept their mild swelling like as it is. So before even going on an X-ray in a patient with diabetes who has neuropathy, if there is a unilateral, limited, localized swelling of the foot, which is restricted to the foot and specifically to the midfoot region, which is erythematous and which is hot, always have a suspicion of Charcot's. Yes, it can be cellulitis, I don't deny that, but in a given patient without a prior history of maybe fever, so this Charcot should be suspected. And the best way in the secondary, even I would say primary health center, why not? They also have the X-ray facility. So you can definitely do an X-ray. At least the stages that I had shown, probably that might not be there if you can diagnose early. Second thing, your question about the stages. Yes, sir, there are stages of the Charcot's that is called Eisenhower staging, but that was devised around 40 years back by an orthopedician. And that is again based upon X-ray staging of Charcot's. So even before X-ray, I would say clinical suspicion and unilateral erythematous hot swollen foot, suspect Charcot's. Then X-ray, and if X-ray is normal, please do an MRI because MRI is very sensitive. And as you were saying, we are a tertiary care institute, but mind it, sir, I have seen many patients who just came with 2 days of swelling, and everybody thought that it may be because of CKD, it might be because of simple just a trauma or twisting of the foot, but it was Charcot's once we did an MRI.
Another question.
Dr. Rastogi, it's a nice presentation and very informative. I have one question. How long do you give teriparatide?
Yes.
It's like any osteoporosis you treat?
Exactly. So, ma'am, the study that we conducted, we gave teriparatide for a period of 12 months. And recently, Dr. Nina Petrova from King's College, and she had given teriparatide in acute Charcot's, and she had given just for 3 months. So that was a different role. That was to halt the progression of acute Charcot's, and our purpose was to increase the bone mineral content of the foot bones. And we found out that if we give for 1 year, there was a significant increase in the BMC, which prevented future occurrence of fractures in the foot bones and also deformity. And mind it, ma'am, these patients all had normal number BMD.
Okay, if the T-score for the spine and the femoral neck, if they are normal, then how do you approach?
Exactly, ma'am. That's what I'm telling. So in this study that we had, so we only took those patients who had a normal BMD at lumbar and the hip, because we were measuring, ma'am, bone turnover markers. So we were thinking that if already they had osteoporosis, diffuse osteoporosis of all the trabecular bones, probably the BTM change would be more from those metabolically active bone like vertebra. Therefore, we specially took those patients. And I would very honestly say that probably this study has a limitation because everybody asked that probably these BTMs is a systemic bone turnover marker. Why hadn't you taken the sample from the dorsal venous arch of the foot? That would be more useful for assessing the bone turnovers of the which is coming from the foot bones.
Okay, thank you.
Thank you, Asu sir. I think no more question either. One question from my side. And is there any role of USG in detecting early Charcot foot, or if patient is having peripheral neuropathy, or is there any role of USG in monitoring the patient of Charcot arthropathy?
No, sir. So why I am saying no? Because ultrasound, yes, you are right that people have done ultrasound, especially of the calcaneum bone to assess the bone mineral content. But ultrasound is a very poor modality to assess the marrow edema. And it is also not useful to follow a patient of Charcot's because we need a modality which can pick a marrow edema. So ultrasound is not a modality for that.
Dr. Vasti, can I ask a question, sir?
Yeah, please, if the organizers permit.
Okay, you can.
Thank you, sir, for a wonderful presentation. I'm Dr. Ekta, actually working in the field of autonomic and vascular neuropathy. Actually, you have mentioned about cardiac autonomic neuropathy. Can there is any kind of a relation between mild, moderate, or severe autonomic neuropathy with Charcot's disease?
Yeah, exactly. So, Dr. Ekta, thanks for the question. And we in our clinics are regularly monitoring our patients for autonomic neuropathy with both pseudomotor testing as well as cardiac autonomic neuropathy. And we use Ewing's criteria for the diagnosis of CAN. And we have found out that those patients who have a mild neuropathy, they are less likelihood of developing Charcot as compared to those who have definite of severe. And this is how the Ewing's have classified CAN. mild and definite and severe. So you're absolutely right that those patients have severe CAN, they probably also had a diffuse foot autonomic neuropathy and pseudomotor dysfunction, and they're more likely to have Charcot's.
Okay, thank you for a clarification, sir. Thank you.
My pleasure.
Thank you. I would like to thank our guest speaker for this session, Dr. Deep Datta sir, as well as Dr. Ashu Rastogi sir. They have delivered an excellent talk today to make this diabetic day more informative. So I declare that this session is over and I will hand over the mic. Again, I will thank all to attend this session. Thank you very much.
I thank the speaker for such a wonderful presentation. Next, I would like Dr. Asha to felicitate our chairperson, Dr. Pritam Vasni, sir. I request Dr. Nazia to felicitate Dr. Jashaketan, sir. Next, let's proceed to the next session of the day. To chair the session, I would like to call upon the very respected Dr. Biplab Bandopadhyay, sir, who is a renowned endocrinologist of the state with more than 25 years of experience in the field of endocrinology. I invite you, sir. Our second chairperson is respected Dr. Ajit Kumar, sir, who is the Assistant Professor, Department of Medicine, AIIMS Raipur. He is the Assistant Professor, Department of Medicine, with 10 years of clinical and academic experience and numerous publications in various international and national journals. I hand over the session to our respected chairpersons.
Very good afternoon. As we are running short of time, so directly I take my pleasure to invite Dr. Rohini Rokam. She will be talking about 100 years of insulin. As we all know that insulin being the cornerstone in treatment of diabetes, and it has completed 100 years. Now, Dr. Rohini will be telling how this progress has been till date. Dr. Rohini, can I have her introduction, please? Dr. Rohini is working as Assistant Professor in Department of Medicine, AIIMS Raipur. And she has got a great, good clinical and academic experience, and she has got a few publications in index journals, and I think her interest is in diabetic foot, and she will be talking on this insulin. Over to you, ma'am.
Thank you, respected chairpersons, for giving me this opportunity. Slide loads. This is an academic program, I know, but right now I would like to tell you all a story about insulin. So before we go to the story about insulin, Let me start just a few thousand years before insulin was discovered. So around India is known about diabetes since around 3000 BC. They knew that there is something in the diabetic patients which turns the urine sweet. That's why they named it Madhumeh. That means the urine is turning sweet. Have you ever wondered why it is called diabetes mellitus? Means most of the diseases are pretty self-explanatory. You know that when we say myocardial infarction, it means there is death of myocardial cells. But what is the relationship between this diabetes mellitus and hyperglycemia or pancreas or the insulin? So basically, diabetes comes from the Greek word, which actually means to siphon out. You can see the siphoning out picture here. The urine gets siphoned out from the diabetic patients and leaves them cachexic. The term mellitus was added somewhere in 1600s to differentiate diabetes from other causes of polyuria, because the diabetic urine attracted ants. Mellitus literally means like honey. So the terminology of diabetes mellitus came. Now these two German scientists, Oskar Minkowski and Joseph von Mering, are credited to the fact that they discovered pancreatectomized dogs developed a physiology similar to diabetes, that is, they developed hyperglycemia. Now coming to the actual story of discovery of insulin, the previous slide I showed you, the German scientists actually found this association in 1880s. Since then, as soon as this thing was published, scientists had been interested in using pancreatic extracts to treat the diabetes, but none of them was successful. Now, this young gentleman, Dr. Frederick Banting, he was a Canadian doctor. He had just returned from World War I. He was actually interested in pediatric orthopedics. But his mentor, Dr. Miller, asked him to make a presentation on carbohydrate metabolism. And when he read the papers, he got interested in this carbohydrate metabolism and pancreas and the relationship with diabetes. So he came up with an idea to again use pancreatic extracts to treat diabetes. But what he hypothesized was, because the pancreas has digestive enzymes within it, it has trypsin and other enzymes which digest the proteins. So when the other previous scientists were using pancreatic extracts, they were not separating the trypsin from the active endocrine part. So it led to destruction of insulin, and none of their experiments were successful. So with this hypothesis, he went to Professor J.J. McLeod, who was he was a professor of physiology at University of Toronto. And initially, Dr. McLeod was skeptical, but after a lot of persuasion, he did agree. And what he gave Banting was a dingy little room as a lab, a very small room, and 10 dogs on which already some experiments had been done. And he gave him a stipulated time of 8 weeks. Can you imagine, just 8 weeks for discovery of insulin? So Banting accepted it, but the one good thing McLeod did here was, he knew that Banting had literally no research experience. So he asked for volunteers from his students, from McLeod's students, to assist Banting. And thus was introduced the famous Dr. Best. He volunteered to help Banting in his research. Though they could not complete it in stipulated time, what they did was they ligated dog pancreatic ducts just enough that the exocrine parts get atrophied, but the endocrine part still survives. And they used this pancreatic extracts to inject among already pancreatectomized dogs, and they found that actually the blood glucose level did come down. So they repeated this experiment in various ways. They tried to isolate and purify the substance which they got from pancreas. They initially called it iletin because they supposed it was secreted from the islet of Langerhans. They initially called it iletin. And when this news reached Professor J.J. McLeod, he helped them one step further. He introduced them to Dr. J.V. Collins, who was a biochemist. He came into the picture now, and he further purified the extraction of insulin. which helped in ultimately in 1922. So insulin was first discovered in 1921. The discovery was reported by Dr. J.J. McLeod in conferences for the first time on 14th November 1921, exactly 100 years from today. And in January 1922, this young fellow, if you can imagine, this is a 14-year-old boy, Leonard Thompson, he was almost at the verge of death from type 1 diabetes. The treatment before insulin for type 1 diabetes was starve the patient. They literally kept the patient on calories of 400 to 600 calories intake. A patient of diabetes who is already getting emaciated because of a disease, they further restricted the caloric intake. So he was almost at the verge of death when after proper consent and all, they injected him with insulin, and within a few months he started showing improvement and he survived. He actually survived till the age of 27 years. This is a young Leonard Thompson. He ultimately died 13 years later because of pneumonia, but still his lifespan was increased by a further 13 years. Now this news started spreading. They started, but the way these our scientists were producing insulin was not sufficient to meet the patient load which was presented to them. So Eli Lilly came up. It came up with the offer that they will produce insulin commercially. In return, they gave donations to the University of Toronto for furthering their research. Now, when this spread in the American continent, this Dr. August Krog and his wife, Dr. Mary Krog, were present in the US. Dr. August Krog was already a Nobel laureate. He had received the Nobel Prize for actually discovering what happens to the capillaries and arterioles within the muscles during exercise. So when they heard about insulin, they offered to take this back to Europe. He, along with Hagdon, I'll talk about Hagdon in a little while, laid the foundation of what today is Novo Nordisk, which took over the insulin production in Europe. So since the discovery of insulin, there have been 4 Nobel Prizes awarded for issues related to insulin. The first, as we know, in 1923. Surprisingly, it was not Best, it was Banting and MacLeod who got the Nobel Prize. There was a lot of academic controversy at the time, but very generously, Banting shared his Nobel Prize with Best and MacLeod shared his Nobel Prize with Collett. In 1958, Dr. Frederick Sanger was given the Nobel Prize for isolating the amino acid sequence in bovine insulin. In 1964, Dr. Dorothy Hodgkin was awarded Nobel Prize for identifying the 3D structure of the insulin. And lastly, in 1977, Dr. Rosalind Yalow was awarded the Nobel Prize. She had discovered the radioimmunoassay to assess serum insulin levels, which helped them properly differentiate between type 1 and type 2 diabetes. Now, this is a timeline you will commonly see in most of the presentations related to 100 years of insulin. I already told you 1921-22 when insulin was discovered. Now, first human recombinant DNA technology, insulin produced by recombinant DNA technology came in 1982. And since then, there have been multiple advances in insulin therapy. I'll not go into the very details of the biochemistry of insulin. We all know it has one alpha chain, one beta chain, and the number of amino acids. All of you are aware of that. Just remember that insulin is not present as monomers. Two insulin molecules join to form a dimer, and then 3 dimers join to form a hexamer, which is present in the beta cell. This beta cell, when it secretes insulin, hexamers are broken down and secreted as monomers. So these monomers go and directly act upon the insulin receptor on target cells. But what happens when you inject insulin exogenously is you are giving hexamers. It takes time for these hexamers to dissociate into dimers and then monomers. Ultimately, monomers are the one which go into the circulation and act on the target cells. So here is the delay part which comes when we give exogenous insulin. You can see in this graph, this is the normal. The blue graph is the normal insulin response, the human body insulin response to a meal. And you can see in this, the red line shows the, when you inject exogenous insulin, you can see that the peak is delayed. And because of slow release, the duration of action gets prolonged. So this is the graph I'll be showing you repeatedly in the coming few slides. how the action of insulin is studied in experiments is there is a pharmacokinetic profile, there is a pharmacodynamic profile. Pharmacokinetic profile is the subjects are given insulin and then you plot serum insulin concentration against time. The other one is pharmacodynamic profile. This is something known as euglycemic clamp. You give insulin and then you start the subject on glucose infusion to maintain the serum glucose within a narrow range. So when the insulin level rises, you obviously will have to increase the glucose infusion rate. And as the level of insulin falls, the glucose infusion rate will decrease. Now coming to modified insulins, I told you the first shortcoming was the initial insulin which was discovered was given as short acting. They had to give multiple injections. And since the very beginning, we have been trying to mimic the physiological insulin response. I told you about Dr. Hepburn. He was the first one to, he found that the fish trout, its semen contain a certain substance called protamine. And when he added this protamine to the insulin injection, it prolonged the duration of action of the insulin. You can see this is the pharmacokinetic profile. You can see the peak is smaller and the action is prolonged. So this is came to be known as NPH insulin, which we are still using in our country. And he was one of the founder persons of Novo Nordisk. Now, why was there a need of further insulins? See, this is the dotted line shows the normal insulin response again to a mean, and the gray line shows when you inject the patient with regular human insulin. So you can see the difference between the peak and the duration action. That's why there was a need for a more rapid acting insulins which mimic the physiological profile. The fast acting analogs, mainly Lispro, Aspart, and Blulicin, have been approved within a span of 8 years. They have been there for almost 20 years now. But the latest one which was approved by FDA was the fast acting aspartate. The faint blue line, I don't know if you're able to see, but there's a faint blue line which is the most close to the normal physiological action of the urine. There is another ultra rapid acting Lispro which has been approved in European Union but not yet been FDA approved. Now coming to long acting insulins, as I said, we had to give repeated doses of short acting insulin. So we needed a long acting insulin to mimic the normal basal insulin secretion in the human body. So the first one to be approved was Glargine in 2000. They made certain tiny adjustments in the amino acid sequence. What happened was the insulin gets precipitated in the subcutaneous space, and from this precipitate, it is slowly released into the circulation. So this gives you an almost peakless insulin with a duration of action of more than 24 hours. Later, the Detamir was approved. Detamir, again, some side chain modifications led to the formation of dihexamers, and after it was released as monomers, it binds to the albumin, which further delays its clearance from the circulation. Similarly, there is Degludec. Degludec, they form multi-hexamers in the injection, and again, when the monomers are secreted, they bind to the albumin, prolonging their duration of action. Degludec currently is the most long-acting insulin available. Coming to premix insulin, the point of premix insulin was to reduce the number of doses of insulin the patient takes. So this is human insulin 30/70, in which 30% was regular and 70% was an intermediate acting insulin. You can see the peak of insulin here is peak has reduced because the concentration of regular insulin is 30%. Here it is 100% regular insulin. Here the regular is only 30%. So the peak has become small, but the duration has increased because of the addition of intermediate acting insulin. Similarly, it has been for Lispro 25/75, and Degludec aspartate is the only analog combination available right now. There is a combination of aspartate 30% with 70% of Degludec. Again, you can see a similar profile of action. The peak is small because it is a rapid acting insulin. It has an early peak, and then there is a prolonged duration because of Degludec. Coming to higher concentration insulin, this has been there in use since long. In 1980s itself, the first 500 units per ml insulin was introduced. The initial insulins were 5 units, 10 units per ml, 40 units per ml. In India, we still use 40 units per ml, but mostly worldwide and the newer insulins which are available as 100 units per ml. Now, what you have to remember is this 500 regular insulin is not the same as it is not just that you are increasing the concentration of the insulin, the time profile action of the insulin changes as well because it is highly concentrated. The concentrated insulin, the release becomes slower and the duration gets slightly prolonged. It almost starts acting like an intermediate acting. Similarly, for glargine, 300 units per ml, which has again been recently approved. Again, it is not the same as 100 unit glargine. You can see this is for 100 units per ml glargine, and these are various doses of 300 units of glargine. To produce a similar effect, you have to give a higher dose of 300 units per ml glargine. But the benefit of 300 unit glargine was, one is decreased concentration, another was it reduced hypoglycemia. So it is said when you're shifting the patient from 100 units per ml to 300 units per glargine, per ml glargine, the dose requirement goes up by almost 12%. Coming to alternative routes, this here is the Exubera device. Sorry, this should be inhalational insulin. Exubera was first approved in 2007, but because of the bulky device, it was not much popular among the practitioners or the patients. So though it was data-wise it was successful, it did not come much into use in the public. Now, Afrezza, we have all heard of Afrezza, was approved in 2014. Now, see, this is a compact device, a tiny little instrument. You have to put cartridges, 4 units, 8 units, and 12 units cartridges are available. And again, you take it by inhalational route. The problem here was there were pulmonary complications. There are some reports of pulmonary fibrosis, hypersensitivity. But the point here is it is a very short acting duration because the absorption is through a vast surface area and it is a relatively rapid absorption. The duration of action of this insulin is hardly around 2 to 3 hours. Coming to oral insulin now, all of us hate injections. So when insulin was first introduced, the main drawback was, do I have to take so many injections per day? So insulin was introduced in 1921. Since 1923, people have been trying to make the ideal oral insulin. But the problem with oral insulin is, number one, the bioavailability, because it is a protein, it is highly susceptible to enzymatic digestion within the GIT. Plus, there is food dependence. If you take insulin along with food, the absorption gets decreased. If you take it before food, keep a good gap between food and insulin, the absorption increases. But then that won't be physiological. You give insulin, oral insulin 1 hour before meal, the patient will have early hypoglycemia and later on will develop hyperglycemia. So these are the constraints. But despite that, there have been trials. There was Trigopil, there was ORMD 801. These were oral bolus insulin. Trigopil did not succeed in trials. ORMD 801 also did not show much promise. There are around 15 trials which have already, some have already been completed, some are still ongoing for ORMD 801. But till now, the published reports does not show much promise. Now, I338 or insulin 338 is a basal formulation of oral basal insulin formulation. Because it will be a long-acting insulin, we can remove this component. Food dependence can be removed. This is based on GPET technology and nanotechnology, which will delay the release of insulin in the GIT. So when you take, you can see in this study, they showed that I338 and insulin glargine, the profile was almost similar. It did bring down HbA1c level, though fasting hyperglycemia was not much reduced, but HbA1c level did reduce. But again, the dose was very high to produce similar effects, and the cost of production is very high for this. So till now, it has not come to clinical practice. Then briefly, I'd like to mention about the future of insulin. Probably very soon we will see once weekly insulins being introduced into the market. Icodec, which is currently in phase 3 trials, is basically insulin degludec with a 80 carbon fatty acid side chain attached to it. It has a half-life of 7 days. You can, because it has a long half-life, to produce a steady state, it is better if we give a loading dose. The loading dose, the first dose which we give is usually double the dose and then followed by normal dosing every week. So in this study, it was shown that it has effects similar to glargine, once daily glargine and once daily icodec. The results were similar in reducing HbA1c levels. The hypoglycemia levels were also less. But the constraint of once weekly insulin is you can titrate the dose only once a week. Now this is another once weekly insulin, basal insulin FC, which is insulin attached to a FC component of immunoglobulin. Again, you can see it has effects similar to that of degludec, but it is still in studies. Coming to hepatopreferential insulins. Now, what is the concept behind giving insulin to the liver? So this is the normal physiology which happens. When you eat, the pancreas secretes insulin into the portal vein. From the portal vein, the bulk of insulin goes to liver and it acts on hepatic glucose production and hepatic glucose output, and then it goes to systemic circulation where it acts on the skeletal muscle or peripheral target. But when you give insulin exogenously, it is first going to go into the systemic circulation and less is going to the liver. So the concept was, if we give insulin directly to the liver, maybe the physiological profile of the insulin will be better. Now, one way to solve it is giving oral insulin because it will directly go to the portal circulation. But as I told you, the studies are still on. The other ways were pegylated insulin lispro. Now, there have been 7 trials, namely IMAGINE trials on pegylated insulin lispro. And it did show promise. It showed that there was lesser weight gain, there was lesser hypoglycemia, HbA1c targets were reached. But the problem was the level of liver enzymes went up. And there were more of injection site lipodystrophy and elevated TG, elevated liver fat. So again, these could not be brought into commercial practice. Then there is this new concept, studies are still going on, in which there is hepatocyte-directed vesicle lispro. This is again based on nanotechnology. A part of insulin which is injected is bound to such a compound which has preference only for hepatocyte receptors. So a proportion of the insulin which is injected will go directly to the liver and act only on the liver. Again, we can see that the level of hypoglycemia events are almost less or comparable to the conventional insulin. Now coming to glucose responsive insulin, or this will be the holy grail of treatment of diabetes, almost like artificial pancreas. The concept again is similar. You keep the insulin molecules in between, surrounded by a compound which is glucose sensitive. Whenever the glucose level in the body goes up, the coating will break down, it will release insulin, insulin will act, and once the blood sugar comes down, the coating will again get reformed and insulin release will decrease. Though the concept seems very simple, it is very difficult to devise actually. The challenges are, you have to maintain the blood glucose in the normal blood glucose range in the body is very narrow, somewhere between 70, 80 to 140. The second thing is, you have the glucose sensitive moiety which surrounds the insulin must have a very high selectivity and affinity for a relatively small molecule. Glucose is a very small molecule. Your glucose sensitive moiety should only react when it gets glucose. The third thing is lag in activation and inactivation of insulin. Most of the glucose responsive insulins have been tried as transdermal patches. So when you give insulin to the subcutaneous tissue, your capillary blood glucose has to reach the subcutaneous tissue. Then the glucose will be sensed by glucose sensing moiety. Insulin will be released again to the subcutaneous tissue and from there to the circulation. So there will be a lag of some time before to mimic the physiological response. Despite these constraints, this MK2640 was tried in trials. Though it showed promise in animal trials, in humans it did not produce an expected response. As I was telling you, this is a transdermal patch. The basic is there is a micro needle array patch. Within the needles will be these nanoparticles which have both insulin in the center surrounded by glucose sensitive moieties. Whenever the glucose will go high, insulin will be released, and when the glucose comes down, insulin release will be stopped. Now, these closed loop systems are not exactly in the future, they are already in use. We all know about insulin pumps, which secrete insulin in a continuous fashion into the subcutaneous tissue. Now, this insulin pump is synced with a continuous glucose sensor or continuous glucose monitoring device by either you can use a smartphone based application, or there can be direct link between these two And there are specific algorithms. This sensor will sense the blood glucose level. It will send the blood glucose level to the algorithm. The algorithm will calculate how much insulin is to be secreted, and this pump will secrete the required amount of insulin. So to conclude, I'd just like to say that the discovery of insulin was not just path changing for diabetes, it was path changing for the entire of science, medicine itself, because it was the first molecule whose amino acid sequence was identified. The enzyme assays for picking up hormone levels was devised with this, and a lot of insight into the molecular biochemistry came with this. And though it has been 100 years since the discovery of insulin, the ideal insulin still eludes us. These are my references. Just to conclude, these are few of the famous celebrities with diabetes living who actually take insulin. This is ex-British Prime Minister. You can actually see she has a CGM device attached to it. Thank you.
Thank you, Dr. Rohini. You started this with a story of insulin, but basically it was a story of hope. And hope has really been kept by science. And from the ages when the people were afraid of going outside because they has to take injectables, insulin, now we have got insulin pens. And
But actually, I skipped a very interesting story because
time was not there.
constraint.
And with non-injectable insulin in life, definitely we can hope for the say non-injectable era where the insulin can be given and the patient can enjoy as normal as possible. Really, thank you for your presentation. Now I will like to hand over this to Dr. Biplab sir.
Thank you, Doctor. So the next session is by Professor Dr. Sujay Ghosh. Am I correct? So Dr. Sujay Ghosh is an eminent endocrinologist of India. He is a professor of endocrinology in Kolkata, IGMER and SSKM Hospital. Sujay Ghosh has got more than 258 publications, as I was seeing yesterday in his research gate, and he has got original work in the genetics of medicine. So Dr. Sujay Ghosh, as you see, he is DM endocrinology, FRCP, and professor of endocrinology. He is secretary, national secretary of Endocrine Society of India, and he did a lot of job in democratization of the society. And he is National Joint Secretary of Thyroid Society, National Joint Secretary Research Society of Study of Diabetes in India. So, Dr. Sujay, can you listen to us?
Yes, I can hear you, Biplab.
Yeah. So, Sujay, our deep affection to you for your accepting this invitation, and it is honor to me that I could chair this session. So Sujay Ghosh has got many original work in HbA1c. We may think that HbA1c is a simple term and it has got a normal value of 6.2 in non-diabetic, and when it is more than 6.2, patient is diabetic. But he has got original work how to interpret HbA1c in different situations and in different age groups. So all these questions are with us, and Dr. Sujay will address us. Thank you. Dr. Sujay Ghosh, please.
Thank you, Biplab, for that very, very kind introduction. It's always a pleasure to see you, if not at least physically, at least virtually. And a big thank you to Amrita, who has been our wonderful DM trainee when he was with us at IPGMER Kolkata. So I've been given about 20-25 minutes at the most. I'll probably spend 20 minutes to talk about interpretation of HbA1c. And like Dr. Bandyopadhyay has stated, we sometimes oversimplify interpretation of HbA1c. And the talk today is predominantly going to talk about HPLC method of looking at HbA1c. Though let us all accept that there are several other methods, and I'm going to just touch upon them, which are also important in measurement of A1Cs, particularly in certain circumstances. And more importantly, I will try to show you a few illustrative cases where we tend to go wrong in the interpretation of tests. Because a lot of time when the patient comes to us with an HbA1c report, the front page has the report which is printed of the A1C, and then you have a graph which a lot of us struggle to interpret. So I'll try and share some of the graphs, but I'm not very sure what the clarity would be of these graphs. Hopefully, we'll be able to bring out a book in the near future soon of tests of glycemia where we will be able to redraw these graphs with better graphic designers rather than straight from the patient's reports. So we all realize that A1C plays a very central role in the management of diabetes. The importance is derived from the results from major studies with what started with the DCCT, the UKPDS. Now we know that this is a very, very important test, and almost every major national and international guideline addresses this and uses this for diagnosis as well as making recommendations for management of diabetes. Now, going back, if you look, first time A1C that was described was in the year 1970s, and it was only first available commercially as more of a research test in 1978. But it was DCCT trial which actually brought about a radical change in the way we look at A1Cs. And only as late as 1994, the ADA started recommending target values of A1Cs. And it was included as a diagnostic criteria only about 10 years ago for the management of and diagnosis of A1C, of diabetes. So we've got to know certain basics of chemistry. Hemoglobin spontaneously with glucose reacts to form a glycated derivative in a non-enzymatic manner. And if you look at hemoglobin, when we were taught in our physiology days, you have adult hemoglobin, which is predominantly HbA, which is 97%, and you have HbA2, which contributes to about 2.5%, and fetal hemoglobin in adults is very, very little. Now, if you look at adult hemoglobin, that the bit here, that's 97%, you can look at it and see that part of it is glycated, majority is unglycated. So about 5% of HbA is glycated, which leads to HbA1a, HbA1b, and HbA1c. So A1a and A1b, because the proportion of fractions are relatively smaller, we tend to concentrate on HbA1c. Now, there are various nomenclatures which we tend to use interchangeably, which is not actually correct. So if you're talking about total glycated hemoglobin, you're talking about A1A, A1B, A1C, but we are going to talk only about A1C. And that's the order of elution when you're doing a chromatography. And the hemoglobin molecule forms a stable adduct of glucose to the N-terminal valine of the hemoglobin beta chain. Now, remember, because of the specificity of this reaction, immunoassays have been developed to measure HbA1c as well, which would be relatively specific to look at that bit of HbA1c. Now, talking about the chemistry, you have glucose and you have hemoglobin. Once the two react, you have the formation of a Schiff base or an aldamin. Remember, this is very labile. And with time, this then progresses to the formation of an amidary product, which is a ketoamine, which is the stable HbA1c. Now, why did I bring up this particular slide? It is because if you suddenly see that there is a rapid, dramatic change in blood glucose levels, particularly, there might be a high amount of labile HbA1c, which might be measured when you are doing an HPLC to measure A1C. So labile A1C usually denotes rapid changes in glucose levels, rapid changes and formation of albumin without formation of a stable ketoamine. So if you look at an HbA1c today, we know it tells us what has happened in the last 3 months or so, but with predominant effect from what has happened in the last 1 month. So the weightage of A1C has been shown in this demonstrative slide to show that it's almost about 50-52% of what's happened in the month before, about 27% from what's happened the month before that, and about 15% of what's happened the month before. The reason is very clear, because RBC has a lifespan of 120 days. So accordingly, depending on the number of RBC proportion which are there in the circulation, you would expect this kind of contribution to A1C. And there are studies to show that the estimated average glucose correlates very strongly with A1C, but this is mostly Caucasian data. We have relatively less Asian data to actually reconfirm this particular statement. And there are formulas to tell us that if you look at A1C, this is probably the estimated average glucose. You will find in the report often estimated average glucose is stated, but remember, one of the things is that this rate of glycosylation is individual dependent, racial variations, and ethnicity dependent. So some people might be fast glycators, some people might be slow glycators, but overall, this is what you would expect the average glucose to be like. Now, when you're looking at assays by which you can estimate HbA1c, there are several methods of doing so. The first set is the charged base assays. And in that, excuse me, HPLC is the commonest method. It could be a structure-based assay in which boronate affinity chromatography is often used, particularly in patients with chronic kidney disease where there might be problems. And immunoassays are also being used in clinical practice. Up to 2007, everybody talked about A1C as a percentage. We in India still talk about A1C as a percentage, but this consensus statement of 2007 probably has dramatically changed the way we actually look at HbA1c. And you will see that the newer labs are also now reporting, as the IFCC has told to report, as millimoles per moles in the brackets as well. Why is that? And I'll tell you a story. So I told you already that it was the DCCT which told us that how important HbA1c was. Now, the DCCT trial was conducted in 32 centers, and each of those 32 centers had a different way of measuring HbA1c. Now, the center that contributed the highest number of patients, he had the greatest clout. So, uska dadagiri chalta tha. So he said, please report your A1C reports from your center as if it was done by my method. So other people were doing A1C by the other different methods and reporting that as if it had been reported by that particular center of DCCT. So therefore, you will often see this word written DCCT aligned. So it was not on the basis of science, because what was measured was actually poor science, and it actually gave a value of 2 percentage points greater than what the actual reading would have been. So when we are saying today that your target HbA1c is 6.5% or 6%, if you actually measure HbA1c by the currently available IFCC method, it will be 2 percentage points lower than what we are reporting. So what are we doing now? We are actually using good machines, good science, measuring a value, and then recalculating and giving a value of what it would have been had the older non-scientific value had been utilized. So that is the reason why IFCC said that it is best that the newer machines are measuring in millimoles per moles. So you report that as millimoles per moles. So therefore, the newer readings with the IFCC method is standardized. But now there is a problem. Until yesterday or the year before, everybody had reported clinical trials with certain targets of A1Cs, certain values of A1Cs. Now overnight, if you say, kal jo 6 tha, aaj se wo 4 hai, then you will create huge confusion and huge mess. Therefore, what IFCC said was that you have to actually go for dual reporting, at least for a few years. So you will report it as percentage with the older system, and you will report it as the millimoles per moles. This is an editorial that I wrote with my professor when I used to work in the United Kingdom in diabetic medicine. And we talked about the positives and the negatives of this sudden changeover that's probably going to affect the world of people. Now, let me try and teach you a small trick how you can convert the current method of percentage and say what it would have been had you been using the correct IFCC method. So if the HbA1c measured is 5, the IFCC method result is 31. So how do you get to that? So 5 minus 2 is 3, 2 minus 2 is 1. Put the digits together, you will get 31. So this is Kilpatrick's kludge, which is a trick. He was one of the co-authors of that particular article that I showed you, the editorial in Diabetic Medicine with me. So this is only valid for whole numbers. Now, if you have 5.5, this trick is not going to work, but at least it will give you some idea in millimoles per moles what the value would be if you are using the new methods. So with that background, let us look at a few HPLC data to see how things get reported, possibly even wrongly or interpreted wrongly. So this is case number 1. I'm not very sure whether you can read, but if you look at the graph that comes with it, you will see it talks about a peak, HbA1b, HbA1 unknown, labile A1c, A1c, P3, A0, a lot of things are there. And my arrow is pointing on something which says HbA1c is 20.1%. And the report at the bottom is given, as you can see in this particular small square, percentage A1c is 20.1%. So you will say somebody's HbA1c is 20.1%. That's so high. So you've got to remember, this value is above the linearity of reporting for this particular system. And what do I mean by that? So whenever you are reporting any value in endocrinology, particularly assays, you create a normal curve and you say, you know, this, if this is there, then this is the value, this is there, this is the value. And you will see that the highest possible reported HbA1c by the Biorad D10 machine is 18.5. So that report of 20.1 is not possible. So it is like saying my machine can measure prolactin levels up to 500, and then you've given a report of 560. You can do that only after doing a half dilution and then recalculating and seeing whether that prolactin value is actually accurate or not. We agree that this particular patient has very high A1C, but it cannot report a value of 20.1. So whenever you're looking at HbA1c reporting of a particular machine, the clinical biochemist actually has to know what is the highest possible reading that is possibly being given by that machine. If there is a problem, then you have to go for a dilution and redo the test and reassess and figure out what the real reading would be like. Now, this is the second patient, and this is probably better read. Always try to look at that, all of those values that they are at the bottom. So you will see A1, A1, B, F is fetal hemoglobin, L, A1C is labile hemoglobin or carb hemoglobin, A1C, P3, A0, and then you see that there is something called an S window. Now, we already discussed that normally A0, that is total hemoglobin or A, is going to be somewhere around 90, 95, 97%. That you see here is only 50%, where there is a window of abnormality, which is shaded here, which is almost about 38%. So essentially, this is sickle cell disease. The machine has picked up it as S window. In most of the times, whenever you have variants in the hemoglobin, it will come up as variant window. So always look at the variant window to tell you if there is abnormal hemoglobin. So this is essentially sickle cell anemia. Now, the machine with which we most commonly do hemoglobin A1c assay is the Biorad D10 machine. This is the same machine with which we do HPLC for thalassemia screening. There are two modes that are there on the machine. One is for hemoglobin A1C and the other is for hemoglobinopathies. Whenever you find that there is a variant window in the graph of the HbA1c, you should run the same sample on the other mode. That is called the A2 mode for looking at variant hemoglobins. Because in this part of the country, whether it is Chhattisgarh, whether it is Bihar, whether it is Bengal, almost about 8 to 9% of the population will have some kind of abnormality. I'm not saying it is homozygous, but heterozygous abnormality of hemoglobin disease. Looking at the next patient, now you would have already been wiser after seeing the previous graph. You can see A0 is 46.8%, and below that you can see variant window is 40.8%. So straight away, you know the interpretation of this HbA1c is wrong, that there is some kind of variant, therefore it is interfering with the HbA1c assay. A few more cases. This is something which is dramatic. You see the HbA1c is 0%. This is a very, very specific kind of hemoglobinopathy that we see in India, particularly in Eastern India. This is hemoglobin E disease. Hemoglobin E disease in the electrophoresis elutes exactly at the same point where HbA1c normally would have eluted. Therefore, if you suddenly see somebody's got an A1c of 0, you do the A2 mode on the biorad machine, you will see a very big black peak of hemoglobin E disease. And you can see the variant window tells you that 85.9% is variant hemoglobin. Again, if you, let me just move this bit. You can see here the fetal hemoglobin. Can you see the third column, F? The fetal hemoglobin is 15.5%. Now, one of the things that you've got to know about your machine is if you go onto the IFCC or NGSP website, it will tell you everything about whatever machine your particular lab is using, because you have to be aware of the machine that your lab is using in the reporting. And for example, the Biorad D10, which is probably used in 80 to 90% of the labs in India, if the bilirubin is above 20, you will know that there will be interference. If the triglyceride is over 5,680, there will be interference. If the fetal hemoglobin is above 10%, there will be interference. If the labile hemoglobin concentration is more than 4%, there will be interference. If the carbamylated hemoglobin is more than 3.5%, there will be interference. So it is important to know that these substances will actually interfere with the hemoglobin assay. Right, I'll skip this bit and move to the next slide. Now, this is an individual where I have tried to demonstrate that, you know, it's very difficult for the lab person, that the biochemist also, to interpret hemoglobin A1c on their own. And we as doctors, we are bad in communicating with them. We don't speak to them. If you look at this individual has got very low hemoglobin to start with. So because probably the patient has had a recent GI bleed. So if the patient has lost so much of blood, if you look at the hematocrit on the hematogram on the right side, it is therefore not surprising that this diabetic individual has come up with an HbA1c of 2.7%. So it's not just that you look at the graph, you look at the table and you say this is the right interpretation of the glycemic control of the patient. Then there are various problems which could lead to inappropriately low A1c and inappropriately high A1c. I have tried to highlight some of them. Always remember blood loss, chronic anemia, B12 deficiency, alcoholism, iron. All of these can actually lead to problems of interpretation of hemoglobin A1c. And amongst the drugs, there are certain drugs that actually we have to remember, particularly the antiretroviral are very important. Dapsone, which fortunately we are now using less. Ribavirin, we are still using, my hepatology colleagues are using. And the vitamin C and vitamin E last year particularly was a menace. Actually, I had a case which I thought I would put up here, where the person was on very high doses of vitamin C, thinking that will prevent COVID in that individual, came with a very low HbA1c. Now, this is again a very interesting case. Now, here you see the hemoglobin A1c has come as 54.2%. Now, what could this be? Now, this is one of the case reports that we published, and we actually went back to the family. I managed to trace the family back to Kerala. there is a particular hemoglobin called hemoglobin hope disease. There, the value actually eludes along with the HbA1c. So what you are measuring as HbA1c is actually not HbA1c, it is hemoglobin hope disease. Now, this is again another patient where you've got hemoglobinopathy. As you can see in the variant window, it is 53.2%. This is hemoglobin D or hemoglobin Iran disease. Like I said, whenever you have a variant window, you're supposed to actually run the hemoglobin HPLC assay for detection of hemoglobinopathy. Again, this is another patient where you can see that labile HbA1c is very, very high. You can see 26% is labile HbA1c. Therefore, you know that this reading is particularly wrong. So what are the circumstances where you suddenly get labile A1c very high? Say someone had an HbA1c of say 10, 12, 13, and then all of a sudden you have started intensive glycemic control. You might find, because of the basic biochemistry that I talked of, you might have a labile shift base, which contributes to this abnormality. This is also seen if carbamylated hemoglobin is very high, which is seen in uremia or chronic kidney disease. So I've already talked about that. Then there might be disorders of persistence of fetal hemoglobin. This patient, for example, if you see fetal hemoglobin is 25%, and I've already told you the particular assay that we use, there is interference when the fetal hemoglobin percentage is more than 10%. Now, coming towards the end of my presentation, this is a 48-year-old lady, known diabetes for 12 years on basal bolus therapy, admitted for hysterectomy. If you look at the HbA1c is very high, surgeon has called you to review the patient before the gynecologist will actually operate. But if you see the patient, the average, glucose, if you look at the fructose, I mean, that's not bad. And even if the CBG readings that you're looking at is not that bad, then why is the disparity? So if you look at the hemoglobin is only 7.5. The individual has iron deficiency anemia. God is intelligent and has made sure that this lady survives by prolonging the lifespan of the RBC. So this 7.5 hemoglobin is an iron deficiency anemia. The RBC has survived in the circulation for a very long period of time and therefore has undergone more glycosylation and inadvertently is giving you a reading of excess HbA1c when things are not that bad. So HbA1c can be falsely low if there is decreased RBC lifespan, hemolysis or erythropoietin therapy, or it can be falsely high, for example, in iron deficiency anemia, acidosis, and hemoglobin carbamylation, which I showed in the previous slide. They are not acutely altered with either hemodialysis or peritoneal dialysis. So I will finish by saying a few things. We often misinterpret or make mistakes because we are not talking to our colleagues. We are not communicating to our colleagues the history. The clinical biochemist is our friend. We need to speak to him, discuss with him, because there'll be a lot of things that he will be able to help us with. The history and the background of the patient is very, very important. And, we often have this problem of saying, this I cannot explain with the patient and therefore it must be a wrong report. Not necessarily. Maybe we are not being able to diagnose something. And it is always okay to accept, to say that I am uncertain of the results. Use appropriate technology. You can go for a SMBG. You can go for a CGM where you are thinking that things are wrong. And I have only presented to you of cases that I was personally able to solve. There must be other issues that where I have not been able to solve and figure out what the problem was in the disparity of the report and the clinical presentation. I shall stop there. Thank you very much.
Thank you, Dr. Sujay Ghosh, for excellent presentation, deliberation, and making us understand HbA1c, which we think that it is so simple. My question is that where HPLC method is not used and we are getting the reports, should we absolutely deny those reports accepting?
No, I don't think so.
Approach?
Sir, if you are looking at serial reports, irrespective of what methodology is being used, it should give you at least some idea of what is happening. And amongst the immunoassays, Roche now has an immunoassay which is like a chemiluminescent assay. which is very, very specific, which is relatively cheaper than our biorad machine. And why I am bringing this up is because particularly in the smaller centers, smaller towns, people might have a center where there is a chemiluminescent assay to do thyroid hormones.
Right.
People might not have another ability to buy another HPLC biorad machine or some other machine. With that machine itself, you can do very good immunoassays. So those immunoturbidometric methods or immunoassay methods are not to be discouraged. We should probably at least utilize them sensibly. And like I said, the report means nothing, whether it's an HbA1c with an HPLC or another method. The story has to match the clinical presentation, the history, the medication has to match with what you're looking at in the report. And then we make clinical decisions.
Thank you. Thank you. Any other questions? Yeah, please.
Sir, it was an excellent presentation and has sorted out many of problems that we face. I am a nephrologist and I wanted to know what is the take on HbA1c when dealing with patient with advanced kidney diseases. So many
Right.
a time we see there is a lots of disparity between the blood glucose with the patient. They come with hypoglycemia, repeated episodes of hypoglycemia, but HbA1c may still be high. So how to explain those things?
Right. Thank you very much. I think it's an excellent question. And I think nephrology is one area where HbA1c can be highly fallacious because of multiple reasons. Now, you might be using erythropoietin in that individual. That could be one area of problem. The individual might be iron deficient, because that you see a lot of times. Even before you start the erythropoietin, you will see a lot of them are having iron deficiency anemia, anemia of chronic illness. That will be there. And they will have higher levels of carbamylated hemoglobin. That again is another source of error. So what I would suggest, and this is not just for nephrology. See, in day-to-day clinical practice, what do we normally tell our patients to do? We ask them to do a fasting and a post-meal, right? If I find that those readings are wrong, abnormally high or abnormally low, I don't even ask for an A1C. I ask for an A1C when my day-to-day SMBG readings are relatively okay. Now I want to know the fine tuning. Okay, I have checked it for 1 week and I'm seeing that the fasting is okay, post-breakfast is okay, pre-lunch is okay. But I want to know, has it been okay all through the day for the last 3 months? I would use that as a clinical guide for management in most of my patients and not bank on A1C. So day-to-day home readings are perhaps even more important than doing an HbA1c. Unfortunately, because in India, people maybe think that the glucometer is too expensive or costly, they would go and spend something like 1,000 rupees in one go for an A1C, but not buy a glucometer and do tests for 20 rupees. So I would go more by the home readings. Now, the situation that you're talking about is very common. Patient with kidney disease comes to us with high A1C with hypoglycemia. That means this patient is having high fluctuations of glucose reading. Do a 6-point or a 7-point home glucose readings, figure out what is going wrong. The other challenge and the issue with nephrology patients that we face is patient might be undergoing hemodialysis 3 days a week and then not going dialysis on the other 4 days. So you have to have 2 sets of SMBG charts, one set for the days of dialysis, one set for the days of no dialysis, and accordingly adjust your treatment regime depending on whether it's the dialysis day or whether it's the non-dialysis day. Hope that answers at least some of the issues. There are multiple issues actually.
Thank you, sir. Thank you, sir, for such an informative thing. Actually, we are just thinking HbA1c is so simple, but even interpreting HbA1c, we can find out many rare diseases also. It's not only in diabetes; it is helping. It can rather help in other diseases also. Thank you for such a nice presentation, sir.
Thank you very much.
Now I would like to invite Dr. Vinay Rathore, sir, and he will be talking on diabetic kidney disease and non-kidney disease. Earlier we had someone was telling that each and every Indian, rather Asian, is diabetic. Otherwise, if it is not proved that he is not diabetic. So when diabetic patients are with us, we actually try to attribute all symptoms secondary to this diabetes. It is not like that. Even a diabetic patient can have urinary symptoms because of other illness. And this Dr. Vinay Rathore will be putting more light on this thing. Vinay Rathore sir is working as assistant professor in Department of Nephrology here in AIIMS Raipur. And his primary research interests are in chronic kidney disease of unknown origin, peritoneal dialysis, and tropical nephrology. Over to you, sir.
And at the same time, I'm Sir and his team for inviting me to deliver this talk. So I'll be basically talking about, as the chairperson have already said, about non-diabetic kidney disease in patients with diabetes. So it's a problem not only for the nephrologist, but for the general physicians as well as endocrinologists, as well as for all the medical fraternity. Particularly, we have a tendency that anything related to renal issue in a patient with diabetes is usually labeled as is attributed to diabetes disease itself. And because the population of diabetes patient is such a large one, that many of the non-diabetes kidney diseases may occur in these patients. Therefore, one has to remain extremely vigilant to diagnose these disorders. So we all know that it's very commonly known that diabetic nephropathy is probably one of the most feared complications of diabetes, and probably more feared by the patients than even the cardiovascular outcomes. This disease is much more feared. So kidney disease is probably much more feared as compared to cardiac diseases in patients with diabetic nephropathy because of the stigma associated with chronic kidney disease, which is very well known. And obviously, it's one of the leading cause of chronic kidney disease worldwide. Not just the end-stage renal disease, but in fact, it is a very important predictor of cardiovascular mortality. So a patient with diabetes and CKD has much more higher incidence of going into dying because of cardiovascular illness rather than having to go a dialysis procedure or end-stage renal disease. So cardiovascular mortality is particularly high, and obviously prevalence is increasing, which we have discussed in the morning panel discussion. And to the tune of 40% of previous studies, now hopefully with the newer interventions, this number will come down, and in fact is coming down. But 40% of the patients are expected to have some sort of kidney disease among the patients with diabetes. So the prevalence says that about 34% will have some sort of diabetic kidney disease in these patients, and about 6.5 will have both impaired GFRS and albuminuria. So coming to what are the causes of renal dysfunction in patients with diabetes? So obviously one of the bigger chunks will be your diabetic kidney disease, but then there are so many other causes of renal dysfunctions are there, which are not because of diabetic kidney disease, but still are related to diabetes. So these are certain diseases are like this ischemic nephropathies, capillary necrosis, increased risk of infections, increased risk of acute kidney injury and contrast-induced nephropathy, atherosclerotic disease, which are very common in these patients. So these are all disorders which are intrinsically related to diabetes, but they are not diabetic kidney disease. So they are all can be caused can be present in patients with diabetes. And then there are a whole gamut of non-diabetic kidney disease which can also be present in this. So diabetic kidney disease, we all know that most of the time it is because of the damages in the early phase is because of hemodynamic alteration and hyperabsorption because of hyperfiltration of the sugars to the tubulointerstitial environment. And then finally, in the later on period is because of your remodeling phenomena. So this is predominantly the diabetes kidney disease, but in patients with diabetes, other causes like this has to be always been kept into mind, and then non-diabetic kidney disease as well. So then it becomes, so we now have a reasonable idea that renal dysfunction is quite common in patients with diabetes. then one is to determine whether it is due to non-diabetic kidney disease or diabetic kidney disease. So determining is one thing, and is quite often confused with your various terminologies which are in vogue among the medical practitioners. So one of these is diabetic kidney disease, which is preferred terms used nowadays. It is usually a presumptive diagnosis of diabetes in a patient of kidney disease in a patient with diabetes, and can usually be measured. Is usually just is a presumptive diagnosis, so it does not require kidney biopsy, but is managed is diagnosed on the basis of your measurement of urine albumin and creatinine ratio, and the measurement of serum creatinine, that is estimation of GFR. So we'll see how it is diagnosed, but it is most importantly to say that this is associated with classical as well as non-classical glomerular disease, tubulointerstitial disease, and microvasculature. On the other hand, the term which so commonly used is diabetic nephropathy, which should usually be a historical term used for type 1 diabetes patient who had retinopathy as well as albuminuria, and that corresponds pathologically to what is known as classical diabetic glomerulopathy. Now, again, the third term is diabetic glomerulopathy. Usually, it's a biopsy-proven thing used by the pathologist, and there is a whole gamut of classification classes. So class 1, class 2A, class 2B, class 3, and class 4, depending upon the light microscopic finding. The early diabetes can only be diagnosed with the help of electron microscopy, but then as the stage progresses, can be seen in the form of mild mesangial expansion. It can be seen in this slide, and then severe mesangial expansion, and then finally the telltale sign of diabetic nephropathy, the KW lesion and nodular glomerulosclerosis, which can be seen in these slides. So usually this is reserved for the pathologist. So knowing now, then we are clear with the terminologies. Then one is to know whether a patient has diabetic kidney disease or non-diabetic kidney disease. One should be knowing about the natural history of the disease. So this again has been taken from type 1 diabetes. Most of the time this will correspond to patients with type 1 diabetes where the onset of diabetes is exactly known. Not in the patient with type 2 diabetes, where you cannot be very sure about what is the onset of diabetes. So the stage 1 corresponds with glomerular hyperfiltration. In fact, at this time, the GFR will be increased at the time of the diagnosis, usually seen at the time of diagnosis. And usually the stage 2 or stage 2 is where you do not have much of albuminuria. The albumin is less than 30 milligrams, usually seen in the first 5 years of the diabetes, and corresponds to what is seen with the electron microscopy at this stage. The stage 1 of class 1 of the pathological classification. Stage 3 is from where the incipient and microalbuminuria starts. The albumin level goes up to 30 to 300 milligrams per day, the 24-hour urinary excretion. And this is usually seen between 5 to 15 years of your diabetes, having the diabetes, type 1 diabetes. Then finally, a progressive macroalbuminuria stage where there is a rapid decline of GFR to the tune of 5 to 10 ml of GFR decline per year, which is seen usually seen about 15 years after having type 1 diabetes. And then ultimately this fall in GFR leads to end-stage renal disease, where renal replacement therapy is usually required. Again, the similar thing, as you can say, this holds true for type 1 diabetes, and usually there will be microalbuminuria, the normal albuminuria, then there will be some microalbuminuria at about 5 to 10 years after the onset, and then there is persistent macroalbuminuria leading into end-stage renal disease. At the same time, the GFR may in fact be higher in the initial few years of the disease when there is hyperfiltration, and then there is, once the macroalbuminuria sets in, there is a very rapid decline of GFR leading on to end-stage renal disease. So this has to be kept in mind while dealing with diabetic kidney disease or non-diabetic kidney disease. So how do we know whether a patient with type 2 diabetes or any diabetes has some sort of kidney disease or not? So two most important tests are urine albumin excretion, which can be done by 24-hour urinary albumin excretion, or more easier will be, which is usually a cumbersome process to collect 24-hour urine protein. So we go for spot albumin creatinine ratio, and then in resource limited setting, one can go for urine reflex also. So this is one of the most important tests. But like in previous discussion where that we have, every test should be taken in consideration with the clinical case scenario, and therefore this also test has got lots of fallacies, and therefore should be repeated at least over 3 to 6 months. And during this 3 to 6 months, if there are 2 or more values which are showing macroalbuminuria or microalbuminuria, then only we should be labeling that this is an abnormal, because increased albumin excretion can be seen in many short illnesses like fever, like with exercise, even orthostatic hyperproteinuria is well-known phenomenon. So the interpretation is again has to be quite, again, because of so many values which are used, 24-hour urinary protein, then it can be managed, it can be mentioned as mg per 24 hour, it can be mentioned as micrograms per minute, similarly milligrams per minute. So there are so many values which are there, but one should remember that 24-hour urinary excretion of less than 30 milligram is normal, or less A1, what is defined by KDIGO. Between 30 to 300 is A2, moderately increased, and severely increased is more than 300. What is this will be microalbuminuria, this is will be the macroalbuminuria according to the previous classifications. When you take on spot urine creatinine ratio less than 30 milligram per gram, which is commonly reported, is taken to the A1, between 30 to 300 is taken to the A2, and more than 300 is taken to the macroalbuminuria. Then obviously there is serum creatinine like HbA1c, which has got so many different interpretations. Serum creatinine was also measured by something about 40 different diagnostic modalities, but now it has been standardized, and most of the labs now uses standardized creatinine, which can be traced to IDMSA standard and can be used to define eGFR, estimated GFR, by various formula. The most common formula being used is CKD-EPI formula. So when to screen? So we have that, we know the disease, we know the natural history of the disease, then of the diabetic kidney disease, and we know what are the tools that we have to diagnose this diabetic kidney disease. So next some screening, and most of the guidelines suggest that type 1 diabetes should be screened after 5 years from the onset. And of course, there has to be clinical judgment, particularly if uncontrolled, should be screened earlier. And from at the time of diagnosis itself, it should be screened in type 2 diabetes. So diagnosis, for the most of the time, diabetic kidney disease can be diagnosed if we have a history of diabetes, and if there is a macroalbuminuria is present, or if there is microalbuminuria is present in presence of retinopathy. So for this diagnosis, usually kidney biopsy is not required if you have if your clinical features are matching with the natural history of diabetes. And as I said, different terminologies are used. So most common, even diabetic kidney disease, many people will not like to use this word, but they will in fact say it is chronic kidney disease, and it can be classified according to GFR as well as according to albuminuria in these patients, A1, A2, A3, and G1 to G5. So why it is very important to diagnose diabetic kidney disease in patients with diabetes is because of this. So about 2% per year will proceed from no nephropathy to microalbuminuria, 2.5% will proceed to macroalbuminuria, and about 2.3% every year will proceed to renal disorders requiring renal transplantation. So huge number when you take off this. And more important than this will be this many patients will proceed to death because of cardiovascular diseases rather than proceeding to end-stage renal disease. So when you have a macroalbuminuria, only 2.3% will go towards end-stage renal disease and renal replacement therapy, but 4.6% will go towards cardiovascular mortality. So prevention of cardiovascular mortality is probably more important in this patient. Now, now having said that, we have the diagnostic modalities, we have the natural history. Let us see few cases whether this could be diabetic kidney disease or not. So let us start with this patient, a 65-year-old male with diabetes for almost about 25 years, and he has retinopathy. Now he has GFR, which was estimated for over a period of prolonged period of 5 years, and we can see the GFR has declined from 66 to 10, and the albuminuria has increased from 59 to ACR has increased to 340. So this is a classical case scenario of diabetic nephropathy. You can see the GFR has been falling steadily as it should be expected. And this is the importance of knowing creatinine value and GFR value in past also. If the patient presents to you at this point of time, if you can plot this chart, if you have the creatinine of the patient in the past, then probably you can say with sufficient evidence that this is nothing but diabetic kidney disease. So he may have diabetic kidney disease. He has both retinopathy and albuminuria, and decline in GFR is over a period of time and traditionally following the natural course of the disease. Similarly, a young woman now with a diabetes for just 9 years, but again having retinopathy, and the UACR in this patient, you can see over a period of 2 years has increased from this to this. The GFR has declined from 57 to 38, almost about 20 ml decline over a period of 2 years. Again, fitting typically into diabetic nephropathy. So she may have diabetic nephropathy. Again, she has retinopathy and albuminuria, and there is a decline which is usually acceptable with diabetic nephropathy. Now, a different case scenario. Now we have a 57-year-old female with a good control of glycemic control, has now presented with NSRK just for 15 days. So we have pedal edema, the blood pressure is again normal. So most of the diabetic nephropathy will have some sort of hypertension. So particularly when they proceed towards macroalbuminuria, but here the patient is having normal blood pressure, a fundus is normal. And then we have the urine investigations, which are suggestive of typically of nephrotic syndrome, a high level of urinary protein excretion, 4+ proteinuria. Creatinine has gone up within 15 days, it is 1.9. Triglycerides are sky high, kidney sizes are normal. Obviously, it suggests that it is something else than from the diabetic disease. Here, CH3, C4 were normal. We did a kidney biopsy in this patient, and then found out that there is the glomerular basement membranes are thickened, but the mesenterium is not expanded. So when we say mesenterium is not expanded, that probably it is not to the tune of the diabetic nephropathy stage 2, but mesenterium basement membrane thickening is there. On further immunohistochemistry, it was found that this patient has positivity for anti-PLAR, and her immunofluorescence microscopy was positive for IgG and IgG4, typically correlating into membranous nephropathy. So this patient, although has diabetes, this patient turned out to be, her renal problem was because of membranous nephropathy, which was very well taken care of with Montessori regime. The patient entered remission, and she is now following in our clinic with normal renal functions. A little bit more trickier case scenario. So here we have a 52-year-old male. It's already a known case of prolonged diabetes, 10 years of diabetes, but he has presented with back pain and again edema for just 15 days duration. So recent onset of edema. Examination is has general examination with pallor and some sort of symptoms suggestive of peripheral neuropathy. Fundus that did show NPDR, that is non-proliferative diabetic retinopathy in this patient. Looking into this, one would like to think that her kidney problems may be because of diabetes only, but then there are certain clues which points out that it is not like hemoglobin is very low, serum creatinine is high. More than that, the serum albumin is 2.8, but in 24-hour protein excretion was 3.3 gram. Incidentally, the protein was not detected in routine microscopic examination. Now, this is one such scenario which points that there is something odd happening with this patient. So therefore, we planned a kidney biopsy, and the kidney biopsy shows this fractured cast in the tubules, and typical and with lots of tubular interstitial inflammation, quite suggestive of myeloma involvement in the kidney, and which was further documented with the serum protein electrophoresis. Urine Benjohn's protein was positive. The serum free blood count assay was restricted to lambda. In fact, kidney biopsy, immunofluorescence biopsy showed lambda restrictions in these casts, and bone marrow shows 20% of plasma cells. So this patient had multiple myeloma. The patient is currently taking anti-myeloma therapy and is on thrice weekly hemodialysis. So if you look into the if you just pass it by this patient, you could have easily missed such an important diagnosis which have therapeutic intervention implications. So kidney biopsy again has helped this patient to reach to a conclusive diagnosis, and is currently managed with anti-myeloma therapy and dialysis. Another important case scenario, particularly for region like us, A 50-year-old male resident from Balangir, Odisha, has presented with weakness of 6 months and decreased appetite for 6 months. In the local hospital, he was evaluated and his HbA1c was found to be 7.5. He was started on glimepiride. His serum creatinine at the presentation itself was 3, a GFR of 22. Blood pressure was essentially normal. And then we have the fundus. There is no evidence of neither hypertension nor diabetic changes. So a patient with recently detected diabetes, a farmer, a male patient, then again hemoglobin was 8.7, which can be explained with CKD. You have a sodium which is on the lower side, a potassium on the lower side, despite having low GFR. A creatinine of 4.2 at presentation to our hospital. 24-hour urine protein was just 30, and the kidney sizes were very small, 7.6 to 7.2. So these are the certain things which says that this patient has CKD, but probably it's not due to diabetes. So probably this is chronic tubular interstitial nephritis. And in this belt, particularly the belt of bordering Chhattisgarh and Odisha, this chronic kidney disease for unknown origin, where the cause is not known, is quite prevalent. And many of these patients may in fact have diabetes. So where again, the differentiation between diabetes and non-diabetes is very difficult, but has to be kept in mind. So as of now, the definition of chronic kidney disease of unknown origin exclude patients who are having diabetes. But again, these sort of presentations are quite common, and one should really, the research should focus on whether the patient suffering from this sort of kidney disease has anything to do with diabetes, or whether diabetes can in fact lead to progression of this sort of kidney disease. So having seen multiple case scenarios, different case scenarios, so one should know when to suspect non-diabetic kidney disease in a patient with diabetes. So absence of retinopathy, low rapidly decreasing GFR, rapidly increasing proteinuria, refractory hypertension. Again, this refractory hypertension is particularly common where you have to suspect vascular causes of the chronic kidney disease, again associated with diabetes, but not diabetic kidney disease. Presence of active urinary sediment. So most of the time, the diabetes usually present with bland sediment. Some amount of RBC may be seen, but macroscopic mituria is not a feature of diabetes, and it should prompt towards investigation of other causes. Signs and symptoms of other diseases, like our patient, the patient number 5th, case scenario 5th, has severe backache, and which is a telltale sign of which is one of the symptoms of multiple myeloma involving the spine. So should not be ignored. A 30% reduction in GFR after the start of ACE inhibitors again may point towards vascular hypertension, so it has to be kept in mind. Asymmetric kidneys should prompt towards another cause of diabetes disease, other cause of kidney disease. And then onset. If the onset of diabetes is, if the onset of CKD is before diabetes, one should consider non-diabetic kidney diseases. Commonly seen are genetic diseases like autosomal dominant polycystic kidney disease. At the time of diagnosis, if you have onset of CKD, probably it is non-diabetic kidney disease, but again, it's not proved with type 2 diabetes. After the diagnosis of diabetes, if the many years have passed by, then probably it is diabetic kidney disease. But one has to be very sure, one has to keep in mind of unmasking of underlying chronic kidney disease because of diabetes. So you may have chronic kidney disease underlying, but when you develop diabetes, because of the filtration pressure of high glucose, which is filtered through the kidney, your underlying chronic kidney disease, where you may have creatinine in the normal range, may actually be unmasked, like what has happened in the patient number 6 probably. So why it is important to consider non-diabetic kidney disease? Because we very well know that diabetic kidney disease is progressive, has relentless progression, decline in GFR, and as of now we have very limited therapeutic options which are available. Obviously, with the modern, with now the researchers have given us little bit more tool. So we have now the ACE inhibitors, ARBs, to prevent the progression of this kidney disease. Other drugs are also like SGLT2 inhibitors have come up. So still diagnosing DKD is important because now we have certain therapeutic options. However, diabetic kidney disease is not the only renal abnormality found in diabetes. There is a significant overlap of clinical finding between diabetes and other renal condition, and very often we attribute kidney disease to diabetes itself and missing the chances of identifying a treatable disease. So again, a whole gamut of non-diabetic kidney disease can be seen, and these are some of the list of the non-diabetic kidney disease which can be seen. It can be glomerular disease, it can be tubular interstitial disease, it can be urinary tract infection. infections. It can be because of non-diabetic kidney disease superimposed on diabetic nephropathy. So there are lots of the kidney diseases which we have to keep in mind when we deal with a patient with type 2 diabetes and kidney disease. How common is it? It's so if you go through the biopsy literatures, Western literatures do point out that about 40% of the patients have non-diabetic kidney disease. So it is common. It is not that uncommon. Even Indian data suggests that most of the data suggests that in fact up to 50% of the patients, biopsied patients may have non-diabetic kidney disease. So what are the indications of the kidney biopsy? So again, when you are the similar thing that we have suspected for non-diabetic kidney disease, they form an indication for kidney biopsy. If retinopathy is not present, probably you would like to do a kidney biopsy in this patient. If the onset of proteinuria has been sudden, so like if the presentation is with nephrotic syndrome, like 15 days, 1 month, like this is there, then probably you would like to do a biopsy. If the evolution of disease is atypical without transition through usual stages, particularly the development of nephrotic syndrome, is an indication for dialysis. If there is microscopic hematuria, should look for some sort of glomerulonephritis, and therefore biopsy may be indicated. And if the decline in GFR is exceptionally rapid, so diabetes by natural history, the decline in GFR is between 5 to 10 ml per year. If it is very rapid, it can lead go to a diagnosis of RPRF and AKI, and where biopsy is required. What are the common findings in biopsy series? It depends upon what are the indications that for which you are doing biopsy and where are you. In countries like US, the FSGS is the most common finding in biopsy series. In Korea, IgA nephropathy is more common. In Indian case scenario, it is more common will be your post-infectious glomerulonephritis and lung disease. Again, treatable conditions. So should be always be identified. Again, the similar thing. So again, the common causes of non-diabetic kidney disease, you can see very well the common causes in India are most time is post-infectious or allergic interstitial nephritis. These are some of the common case scenarios which we can see. Now, what effect this non-diabetic kidney disease have on diabetic kidney disease progression? So this the progression depends upon your diabetes, what type of non-diabetic kidney disease you have, and your age also. So if you do not have any non-diabetic kidney disease, you just have diabetic kidney disease, the progression, if you are young, very young, like in type 1 diabetes, you still require a lot of time to develop diabetic kidney disease. But if you are old, particularly type 2 diabetes, you require a little bit of more time. Again, with old, as the age goes up, your GFR declines naturally, so diabetes is going to affect more, and therefore you have to develop the progression will be much more faster. There are slow variant of non-diabetic kidney disease like IgA nephropathy and all, which can progress very slow. So their effect will be little bit lesser. But there are certain diseases like FSGS and all, they can progress very rapidly, and therefore, if you have diabetes and a non-diabetic kidney disease, you can have a very rapid progression to CKD and will require replacement therapy. So coming to the take-home message, DKD is diabetic kidney disease is common cause of renal dysfunction in patients with diabetes, but non-diabetic kidney diseases are not uncommon. Therefore, one should consider the natural history of each disease which you are considering in a patient, and do kidney biopsy whenever it is indicated, because it can give you a wealth of information. Non-diabetic kidney disease can modify CKD progression that we have all seen. With this, I finish my talk. Thank you.
Thank you, Vinay sir. Really, it was a very informative talk, especially with those practical case scenarios. Even if diabetes is multidimensional, now it is really a time to look beyond diabetes, especially in a belt where other causes can also be because of which can lead to this kidney disease. Thank you again. May we move to next session? I would like to.
Yes.
Got a question.
I'm Dr. Kalpana Das, endocrinologist. So, should all microalbuminuria patient undergo the 24 hours urinary estimation?
There is a very good correlation between albumin creatinine ratio, spot albumin creatinine ratio, and 24-hour urine albumin estimation, albumin excretion. And obviously, 24-hour urine collection is not very precise. To be said that it is cumbersome. Most of the time, the patient will miss one or two times the collection, and then that will affect your value. So even spot urinary creatinine ratio is a very good modality for screening purpose at least.
That means all patient of macroalbuminuria, they should undergo the 24 hours urinary
Ma'am,
estimation.
for diagnostic purpose, actually,
No, it's
either
not
of
for
these-
diagnostic.
Yes.
We don't know how much protein the patient is.
Ma'am, that is not going to actually alter the management. Once you have a diagnosis of your macroalbuminuria, you now have to start certain antiproteinuric drugs, the commonest being ARBs, and you can easily monitor them with spot albumin creatinine ratio in follow-up also.
Okay.
Thank you,
Second
ma'am.
question, any microalbuminuria without retinopathy, that means you suspect it could be because of the non-diabetic kidney disease. So should all such patients should undergo kidney biopsy?
In patient with type 1 diabetes, yes, probably if you have type without retinopathy, we should still consider some sort of other kidney disease. But with type 2 diabetes, probably not, because in type 2 diabetes, it is very well known that even without retinopathy, you may have diabetic kidney disease.
Okay, thank you.
Thank you. Thank you, Dr. Vinay Rathod. Since we are short of time, thanks a lot. This is a last lecture of this session. Dr. Pranita will deliver upon diabetes management in COVID era. As we know that in COVID era, a lot of patients became diabetic due to various factors. COVID virus itself caused diabetes, probably, and steroid use, rampant steroid use in various centers, that also caused diabetes. And Dr. Pranita will speak on this topic of diabetes management, how we did it in COVID era. Still, we are not over. Still, there are cases of COVID are coming. Dr. Pranita, please.
Sorry for the interruption. I just want to announce that our lunch is ready, and meanwhile the session will continue.
Very good afternoon to respected directors, sir, our chairpersons, and all our delegates. First of all, I would like to thank Dr. Ghosh for giving me the opportunity to speak on this topic, which is of global health importance. So COVID, we are still living in COVID-19 pandemic era, and we know that both COVID-19 and diabetes are interrelated to each other. Diabetes can cause severe COVID-19 infections, and this COVID-19 can cause this diabetes more severe. So it is important. So initially it started from this COVID-19 was caused by SARS-CoV-2, and it started from Wuhan, China, and it spread all over India. From the first wave, we had the second wave, and we have seen that how it affected the patients of COVID. In cases of diabetes, so severe infections were there, especially in the second wave. So how it affected, mostly these patients were having the rampant use of steroids, and these patients were mostly having uncontrolled hyperglycemia due to lockdown because of the disrupted access to diabetic care. So it was one of the most important comorbidities which was seen during the severe COVID-19 patients, and it is diabetes patients have increased risk of severe complications, including this ARDS. They are more prone for ventilatory support, and they are more prone for multi-organ failure also. And depending upon the global region, you see these 20 to 50% of patients in COVID-19 pandemic, they had diabetes. And the risk of having worse outcomes is Similar for people with type 1 diabetes and type 2 diabetes, which has recently issued by the statement by American Diabetes Association. You can see this diabetes can promote severe progression in COVID-19. So how it promotes, there are multi-factors are there, which can promote the severe progression. And there are several data from all over the world, like in China, Italy, England, and you can see here, these are the data from China, where you can see these are the data which was studied in around 1,099 patients. And severity was, severe COVID-19 was found among 173 patients, in which it was 16.2% were diabetics. And these non-severe patients, the diabetes prevalence were only 6.7%. So it is related with the diabetes is related with the severe COVID infections. And if you see this composite endpoints, this diabetes patients are more risk for severe infections, more mortality, and more complications. So if you see the survival rate in COVID-19 patients with diabetes, those patients of diabetes which have controlled blood sugar, they have more better survival than the patients who were uncontrolled blood sugar. And if you see the death summary, this is a data from in our country of Tamil Nadu. You can see these patients, the number of these comorbidities were associated in the 82%, and among that, diabetes and hypertension were present in the 33% of the cases, and only diabetes was associated with in the 24% of the cases. So definitely this diabetes is it is having interplay with the COVID-19 patient and causing more severe diseases in this COVID-19 patients. So there are multiple theories which can postulate this mechanism, how this diabetes can accentuate COVID-19 and cause severe infections. So there are it has been seen that there are high levels of inflammatory markers like IL-1, IL-6, and tumor necrosis factor alpha in the people with diabetes. So this coronavirus likely to activate this toll receptor 3 receptors and toll receptor 4 receptors, leading to IL-6 dominated cytokine storms. And these IL-6, we have seen already that these are associated with more mortality in COVID-19 patients. So overactivation of this toll-3 receptors signaling in diabetes may lead to severe diseases and death. So the diabetes is associated with so many comorbidities like hypertension, dyslipidemia, hypertension, and these all together can cause this increased inflammation, and there will be hyperimmune response due to this increased advanced glycation end products, this advanced glycemia, and upregulation of this ACE2 receptors, and ultimately leading to severity of COVID-19 patients, severity of COVID-19 in diabetic patients. So how this COVID-19 is accentuated, can accentuate diabetes? There are several mechanisms, and this angiotensin converting enzyme 2 receptor is very important in this. And it has this is basically the receptor of entry in the human cells of the SARS coronavirus. And this expression, this ACE2 expression is seen in the pancreatic tissue also, which can cause new onset hyperglycemia in non-diabetic patients. So this coronavirus is able to efficiently use this ACE2 receptor and cause viral replication in an adverse way. So why this is association? It has been seen that this coronavirus and the renin-angiotensin aldosterone system has an association, and which leads to severe COVID-19 in patients of diabetes and other comorbidities patients like diabetes and hypertension, those who are associated with that. So there are several factors and several mechanisms which are upregulated in diabetic patients. And if you see, when patient is infected with coronavirus, what happens? There will be increase in inflammatory cytokines and polysaccharides, which can cause lung fibrosis and acute lung damage and ARDS. And there is modulation of this natural killer cells, which can cause increased vascular permeability and which can ultimately leads to acute lung damage and ARDS. And after this infection of this coronavirus in a diabetic patient, there is increased reactive oxygen species and IL-6 also. And there is activation of this renin-angiotensin axis system, which can ultimately increase in insulin resistance, leading to hyperglycemia, vascular endothelial damage, and all this will contribute to this cardiovascular events and will cause thromboembolism and DIC, and ultimately there will be cardiovascular and all causes of mortality will increase. And after this infection, this coronavirus infection in diabetic patient, it has been seen that this fibrinogen level will increase and there will be increase in D-dimer level, which will ultimately cause increase in blood viscosity and ultimately leading to cardiovascular mortality and morbidity. So some clinical features are also exaggerated and accentuated in these patients after infection with coronavirus, like metabolic rate is increased, leading to tissue hypoxia and ultimately leading to interstitial lung damage and ARDS. And after infection, it has been seen that there is dysregulation of glucose metabolism and aggravation of inflammation and immune modulation, ultimately leading to increased glucotoxicity and endothelial damage. And there is increased reactive oxygen species leading to oxidative stress, and cytokine production will be increased like IL-1 and IL-6, ultimately leading to increased thromboembolic risk and damage to vital organs, ultimately leading to deep vein thrombosis, increased incidence of pulmonary embolism and multi-organ dysfunction in this patient, which will ultimately increase the severity of this COVID-19 patient and leading to increase in mortality. So if we see this coronavirus mortality was higher in patients with hyperglycemia in different studies we have already seen. And if it has been seen that diabetes patient, if they are having poor control of blood sugar, they have a poor survival rate and increased mortality rate. And if the blood sugar is controlled well, patient can survive well. It is around 98.9% patient can survive. So it is very important so that we all we have seen first wave, second wave, and we hope that the third wave should not come. And I hope and pray to God that it should not come. So it is still important, the management of diabetes in COVID-19, what are the changes we need to be made in these patients, we should know. So there are different clinical scenarios. Once a patient of diabetes gets COVID-19 infection, it has been already seen that they know all from the these patients are having more prone for severe infections. They become stressful and anxious and depressed. They can have poor sleep. They can have they can have so depressed that they will not exercise, or they will over exercise, or they will eat too much, or they can miss meal because of the anosmia and loss of taste. And there can be change in diet, or there can be change in regimen, or patient can have poor compliance to medicines. And because of lockdown, patient can have difficulty in access to diabetic healthcare persons. And so because of infrequent visits, they can have hyperglycemia, or they can have delayed emergency visits because of the lack of bed and all that. So it is very important that if patient is coming to our outpatient care, what we will do. So it is first and foremost, it is important that euglycemia should be restored as possible as early. And if it is uncontrolled, it should be the drugs, whatever they are taking, they have to continue those drugs, whether it is a OHA or insulin, and it has to be titrated if it is uncontrolled, and euglycemia should be restored. So how to prevention? There should be prevention of infection in diabetes by sensitizing the patients with diabetes for the importance of optimal metabolic control. It is very important. And whatever the drugs they are taking, they have to continue. And there should be caution with premature discontinuation of established therapy. And in the period of lockdown, this telemedicine has helped us a lot. And they should, if there is a problem in accessing diabetes health care persons, so they can utilize the telemedicine and connected health model if possible to maintain their maximum self-containment if they are infected. So those patients who are admitted or in ICUs, how to see, we have to monitor for new onset diabetes. So So because we have seen in the second wave, we have used steroids rampantly. So there was steroid-induced hyperglycemia also. So it caused new onset hyperglycemia in patients who have never diabetes, or the pre-existing diabetic patient have worsened their blood sugar level. So we have to monitor this new onset diabetes in infected patients and management of these patients who are already of diabetes. So our general advice is that whatever medicine they are taking, they have to continue, and insulin treatment should never be stopped if they are taking from the previously. And we have to test blood glucose as frequent as possible, like every 4 hours, or we have to keep track of the results. We have to take we have to take plenty of fluids so that we should not be dehydrated, and try to eat as normal people. And this weight loss can be there, so we have to weigh the patient every day, because losing weight while eating normally is a sign of hyperglycemia. So check the temperature every morning and evening, and even there is a fever, this can be a sign of infection in diabetic patients. So our target should be those patients who are mild to moderate or non-elderly COVID-19 patient. We can stick to strict high control target, but those patients who are elderly or those who have having steroid, we have to set up a low or medium control target. And for admitted patients, severe and critically ill patients, we have to set low control target. Those who are having comorbidities also, we have to set up a low control target. So our target is in this mildly ill patient is to fasting blood sugar should be below less than 110, and 2-hour postprandial glucose should be less than 140. And we have to maintain strict glycemic control in mildly ill patients. But those patients who are moderately ill, we can maintain this fasting blood pressure, fasting plasma glucose up to 140, and the 2-hour postprandial glucose up to 180. And if they are moderately ill, we can add subcutaneous insulin delivery system. And those patients who are severe, critically ill patients, those patients we maintain the fasting blood glucose slightly towards higher side, 140 to 180, and the postprandial glucose should be 140 to 250, and they should be kept on IV insulin infusion. So those patients who are on oral anti-diabetic agents at admission, they should continue their own oral anti-diabetic agents. If blood sugars are controlled, like fasting meal, pre-meal should be less than 140, and post-meal should be less than 180. And if patient is conscious, oriented, has good oral acceptance, and there are mild COVID symptoms, and KFT, LFT are normal, we should continue the existing, whatever he is taking, we will have to continue. And if patient does not fulfill this criteria, like this pre-meal sugar is high, post-meal sugar is high, and patient is moderate to severe cases, we have to start on the basal bolus insulin regimen or the IV insulin infusion, depending upon his blood sugar levels. So talking about the OHA, which we can give in this COVID-19 patients, this metformin, there is risk of dehydration and lactic acid. So there is no evidence to discontinue it. We have to continue it, but we have to be cautious of lactic acidosis and dehydration. It has got anti-proliferative and immunomodulatory effects in COVID-19, so we should continue it. And it has been seen that there is decreased mortality in lower respiratory tract infection. And during illness, patient is sick and the severe COVID-19 infection is there, the renal function should be carefully monitored because of the high risk of acute and chronic kidney disease. So thiazolidine it has been seen that it causes upregulation of the angiotensin converting enzyme 2 receptors. So we should avoid. It has got increased risk of pneumonia in diabetic patient. So we should avoid because of the risk of fluid retention also. And this SGLT2 inhibitors, it has been seen that it can cause euglycemic ketoacidosis. So better to avoid this SGLT2 inhibitors. DPP4 inhibitors we can continue because there is no as such direct evidence of increased upper respiratory infections or the increased risk of lower respiratory infections. So we should continue this DPP4 inhibitors. So whom to start on oral anti-diabetic drugs? So we'll prescribe oral glucose lowering drugs if there is no contraindications for oral glucose lowering agents and their symptoms are mild And there is mild hyperglycemia. Pre-meal blood sugar is less than 180 and post-meal blood sugar is less than 250. So DPP-4 inhibitors are relatively safe. We can continue on this so that the vildagliptin, teneligliptin, sitagliptin, and linagliptin we can continue. Only saxagliptin we can avoid. And metformin, we should be cautious. We should continue, but we should be cautious of lactic acidosis. And sulfonylurea, there is risk of hypoglycemia, so we have to be cautious when we are giving this sulfonylurea. And we should stop these drugs like SGLT2 inhibitors because of euglycemic ketoacidosis and 5-litagen because of chances of upregulation of this AC2 receptors and increased incidence of pneumonia and fluid retention causing this 5-litagen. So if patient is already on oral anti-diabetic agents and blood glucose levels are uncontrolled, what we will do? If pre-blood sugar are 140 to 180 and post-meal blood sugar value is 180 to 250, we'll titrate the drugs. And this oral anti-diabetic agents will optimize and will try to achieve euglycemia. If pre-meal blood sugar value is more than 180 and post-meal blood sugar value is more than 250, we'll start basal bolus insulin regimen. And if fasting blood glucose is more than 140 and post-meal increment in blood glucose level is normal, then we can add just basal insulin or injection NPH insulin bedtime 2 hours after dinner. So newly diagnosed diabetes at admission, we'll have to look for the blood sugar level. If it is 150 to pre-meal level, it is 150 to 180 or post-meal, it is 200 to 250. We will titrate the drugs. If blood sugar level at admission, pre-meal is more than 80 and post-meal is more than 250, we'll start on insulin and will not initiate drugs, which I have already discussed, like 5-litagen and SGLT2 inhibitors. And in moderate to severe COVID-19 infections, we will stop 5-litagen and SGLT2 inhibitors and will initiate insulin for patients who are newly detected with diabetes. And how we will start? We will start with the 0.4 unit per kg per day. If age is more than 65 years, there is no nephropathy or liver disease. If it is there, if patient is elderly, patient is having nephropathy, patient is having liver disease, we'll start with the half of the dose, that is 2 unit per kg per day. And the total daily doses will divide into 4 doses, 25% of each. And 3 doses are for bolus insulin, which is the regular insulin, and 1 dose for basal insulin. So how to switch to basal bolus insulin regimen from insulin infusion? So those patients who are severely ill, those who are patients who are having uncontrolled blood sugar or DKA patient, which can because of hyperglycemia and steroid-related patient can present to DKA also. So we should not switch from insulin infusion to basal bolus regimen until blood glucose levels are controlled on insulin infusion, or patient is orally accepting or on RT feed, and patient is hemodynamically stable. Insulin infusion has to be overlapped with basal bolus insulin regimen for at least 60 to 120 minutes before stopping, and do not stop insulin infusion abruptly. Otherwise, patient will again have uncontrolled hyperglycemia and there will be more complications. So we have to prescribe insulin on those patients if there are contraindications of oral glucose lowering agents, or there is moderate to severe COVID-19 patient, or there is moderate hyperglycemia like fasting blood glucose is more than 180 and pre-meal, post-meal blood sugar is more than 250 milligram per dl. So this basal bolus insulin regimen will start with 0.4 unit per kg, and in the comorbidities like CKD or liver disease or elderly patient, will start with the lower dose, and again we'll switch over the basal bolus insulin, and we'll divide it into 4 doses, and we'll target the blood sugar level. Pre-meal should be less than 140 and post-meal should be less than 180. We'll prefer IV insulin in cases where there are uncontrolled hyperglycemia. Despite using the basal bolus insulin, if the patient is DKA, patient is sick, if patient is not taking orally, we'll have to start with the RT feeding. And if there is erratic diet, we'll have to give insulin infusion. If there is emergencies like HHS or DK or other emergency surgery, or in cases of labor, we'll prefer to give this IV insulin. And we will have to initiate this IV insulin at the doses of 0.05 to 0.1 unit per kg body weight. And we'll titrate the infusion rate, and we'll see the hourly blood sugar, which should be at least 50 to 75. It should not be more than 75, or it should not be less than 75. We'll have to monitor it every 1 to 2 hourly. Our target blood glucose between 140 to 220 milligram per DL, we have to achieve it. So what are the, if patient is having no previous diabetes, the patient who are having steroid induced hyperglycemia, those patients who are never previously diabetes, will have to start insulin on the 0.2 unit per kg per day. We'll prefer NPH 0.1 unit per kg in the morning, and regular insulin 0.1 unit per kg before lunch. And already the patient who are already on 1 or 2 oral hypoglycemic agents, for diabetic, we'll start with the 0.4 unit per kg, in which NPH will give 0.1 unit per kg in the BD dose, and regular insulin 0.1 unit per kg before breakfast, before lunch, and before dinner. And those patients who are already on more than 2 oral glucose lowering agents for diabetes, will start with the higher dose, that is 0.6 unit per kg, and we'll divide it into NPH and regular insulin. And each regular insulin before meal 8 hourly. And diabetes patients who are already on insulin 0.6 unit per kg will have to calculate the dose, and which is 1.2 into patient insulin dose unit per kg, and we'll give 50% of the NPH, and 2/3 in the morning and 1/3 in the evening, and 50% of regular insulin before each meal. So in the nutshell, those patients, what the OHA will prefer, all OHA patient who is already taking, the patient will continue except this thiazolidine dion, and this SGLT2 inhibitor will stop, and will continue other drugs, and will titrate to maintain euglycemia. And this is the nutshell what we have already discussed. So diabetes is it's an independent risk factor influencing this severity of the COVID-19 infection, and ultimately uncontrolled blood sugar will lead to mortality. So during this COVID-19 pandemic, control of blood sugar is very important, and judicious selection of oral anti-diabetics and insulin is in the core in the management. So we'll thank you for your patience listening. You must be hungry.
Thank you, doctor, for excellent deliberation, and you have a lot of experience during all this period of COVID to manage the patients of COVID. Newer and newer things will come, the data will come, and we will be wiser. Thank you.
Thank you, Madam and Sir, for the very informative session. Next, I request Dr. Asha to kindly felicitate Dr. Biplab Bandyopadhyay, Sir. I request Dr. Ankit to felicitate Dr. Ajit Kumar, Sir. Next, I would like to request Dr. Biplab Bandyopadhyay, Sir, to kindly felicitate Dr. Rohini, Madam. I request Dr. Biplab Bandyopadhyay, Sir, again to felicitate respected Dr. Vinay Rathore, Sir. And now I request Dr. Ajit Kumar sir to felicitate Dr. Pranita madam. Next we will proceed to the one of the most awaited session of the day, which is a debate on the topic fibrates should be used to address moderate hypertriglyceridemia in diabetes. To chair the session, I would like to call upon our very respected Dr. Kalpana Das Madam, who is the Chief Consultant Endocrinologist at the Apollo Hospital, Honorary Faculty for American Textile University, PHFI India. She has presented more than 200 papers at various national and international forums and is also associated with various diabetes education programs. Next, I invite our second chairperson, Dr. Pankaj Kanoj sir, who is the Assistant Professor, Department of General Medicine. He has published more than 15 publications in various national and international journals and has published 4 chapters in various national and international textbooks.
Into a debate, very interesting topic. As you know that the new guideline that reinforces the use of heart healthy lifestyle and the use of statin as the first and first line agent for primary and secondary prevention of atherosclerotic cardiovascular disease. However, looking beyond the statins, the role of lipid lowering agents, I mean to say lowering the hypertriglyceridemia, it is questionable if it can prevent the atherosclerotic disease or not. So we are going to have a debate on this issue. So we have with us Dr. Nishant Raizada, which is a speaker of national repute. So I'll be introducing him. His present appellation is he is the Associate Professor of Department of Endocrinology at UCMS and GTB Hospital, New Delhi. And total clinical and academic experience is, I think it should be more than 10. And previously, he also worked as Assistant Professor at AIIMS, New Delhi. And he has many honors and achievement to his credit, like Sudhir Rehan Memorial Award 2011, that is from MAMC, and Dr. MMS Ahuja Book Prize Award 2016 from AIIMS, and Deputy Executive Editor in the IJEM. Currently, he is there, and he has total 30 publication in the national and international journals to his credit. So at the end of this debate, I would request all the audience and those who are online, so please vote in favor of this debate and against the debate, so that we can conclude about the topic. So Dr. Nishant Raizada. In favor of
Favor.
In favor, Dr. Nishant Raizada.
So I will request Dr. Nishant Raizada to speak against the favor of this motion. The fibrates should be used to address the moderate hypertriglyceridemia in diabetes.
Thank you to respected chairpersons. I hope I'm audible and the slides are visible to you.
You are audible, sir, but slides, yes, your slides are also visible.
Thank you. So I will begin. So I'm speaking for the motion. So why are we having this debate? These are the recommendations regarding cardiovascular disease management by the American Diabetes Association in 2021. And if you notice out here, for moderate hypertriglyceridemia, they do not mention the use of fibrates or, for that matter, other medications. There is a brief mention of icosapent which can be used. And further in the text, it says that in large trial of patient with diabetes, fenofibrate failed to reduce overall cardiovascular outcome. And again, there is no benefit of statin plus fibrate combination therapy. Now, with this background, I'll present my arguments. First argument will be regarding the TG triglycerides and the risk of ASCVD. The second would be regarding the RCT evidence, and finally some new developments. So over the years, this is how the recommendations of various international bodies have emerged. In the initial few years, there was a recommendation to lower triglycerides to prevent ASCVD, but in the more recent years, this recommendation has become a very patchy one. And this is better illustrated with the help of this diagram. In the beginning, there was almost equal in clinical focus on triglycerides as well as LDL, but gradually, in the interest in LDL increased because of the developments regarding familial hypercholesterolemia and development of statins, whereas that on TGs began to reduce. And in fact, the interest in HDL came up, and it was found that because HDL high TG and low HDL coexist, it was felt that probably TG is a bystander and HDL actually is driving the process. So I'll present some studies in favor of triglycerides increasing the risk of ASCVD. Now, this is an old meta-analysis published in 2007 in Circulation. This was a large meta-analysis, nearly 262,000 participants. And if you see out here, they found the adjusted hazard odds ratio of 1.72 in favor of coronary heart disease with hypertriglyceridemia. More recently, in 2018, this is a study published from the Danish Patient Registry. They looked at 58,000 patients with nearly 8 years of follow-up. They were non-diabetic patients, of course. And they compared those with high TG with those with normal TG and those who were eligible for statin therapy based upon other risk factors. So the gray bar out here, which you see, are the people who were eligible for statin therapy because of high LDL or other cardiovascular risk factors, whereas the red bar is the people with high TG who were not eligible. Now, the incidence rate of major cardiovascular events in this high TG group was almost same as that of those who were considered eligible for statin therapy, whereas those with normal TG had nearly half that risk. Now, another question which is there is that if you are lowering LDL to normal, or the LDL is normal, still does TG increase the risk? So this is a study from the Kaiser Permanente Northern California cohort. They looked at 28,000 patients with diabetes who had normal cholesterol. So LDL cholesterol was less than 100 in all these patients. And if you look at the hazard ratio, if you've got high TG and low HDL, the hazard ratio is nearly 1.5. Even with the normal LDL, HDL and high TG, hazard ratio is still elevated. Now, as I said in the beginning, that there was a belief that probably HDL is the driver of the disease in case of hypertriglyceridemia, with triglyceride being a bystander. But as early as 2007, the Copenhagen City Heart Study showed that even if you adjust for age and HDL cholesterol, still the hazard ratio is significant for both MI, ischemic heart disease, and total death for patients with increased triglycerides. Furthermore, observational studies, you can say that there could have been some confounder or there could be some reverse causation. But now we have genetic studies. And in this particular study, they studied 185 single nucleotide polymorphisms, which are associated with hypertriglyceridemia. And although these polymorphisms are pleiotropic in the sense that they may also affect LDL and HDL levels, what they did, they statistically adjusted for the effect on LDL and HDL, and they found both unadjusted as well as adjusted TGs predicted increased risk of IHD, whereas the same was not true for HDL, in which case the risk became non-significant once you adjusted for LDL and TG. So these data clearly point that there is enough epidemiological as well as genetic data to show that TGs, independent of both HDL as well as LDL, increase the risk of cardiovascular disease. And furthermore, this is further proven by HDL elevation trials, which have all been done till now, including the niacin-based trials and the CTP inhibitors. None of them could show an improvement in CVD outcomes by increasing the HDL, again proving that HDL is the bystander and TG is probably the thing which is causing this increased risk. Now I'll move on to the RCT evidence. And this is the RCT which I showed in the initial slide, in which was quoted in the ADA recommendation, which said that fenofibrate did not significantly reduce the risk of primary outcome of coronary events. This is, of course, the field study published in 2005. But before you accept this study, you would like to ask the question that what percentage of people in this study had high TG? So this slide shows the baseline data of this field trial. And if you look closely, only 15% of the patients in this trial had a TG more than 200. Half of the patient had absolutely normal TG, and another 35% had TG was mildly high, that is between 150 to 200 milligram per DL. So it is not surprising that a drug which is designed to lower TG, if you use the drug in only 15% of the population and the remaining population has a normal or near normal TG, then not finding a significant result is hardly surprising. And furthermore, this is corroborated by the subgroup analysis of the field trial, in which if you look at the subgroup with a high TG, that is TG more than 200, this is TG more than 2.3, nearly almost TG more than 200. In this, there was a significantly lower hazard ratio, 0.77, and this was also even lower in those who had low TG with high TG with low HDL. This is an older study. This is benzafibrate infarct prevention study. Again, this study was done in patients with CBD and dyslipidemia, and they were given benzafibrate versus placebo. And over 6 years of follow-up, overall what the study found, there was no improvement in the infarction rates. But if you split the study into two parts, patients with TG less than 200, which is the upper graph, and more than 200, which is the lower graph, you see in high TG patients, clearly there was a reduction in the incidence of the primary endpoint. Similarly, we're going on to the Accord lipid trial. Here the question was, if we add fibrates to statin, will it give any incremental benefit? Total of 5,000 patients studied. Simvastatin was given to all, with fenofibrate given to one half and placebo to the other half. 5 years of follow-up. Overall, the result, there was no significant difference. 10.5% events in fenofibrate group and 11.2 in the placebo group. But again, most of the patients did not have hypertriglyceridemia. And when you look at the subgroup analysis, this is the group with central bars which have the high TG and low HDL. Here, the 17.3% incidence was there in the placebo and only 12.4 in the fenofibrate group. Clearly, a 31% reduction in the risk. Now, this is the accordion lipid study. This is a follow-up of the previous study. And at more than 10 years of follow-up, again, overall, there was no difference. But if you look at the fenofibrate group, in those who had high TG and low HDL, there was a significant difference, a 0.73 hazard ratio, which is significant. The benefits with fibrates in these trials has not been only ASCVD reduction, but also improvement in microvascular complication. In the Accord I study, the fenofibrate group had 6.5% progression of retinopathy, which was compared to 10.2 in the placebo group. And similar findings were also found in the FIELDS trial also. And in addition to that, even microalbuminuria and macroalbuminuria in the Accord study and albuminuria progression in the FIELDS study were all significant in favor of fenofibrates. So now I'll move on to some new developments. Essentially, this is pemafibrate. Pemafibrate is a selective PPR alpha agonist. And while older fibrates had several off-target effects, which may have reduced the CV benefits, pemafibrate has a beneficial effects on KFT, LFT, and inflammatory markers. At the same time, it retains its efficacy on the lipid profile. So pemafibrate has been proposed to have all these benefits. Many of them have been already proven in animal studies, and human studies are going underway. And this is the RCT which should really settle the question which we are addressing today. This is the prominent study, and this study is to be done in patients with diabetes. Inclusion criteria is hypertriglyceridemia, TG more than 200 and less than 500. 10,000 patients have been recruited, and results are expected in May 22. And hopefully we'll get an answer to this question once and for all. So to conclude my arguments, increased TG is clearly associated with increased CV risk. This has been shown in epidemiological study and as well as in genetic studies. And this increased risk is independent of LDL and HDL risks. Available RCTs have not specifically looked at diabetes with high triglyceridemia patients. But in all subgroup analysis, fibrates have clearly lowered the CV risk if the TG has been high. And additionally, they have also improved microvascular outcomes such as nephropathy and retinopathy. So finally, the lack of a proper RCT should not be a ground to deny a treatment with obvious benefits, especially when subgroup data clearly is showing that there is a risk reduction in ASCVD as well as improvement in microvascular complications. Thank you.
Thank you, sir, for wonderful talk. So first we will take the second speaker, then we will go for a debate. And if any questions are there, we will take that also. So can we have introduction slide for second speaker? So our second speaker, who will be against the notion, is Dr. Jaideep Khare.
Yes, sir.
Can we have
So-
introduction slide?
Okay,
Sir,
okay,
just
okay.
for a 1 minute, sir.
Okay, sorry.
Okay, sir is an associate professor in the People Medical College, Bhopal. So, sir, you can continue.
Not audible. Your mic is off. Sir, please unmute yourself.
Yeah, sorry. So good afternoon all, and I thank the organizing committee for having me here, and I will congratulate Dr. Nishant for presenting his session such a nice way that and doing the statistical sub-analysis that fibrate should be used for moderate hypertriglyceridemia. But I will say here a disclaimer that every patient is individual and has to be treated accordingly. But today I will be talking against the notion. He has presented his presentation in such a way that all of must have seen this movie, that in which the heroine presents the hero, the statin's actual hero, those who are proven fact that they reduces the cardiovascular risk and other factors also. So here, Sunil Grover is presented as a hero, which I will say the fibrates, and he has presented few studies that it helps in reducing the in lipid profile kidney function test. So Sunil Grover is a very good hero. He can be replaced by he can replace Amitabh Bachchan or any actors in the movies. And I will say starting with like this. So as we have already discussed here, that what is hypertriglyceridemia? It is very common condition, and it is defined when the fasting triglyceride levels is more than 150 or non-fasting more than 175. And if we have to treat, Dr. Nishant has already covered that it is an important risk factor for ASCVD. Now the question is whether we should give fibrates or not. So again, I will say that what are the causes of hypertriglyceridemia? Then there are several secondary causes of hypertriglyceridemia, like the lifestyle factors like alcohol, diet, decreased physical activity, smoking, medical conditions like uncontrolled diabetes, hypothyroidism, nephrotic syndrome, Cushing's, HIV, or drug induced. So for this, we'll be giving fibrates or we will be correcting these secondary causes. So the important thing is to correct these secondary causes. And if we have to classify according to the American Heart Association or the Endocrine Society of Endocrine Society, then the mild to moderate is considered if the triglyceride levels are between 150 to 500, or it is very high if it is more than 500. But for Endocrine Society, moderate is 200 to 99, and it is very high if it is more than 1000. So what do guidelines recommend? We know that he has already covered in his graph that earlier the LDL and TG levels were equally important. Now the TG came down, now was LDL is come. So again, I will say that if triglyceridemia is there, the target is to primarily treat the LDL cholesterol levels. Then secondary target is to treat non-HDLC and ApoB. And finally, if then also the ASCVD risk score is high, then only think of the triglycerides. So the guidelines emphasizes on this sequence. And why it is required to treat hypertriglyceridemia. Why? There is definitely increased risk of cardiovascular diseases, but if it is very high, then only there is risk of pancreatitis. Then it is generally seen if the TG levels is more than 1000. So it is very high. So I think that has to be treated. And according to the ACC guidelines 2021, and we should wait for the 2022 results which are going to come. But till now, these guidelines are the gold standards that we have to treat using statins. Then the triglyceride non-statin treatment along with the lifestyle intervention has to be used to prevent ASCVD in the patient, those who have hypertriglyceridemias. And here, if we have to look for what guidelines say, whatever the triglyceride levels are, first evaluate for the secondary causes, optimize diet and lifestyle interventions, implement guideline directed statin therapy and optimize the statin adherence, because in India still the patient will say that मैं 4 दिन खाता हूँ, 2 दिन खाता हूँ, नहीं खाता हूँ क्योंकि ये काम की गोली नहीं है, इससे क्योंकि immediately effect नहीं आने वाला. Glycemic control, we all know that in India the average HbA1c is approximately 8.7. So that has to be corrected first, and then monitor the adherence to the therapy. And still the fasting hypertriglyceridemia is high, then refer to the registered dietitian nutritionist. And then if again it is persistently on the higher side, then think of triglyceride risk-based pharmacotherapies. Here again the same thing is there, that we have to actually control the blood sugars, control the diet, and stop alcohol, start activities. And if still it is in the moderately high condition, then refer to the registered dietary nutrition. And if required, then again start the statins, intensify the statins. And again, on intensification of statins also, the SCVD risk is on the higher side. Then what has to be added? They consider for the eicosapentaenoic acid, which is an omega fatty acid. The guideline says of omega fatty acid. If fibrates are not there, if it is not available, then only go for the fibrates that I will be covering on the later slide. So if we have to look for the diabetic patients here, whether it is type 1 diabetic, if we have to look for the cardiovascular risk factors, the guidelines clearly say look for the LDL levels as the primary target. And if LDL is more than 70, start statin therapies and lipid lowering therapies. Whether type 2 diabetic, if they have the cardiovascular risk factors, chronic kidney disease of any stage, or diabetic retinopathy, yes, I agree with him that in ACCORD trial, they have clearly shown that diabetic retinopathy fibrates are beneficial. So it has to be used. So that's why I have told that every individual patient has to be treated accordingly. And here, what Endocrine Society says again, that they recommend adding eicosapentaenoic acid, ethyl ester, or the dose of 4 grams per day to reduce the risk of cardiovascular diseases, to control hypertriglyceridemia, not the fibrates. If the eicosapentaenoic acid is not available, then consider fibrates. And he has already covered this field study, and he has very nicely presented that sub-analysis if we will do that how the phenofibrates are important. So again, this was the another study which was published in the Journal of American College of Cardiology, which says that the fibrates as a monotherapy in diabetic patients has poorer outcome as compared to the statin. So if we have to add fibrates over statin, there are chances that there may be potential interaction also. And we know that myopathy is something which is very commonly. अपने इंडिया में हर किसी को हाथ पैर दर्द होता ही रहता है. And if we will have statins also can lead to myopathies. We will add fibrates, which will increase the cost of the polypharmacy and may increase the side effects. So I will say that until unless the triglyceride levels are very high, more than 1000 milligram per deciliter, fibrates should not be used. The secondary causes has to be ruled out first, and it has to be managed. And if it is persistently on the higher side, go for the lifestyle changes first. If again it is not getting control, add omega fatty acids. If it is not getting control, or we are not having the omega fatty acids, then go for the fibrates. It is like here, I will say again that Akshay Kumar is explaining the fibrates that you are little Hanuman, go jump and eat the sun. Thank you. Thanks a lot for patience hearing.
So may I request everyone to vote in favor or against? Everyone present here and those who are online. So you know the post poll. Yes, this is good.
So we have pre-poll and this post-poll data. So prior to the this session, out of 10 survey, 2 were in the favor and 8 were against the motion. And after this lecture, next post-poll. Okay, till that poll results come out, what we get is that whatever the cause is, first we have to treat the cause, what we have come from this two session, and the treatment should be individualized. So some patient like a case of acute pancreatitis, the treatment should be started. For the other cases where the patient could have started with a lifestyle modification, which can stick with the fat diets, that has to be started first, followed by the omega acids, and later on the fibrates can be started. Now the second thing, which was according this accord lipid trial, what was the confounding factor was the statin, because the statin also decreases this triglyceride level by 25 to 30% whenever it is used in a high dose. Regarding the benzafibrate study, the benzafibrate was never approved from the US FDA. It was used in the European Society, but it was never approved from the US FDA.
Yeah, I agree with you. But I have one question to both the speakers. If somebody is hypersensitive to atorvastatin, so because this is the first line agent, atorvastatin, we use it for primary and secondary prevention. But somebody is hypersensitive to atorvastatin, then how do you go?
Ma'am, difficult question here. And if the statins are on, the patient is sensitive, then we can use the saroglitazar, which is the newer molecule. It has both the alpha and beta agonist activity, and pitavastatin, which is water soluble, because all the statins, whether Atorva or Rosuva, are lipid soluble. Only the pitava doesn't increases the risk of diabetes, and it is water soluble. So I will try a risk to shift the statins or simvastatin. I will ask you only here. First, Dr. Nishant may present, and we will have your opinion regarding this, ma'am.
I am asking because I am hypersensitive to atorvastatin.
Okay, Nishant,
you
your
for the PSPK inhibitor. I'm looking for the PSPK inhibitor.
PSPK inhibitors, yes.
So Dr. Nishant, do you have any Indian data on this dyslipidemia?
No, sir, not regarding the topic which ma'am is asking. I think nothing's different about that. It's a very challenging thing which ma'am has put forward. Some of us try and use ezetimibe if it lowers the LDL to some extent, but the success with that has been limited. Saroglitazar, again, as sir has said, has been used, but again, data on saroglitazar has been a little patchy. So very sticky wicket, I'll say, when you're faced with this issue. But of course, if there is concurrent hypertriglyceridemia, then we can think of giving fibrates, and some people do tolerate it well.
So one practical question, how often we should ask this patient for the investigation? Like the patient of moderate to severe triglyceridemia, having a value of 500 to 1000, how often we should advise him to go for the investigation? Like some guidelines recommend that they should be tested 3 days on the basis of 3 days or weekly also. So what is your idea about this?
Sir, what I do in practice, if it is only marginally above 500, I start them on fibrates and then I let them come back after a month. But of course, if it is the range of closer to 1000, then I do a repeated 1 week. That is what I do. Afterwards, I do a 3 monthly. So that is what I am doing currently.
Very true. I will also go with Dr. Nishant here, because here in India, patient has to pay from his own pockets. If it is not more than 500 or the patient is not having the symptoms of pancreatitis, I ask them to go with fibrates or lifestyle modifications. And if we can ask them to come after a week or a month, and accordingly we can adjust the doses.
Patient coming with hyperlipidemia, I mean to say overall diabetes, dyslipidemia. So we start with atorvastatin, but if the triglyceride is moderately raised, shall we start with both of them, fibrates and the atorvastatin, especially in diabetic patients?
I will say here, Dr. Nishant.
Sir, please go ahead.
Yeah.
Sir, ma'am, here what we used to do, we always used to increase the dose of statins. And everyone here India wants to have
how much?
To maximum dose of 40 milligram of rosuvastatins, we used to give that thing. And in India here, everyone wants to have some multivitamins, taakat ki goli chahiye. So we add the omega fatty acids to them, and that also helps, ma'am. Thank you.
So one more question. Do we have a different strategy for OPD patient and IPD patient? Suppose a patient is admitted with a TG of 2000 and a patient is admitted and the other patient is on OPD basis. So do we have a different strategy?
Yes, sir. If the patient is having that high triglyceride levels, then the ideal is to go for the plasmapheresis. And if it is not available, then we can go with the insulin infusion also. If the patient is not diabetic, then dextrose plus insulin infusion also helps in reducing the triglyceride level immediately in IPD patients. And if the patient is having TG of more than 1,000, I will definitely recommend that patient to get admitted, because we have to explain them that you are at risk of pancreatitis and you should get admitted, get it slightly lower down, and then you may go ahead. Thank you, sir. Thank you, ma'am.
Thank you very much, both of you. You spoke very well. And finally, we should not use fibrates. That is the conclusion. But whenever there is risk of pancreatitis, acute pancreatitis, so we should start this treatment along with the statins.
Thank you, sir.
Thank you. Thank you, ma'am. Thank you, sir.
Thank you so much, ma'am.
I thanks my chairperson and speakers for this interesting session of debate. Now I request Dr. Rashi to felicitate Dr. Kalpana Das ma'am. I request Dr. Sanket to felicitate Dr. Pankaj Kanal, sir. I invite Dr. Antara to give the vote of thanks.
Thank you, Dr. Asha. On the behalf of the organizing team, it is my privilege to propose a vote of thanks on this occasion. First of all, I would like to thank the torchbearer of this event, our Honorable Director, Professor Nitin M. Nagarkar, sir, for leading and inspiring us in working towards the goal of conducting this CME. We are thankful for him for his huge support at all times, and we hope to receive his blessings for all our future endeavors. We are highly indebted to the patron of the CME, Professor Surya Prakash Dhaneria, sir, who due to some unavoidable circumstances not able to join us today. We thank him for lending a helping hand to us at all times. His valuable support has helped a lot in enriching this CME. I'd also like to thank our Associate Dean, sir, Dr. Alok Agarwal, sir. Without your kind presence, we would not have accomplished what we have dreamt of. Conducting the CME would not have been possible without the zealous supports of our advisor, Professor Vinay Pandit, sir, who has devoted lots of time and energy for this program. His humble presence and assistance have highly been encouraging for us. I'd also like to thank our guest speakers, Professor Abhiruchi Galhotra madam, Dr. Dukhabandhu Naik, sir, Dr. Nishant Rajada, sir, Dr. Ashu Rastogi, sir, Dr. Vinay Rathore, sir, Dr. Deep Datta, sir, Professor Sujoy Ghosh, sir, Dr. Jaideep Khare, sir, for not only sparing their invaluable time for us, but also for enlightening us with their commendable talk on their subjects. My heart goes out to thank our respected delegates for accepting our invitation and coming to the CME. No event can take place without a hardworking leader, and it was the dedication and enthusiasm of our leader, our organizing chairperson, Dr. Amritava Ghosh, sir, and our organizing secretary, Dr. Rohini madam, which made this event a huge success. Above and beyond, let's not forget the backbone of the CME, the core committee members, Dr. Shaba Siddiqui, sir, Dr. Pritam Vasnik, sir, Dr. Pranita madam, Dr. Pankaj Kanoje, sir, Dr. Jashaketan Meher, sir, Dr. Ajit Kumar, sir, who went an extra mile and made this CME possible. This vote of thanks would be largely incomplete without expressing my gratitude to the senior residents, Dr. Asha and Dr. Ankit, and also all the junior residents who have been working hard and carrying out all the allotted duties very diligently. Furthermore, let's have a special recognition for the nursing officers, the hospital attendants, and all the volunteers providing their help at the registration counter. Next, I would like to thank our organizer, Mr. Abhinash, and the technical staff operating the audiovisual system, Mr. Khalil, who worked hard and made sure that the CME went smoothly. I'd also like to thank our sponsors for the endless cooperation. I sincerely apologize if I missed out on somebody. Thank you again. And with this, I conclude this academic fest and request everyone to kindly join us for the lunch. Thank you.
I request Dr. Amrita Ghosh to please present a memento to Antara Sen.